అన్నా పర్మనెంట్ టాటూ వేయించుకున్నాను. అమ్మ పేరుది.
रात्रि सोल से काले जगद्धा रात्रि सोल से सारे अपडेट्स पाने के लिए बेल आइकन दबाइए।
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा शुभं कुरुत्वं कल्याणम् आरोग्यं शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रु या कुन्देन्दु
Check one, two. Check one, two. Check mic test. One, two. Check one, two. Check mic test. One, two. Check one, two. Check mic test. Check one, two. Check. Both. Check one, two. కెమెరా చెక్ చేసినావా?
शुभ्र या या
వాట్సాప్ నెంబర్ కరెక్టే కదా? సారీ. హలో. So we will start. Very good morning to all of you. I welcome you all to this interim meeting of Skull-Based Surgery Society of India. Yesterday we had a wonderful workshop with 4 cadavers. It is well attended and well appreciated by both the faculty as well as the delegates. So today's program, as we all know, the live operative surgery which we wanted to do could not be done because of NMC guidelines. So we have selected the eminent faculty across India to present their predominantly the surgical videos to get the feel of virtual operation theatre. I'm sure you will enjoy this academic feast. So as usual, the program will start with Ganesh Prarthana. I request all of you to please stand up for Ganesh Prarthana.
गजानन पद्मार्कं गजाननम् अहर्निशम् अनेकदन्तं भक्तानाम् एकदन्तम् उपास्महे
So the first speaker for this CME is Dr. Anil Kumar Sharma, who is the head of the Department of Neurosurgery in AIMS Raipur. I take pride in introducing him because he is my junior. I have seen him from first year to grow to consultant. He is doing fantastic work and he has been very active in all these academic activities. So he will be speaking on far lateral approach. Anil.
Thank you very much, sir. Can you connect it? Mic is on. What that is not coming. My greetings to all. I'll be speaking on far lateral approach. So as we all know, far lateral approach was initially developed by heroes in 1986 for the vertebral basilar junction and proximal pica aneurysm. And over the period of years, it has become workhorse for the lesions in and around foramen magnum. So foramen magnum lesions are intricating because of vicinity of critical neurovascular structures. These tumors are difficult to operate upon because of their distinctive location, their insidious, progressive, long duration of clinical course. Lesions are usually large enough by the time they are presenting, and the relative large size of the tumor during presentation. So there can be variety of indications for the far lateral approach. That can be lesion anterior to dentate ligament. That can be meningioma. Meningioma is most common intradural tumor in this location. There can be vertebrovascular junction aneurysm and proximal pica aneurysm. And there can be lesions like hemangioblastoma, chondrosarcoma, and so and so. So we know the anatomy of foramen magnum. I will not go into the details. So this is the classification based on location and in relation to vertebral artery of the foramen magnum meningiomas. And there can be variety of approaches to tackle these lesions. That can be posterior approach and lateral approach. And that approach is dictated by the location of the tumor, whether pathology is anterior to dentate ligament, posterior to dentate ligament. That lesion can be very well tackled by the if lesion is posterior to dentate ligament, that can be tackled by standard posterior approach. So this is far lateral approach. This is showing the approach is inferolateral extension of standard suboccipital approach, which includes suboccipital craniotomy, C1 amylaminectomy, and identification and localization of the extradural course and intradural course of vertebral artery, depending on the our need or and during surgery. So this is the position of the patient. That patient is typically positioned in 3/4 quarter prone position, and neck is in flexion and rotated to opposite side. For rotation, we need to take care. Rotation should not be more than 45 degree to compress the venous structures, and that can be very troublesome during surgery. And we can see the flap. Flap is horseshoe shaped flap, that but other variation can be curvilinear incision also, that also can be taken. I prefer to take horseshoe shape because it provides better orientation of midline structures during surgery. And we need not to dissect in muscle plane, we need not to dissect separately, and because it creates extra dead space and lead to potential infection. So muscle flap can be, it's easier to raise muscle flap with this flap. So this one young gentleman presented with neck pain and myelopathy and progressive weakness. We can see the tumor centered in the foramen magnum on the right side. Vertebral artery is typically encased by the tumor. That very well can be appreciated in the axial images. And we can see how there is severe compression on the brainstem and cervicomedullary junction, and how cord is displaced and distorted to left side. So these are the preoperative and postoperative images. Postoperative tumor was resected completely, and this is the pre-op and post-op images. This coming to surgical video. Here that extradural course of vertebral artery that is being identified because tumor was encasing. So here that posterolateral rim of after standard suboccipital craniotomy, posterolateral part of foramen magnum that is being drilled. We need not to resect condyle in all cases because larger the lesion, it's easier to operate. In foramen magnum, if lesion is large, it's easier to operate, and because that lesion itself will provide lot of space, and it will be very easy to go around and play around the tumor in larger lesions. So dura has been opened in the curvilinear fashion, and arachnoid is being, dissection is being done to separate the arachnoid. Now tumor comes into view. We can see how cranial nerves are draping around the tumor and how tumor has displaced the brain stem. So cutting of dentate ligament provide enough space and easier to play around the tumor. It gives enough extra space. And we can see how the cranial nerves are draping over the tumor. So the tumor matrix is being coagulated and nerves are being separated from the tumor. So in these kind of tumor, decompression is required because here we can see vertebral artery. Vertebral artery can be seen how tumor is encasing the vertebral artery. So tumor is being decompressed after coagulation. So with decompression, we get enough space to play around the tumor. That now tumor has been decompressed with ultrasonic aspirator, and sequential fragmentation and piecemeal removal of tumor is being done. So now tumor is being separated from the upper pole. Here we can visualize the vertebral artery on the corner. Vertebral artery is displaced laterally by the tumor, and tumor is being separated from the nerves and being fragmented sequentially. So it's being cut and being decompressed. Here again the vertebral artery is in the view. Here we can see a lower cranial nerve and in the draping inferiorly. So inferior pole of tumor is being decompressed and being coagulated. So now tumor is being separated from the medulla. So there is a definite cleavage plane, and that we were lucky enough to get this proper cleavage plane. So tumor is being separated from medulla and being decompressed. Now tumor is being delivered from the medulla. That part has been removed. So now that vertebral artery is encased by the tumor. So in majority of the time, there will be definite cleavage plane between the tumor and the vertebral artery. But in this case, there was no cleavage plane, though it was appreciated by the preoperative imaging also. Here we can see how vertebral artery is encased by the tumor. So that part is being decompressed with ultrasonic aspirator. We tried multiple times to develop the plane, but it was not possible. So that part, here we can see opposite contralateral vertebral artery. This is contralateral vertebral artery and contralateral pica is seen. Now this is opposite side vertebral artery and pica. And now again we can appreciate there is no cleavage plane between the tumor and vertebral artery. So this part of tumor was decompressed with ultrasonic aspirator, and tumor is being decompressed. Here we can see that some other remnants of tumor are being removed, and this is the view we get after removal of the tumor, and some part remnant of the tumor was left behind on the vertebral artery. So this is the view we get after complete removal of the tumor. And sometimes video angiogram also can be helpful in these kind of cases. It provides real quick time intraoperative picture. So we did video angiogram also to just localize and to identify the vertebral artery and see the encasement. So here we can appreciate that tumor is encasing the vertebral artery and there is no definite plane. So some remnant was left behind and rest near total resection was done, though there was no obvious residual in the post-operative imaging. This is another patient who presented with progressive weakness of all four limbs. So this same that far lateral approach, lower cranial nerves are draping over the tumor and tumor is being decompressed after coagulation. And we need to, there should be minimum manipulation of the neurovascular structures in lower cranial nerves. And we can see vertebral artery in the view, and this is the view we get after removal of the tumor. So this approach can be utilized for this one 40-year-old female who presented with gait ataxia and weakness. So there was purely solid hemangioblastoma, particularly occupying in the CP-angle system and cerebellomedullary system. Here we can see angiogram, this tumor plus. Tumor was purely solid. So these large, purely solid hemangioblastomas should be treated on the line of AV malformation. Only difference in AV malformation, there is true there is no capillary network, and AVM and hemangioblastoma there is capillary network. So that's why they do not bleed, do not present with hemorrhage majority of the time. So this is the view, intraoperative view and video angiogram view. And this is the intraoperative video. This here we can see the after large cherry red color tumor, and so principle of hemangioblast, pure solid hemangioblastoma surgeries are same. Arterial feeder should be disconnected first, and then go around the lesion, and then last there should be venous drainage should be tackled. We should not attempt to enter inside the tumor because it will lead to catastrophic bleeding. So now tumor is being dissected all around, and arterial feeders are being coagulated. Here now tumor is being dissected from the brainstem, and then last that venous drainage is being tackled. And so after devascularization, tumor will look like this. This is another case where there was bilateral mirror meningioma, and we can see how tumor is encasing bilateral vertebral artery. This patient also presented with progressive weakness. A tumor was large on right side, so we decided to operate this patient first on right side. So right side far lateral approach was done, and this is a post-operative imaging. So post-operative, some tumor remnant was left behind along the vertebral artery, and from the same side, opposite side matrix was coagulated, and for residual on the left side, patient was given radiotherapy. Patient is doing well at almost 3 years follow-up. This one proximal pica aneurysm. So far lateral approach can be utilized for this kind of aneurysm. This is another mirror meningioma at foramen magnum. So this we can see this bilateral lesion, but this was not operated by far lateral. This was operated by standard posterior approach. This is, we can see vertebral artery is encasing tumor on left side, and this is some residual was left behind on left side. So this initially this approach was developed by heroes in for vertebrovascular junction and proximal pica aneurysm. So this is large vertebrovascular junction aneurysm arising proximal to pica and distal to basilar forming of basilar. So this is the MRI imaging. There we can see large partially thrombosed aneurysm, and this patient presented with severe ataxia and quadriparesis. We can see axial image, how brainstem is displaced and severely compressed by the aneurysm. So this is the view of far lateral approach. We decided to approach this patient by left side. So this is the view. We can see bilateral vertebral artery, basilar artery, lower cranial nerve, 7th, 8th complex, and this is the aneurysm. This is far lateral approach after standard suboccipital craniotomy and hemilaminectomy. So dura is being opened after CSF release from cisternum magna. Here we can visualize the cranial nerve, 7th, 8th complex and bilateral vertebral artery. So in these partially thrombosed giant aneurysm, it becomes necessary to decompress the aneurysm before definitely identifying the aneurysm neck. So here we can see bilateral vertebral artery and basilar artery. So this is the aneurysm. So aneurysm is being decompressed with the ultrasonic aspirator here. Here we can see pica. Pica is separated from the aneurysm. And we can see junction and basilar artery. Now aneurysm is being decompressed with ultrasonic aspirator. So after decompression, this neck defined and clip bars placed. This patient had difficult postoperative course, and this is the angiogram. Postoperative angiogram, and there was no residual filling of the aneurysm. So this another before segment aneurysm who presented with hemorrhage. Again standard far lateral approach. Here we can see after cutting of dentate ligament, we get enough space. So before segment aneurysm is being identified. This is the aneurysm. Aneurysm is being separated. The neck dissection is being done. So now this dissection has been done here, and clip has been applied. So these are this actually slides are displayed. These are postoperative images of that giant hemangioblastoma case. There was no obvious residual. So take home message is foramen magnum lesions are challenging tumor in the vicinity of brainstem, and this approach can be used to get the overview around the ventrolateral brainstem, and lesion anterior to dentate ligament can be very well tackled by this approach. And the drilling of foramen magnum lateral wall required during approach is always limited, and majority of the time that various variation of the far lateral approach like transcondylar, supracondylar and paracondylar, most of the time condylar drilling is not required because larger the lesion it's easier to operate. That is a dictum. So due to wide versatility, this approach has become the pillar among the approaches for the posterolateral and anterolateral skull base. Thank you. Thank you very much.
We invite questions from the audience.
Excellent presentation. Congratulations. I'm only wondering that how were you so confident that aneurysm would not bleed when you were going for the decompression without proximal control?
No, proximal control was taken, sir.
Oh, okay.
Proximal control was taken, but that is the only way in larger aneurysm. That is the only way.
Yeah.
We need to decompress. Without decompression, we will not be able to define the neck. But proximal bilateral vertebral artery proximal control was taken.
Okay, that's great.
I'd like to invite Dr. Sham to present a memento to Dr. Anil. The next speaker is Dr. Ashish Suri, Professor and Head of Unit, Department of Neurosurgery, AIMS, and President of the Skull Base Society of India. He will be speaking on endonasal approach to pituitary adenomas.
It's coming. It's on keynote. My PowerPoint is having a problem. It's in two presentations, one and two. Keynote पे है. Take your time. Happening? It's in two presentations, one after because. So a bit of change of topic. Thank you for the invitation. Welcome to the interim meeting. It's not only endonasal, it's an overview of my philosophy. So I'll be talking about all pituitary adenomas. So as we know the size, microadenomas less than 10 and macroadenomas more than 10 or equal to 10. Giant adenomas and invasive adenomas. Can I have a pointer? The scroll is not coming here. The approaches are transsphenoidal, that is microscopic, sublabial or paraseptal, endoscopic, endonasal or extended endonasal, and transcranial, conventional intradural, and pterional, which is conventional, and skull-based extradural, intradural, transcavernous, and skull transbasal. What I use are the endonasal, endoscopic, the extended endonasal, and the standard pterional and the transcavernous. So this has been my philosophy and my change over the last 25 years as a faculty. And before that, I was a resident trained completely in microscopic TNTS. So if you see the first 10 years, it was all microscopic, both paraseptal as well as sublabial, then completely changed to endonasal. But there are a lot of green columns that you see. These green columns are the ones which are, you can switch this off. These green columns are the ones which I do extended approaches for the transcavernous approaches. Can you switch off this light, please? Yeah. Light. Yeah, better. Thank you. So just for the residents. So this is the one which I was doing endonasal paraseptal in 2008, 8, and this is 2010. So this is my own journey. So to prove myself whether I have taken the right track, this was the microscopic Hardy speculum. It is all good till the cellular floor, then becomes usually blind. Well, the microscopes have also changed. At that time, it was the Pentero, I think, and before that was the NC4, and now it is the Kinova, but still, the aperture is still, right. So where the vision ends in a microscope, for a pituitary actually, it begins in an endoscope. So with that thought process, I actually changed in 2007-8. Thanks to both Fred Gentili as well as Martin Pittag. This is my own change from microscope to an endoscope journey. So I'll talk initially about the microadenomas and the macroadenomas. These are non-invasive. I always tell that these are tumors between the 4 blue lines, the two cavernous sinuses, two anterior-intercavernous. In these tumors, microadenomas and macroadenomas, except Cushing's adenomas, which are very lateral, close to the carotid, a standard endoscopic endonasal approach, uninostril or binostril, a microscopic endonasal approach, sublabial and paraseptal are the same. There is no difference. There's no difference in extent of resection. There's no difference in recurrence. There's no difference in complications, and no difference in cure. It depends on who's doing it. If you are the best in one technique, you'll be good in the other technique. This is what I've felt in my own hands. So it's for the residents. This is the position, supine, head turned, which I explained yesterday in the cadaver dissection. The patient's face watching at you so that you can face the nostrils, and you can have a clear scope there. This is the area which you'll be operating on, the cellular floor, and I've changed completely to an intraumbilical incision for the fat. There's the usual arrangement. Now we have two screens, so there's another, for the extended approach, the assistant can watch the other screen. So it's not a right or a left side nostril first. Whichever is the most sizable, that side you go between the middle and inferior turbinate. Then you reach the choana, and then you first medialize the middle turbinate, and then you lateralize the middle turbinate. First you medialize it, and then you lateralize it. Medialize to see how much is the uncinate process. Do you need to take off the uncinate process? And then you look at the sphenoid ostium, like we demonstrated yesterday in the cadaver. This is the right side. The first trajectory has to be between the middle and the inferior turbinate. And you may do an inferior fracture of the inferior turbinate. That is the area you can do an inferior fracture. Just especially in Cushing's and Nacros, I do that. So this becomes sizable. Go into the choana. This is completely minimally invasive endonasal skull base surgery. Then you first medialize it, look at the uncinate process, then you lateralize it. Look at the sphenoid ostium, a centimeter above the choana. It'll be, you walk over this, and that is the superior turbinate, and that is where you get that. And then you open the sphenoid ostium inforomedially, and you open the sphenoid sinus. And similar thing on the other side. So if your left side is much more sizable, do the left side first. Then you come to the right side. And then again, between the middle and inferior turbinate, lateralization, sphenoid ostium widening, and look at the owl side, the two sphenoid ostia, and make it a sizable opening. Yes. So this is a large uncinate process there. We removed it in the video, and this is the owl eye appearance. Now, till here, we use the rongers, then we use the drill. Going to sphenoid, that is the cellular floor. The cellular floor, which we showed yesterday, the clivus, the two carotid prominences, the medial OCR, the lateral OCR, the planum, the tuberculum, and the optic processes. Then we have the cellular floor. We drill the cellular floor. Yesterday there was no drill, so we used the 1 millimeter ronger. The 1 millimeter upcut is good for the cellular floor between the 4 blue lines. Anything on the cavernous sinus, do not use the kerrison or the upcutting or the downcutting force. Better use a diamond coast diamond drill. Cellular floor opening is done like that, and the dura is exposed, and all under irrigation. This is because most of the time the medial OCR will have a carotid bulge. In 2 or 3% of cases, there will be no bone over that. So if you're taking a ronger there or a cutting drill, you may injure the carotid there. The cellular dural opening, when I was doing the microscope, it was to be cruciate. Now it's a smiley. I take a 5 o'clock to a 7 o'clock smiley incision, take back cuts there. This prevents the arachnoid bulge from falling down, and then we can do a nice extracapsular dissection and do the micro or the macro adenoma removal. It's a standard approach. Look at the normal pituitary gland, look at the cavernous sinuses, look at the arachnoid bulge, and that's the cavernous sinus. You do not need an extended approach for a standard cavernous sinus exposure, a 3A, sometimes a 3B. You just need a change of a scope, a 0 degree to a 30 degree to a 45 degree. So you do not need any Haddad flap, you do not need any middle turbinectomy. It's a standard minimally invasive procedure. This is what we saw yesterday. If you're doing an OS4, you can actually go lateral to the carotid, that's the 3rd nerve, 4th nerve, and the 6th nerve. We were seeing all that. This is standard Cushing's adenoma, microadenoma, small size, more to the left side. So I'll just scroll through the video if you've seen the steps. So your first trajectory has to be on the sizable nostril between the middle and inferior turbinate. Look at the middle turbinate, medialize it, see, look at the uncinate process, lateralize it. Look at the sphenoid ostium, make a small septostomy flap. So that is over the sphenoid ostium, and that is a semilunar flap over the lower part of the woma. Open the sphenoid ostium in the inferomedial direction. Look at the sphenoid sinus. Look at any septum which is there. Then go to the opposite side. That is a sizable resumption process. We cannot lateralize this, otherwise it will fracture, it will become mobile. So you actually do an uncinectomy, take off some part of the anchus, just expose the antrum. I'm showing my resident how to do a middle turbinectomy. In this, you don't need a middle turbinectomy. This is, so you leave around 5 millimeters of the initial, the base of the middle turbinate, and then you bring it down. The ostia is widened. Both sides you have, and then you need an antrum punch and a back biting forceps. That you take off a bit of the perpendicular plate of the vomer. So usually the posterior septostomy is just 8 millimeters, 8 to 10 millimeters. Then it's all drill. You take the drill, take off the rest of the vomer, take off the septum, and that's the cellular floor. Thin the cellular floor. This is my initial case, so I was using a ronger at that time. Then a smiley incision, 5 o'clock to 7 o'clock, and then back cuts on the thing. Do an extracapsular dissection, look at the microadenoma, take it out completely. But in Cushing's, we published it in 2020, I think. One of my faculty was working on it. It was his thesis topic when he was a resident, that our own remission rates in Cushing's from microscope 60% became around 90% with endoscopes. So this is our recent publication. What do you do if it is an MR negative Cushing's? So if it is MR negative Cushing, you must rule out an ectopic source. Do an IPSS followed by the GAD-DOTA PET-CT. We now we start doing an MR negative Cushing. We now start doing a 3 Tesla perfusion MR. You must do an extended, first a standard endonasal approach, then an extended approach. Explore the pituitary gland and the lateral cella. Look at if there's an adenoma which is not being seen. Look at the cavernous sinuses. Look at the stalk. And in the end, if you do not find the gland and the tumor, do a hemihypophysectomy. And still then, if there's no remission, do bilateral adenectomy or stereotactic radiosurgery or medical management. But here, I usually do 1 or 2 or 3 surgeries before. I always say it's a failure of surgery and the rest of the treatments can follow. This is the algorithm which has been published in Neurosurgical Focus. A couple of cases of MR negative Cushing. This is an interesting case. This was a recurrent Cushing's, no remission in the first surgery. So that we have drilled this is the recurrent surgery. So we have done the drill, taken off the planum, cutting the dura, and you can actually see the tumor on the anterior surface of the lower part of the stalk. That is the adenoma. And we could see that on a contrast MRI. If you can see, this is a thickening of the lower part of the stalk, and then some enhancement, and this patient became disease-free. Another case in which we had to do a 3 Tesla dynamic perfusion MR. We could see this adenoma there on the lower part of the stalk, or the upper part of the gland. So we explored the gland. That is the planum. That is the stalk. We didn't find any tumor in the stalk. We cut the diaphragma. And at the junction of the stalk and the gland, at where the diaphragm was ending, that was the adenoma there. And we took it out, and the patient had complete remission. That was the adenoma. Cushing's are very challenging cases. They are very humbling, actually. I think it's one case, and that was a patient who had remission and then had a recurrence 1 year later. And then we explored, and we found this tumor in the upper part of the stalk, close to the optic chiasm there. Yeah, that was it. That was the only one which I've seen the tumor in the upper part of the stalk. And still the patient was disease-free for 1 year, had a recurrence, underwent a bilateral adenectomy, because we have explored everywhere now. What about larger adenomas, the macroadenomas? These are more straightforward than the micro. I think the microadenomas are much more difficult than macroadenomas. These are much more straightforward because they have a widened cella. This was a non-invasive pituitary macroadenoma, no cavernous sinus extension. I'll just scroll through this. This is a small posterior septostomy that we always do, a small mucosal flap, which I showed yesterday in the cadaver dissection, which rests in the choana. We replace it over the gland later, and then take off the vomer, the keel of the vomer. It's a typical 2 nostril four-hand approach, truly endoscopic, and then the opposite side. We use a Colorado needle to take the monopara needle. And that's the cellular floor. You can see the widened floor. So in my hand, I've always felt that microadenomas, especially Cushing's, I'm better with the endoscope than the microscope. In these adenomas, macroadenomas, I'm the same. I was doing the same job with microscope, the same job with endoscope, the same job with paraseptal, the same job with sublabial. But yes, this is the problem. These are some cases which I've. So you have a tumor there, and the arachnoid is bulging, but we know that I know that something is there behind the arachnoid. So we tried curating from under the surface, but so this, we saw in detail the MRI again. There was two lobules of tumor, one in the cella, there was another one in the supracellar, and which was abutting the stalk, and then we actually delivered this tumor down. There was no subfrontal extension, there was no cavernous sinus. These are the tumors that I would have left when I was doing a microscope approach, and may resort to a second stage surgery when the tumor had come down. So in endoscope in my hand, I feel that you can actually see more. I can look at the stalk there, like this was the stalk. The last bit of the tumor, at the junction of the gland, the tumor was removed. So that is the stalk, you can see that. That is the stalk, the lower part of the stalk. This is a variation, because in most of the endonasal pituitary adenomas we do, the stalk is not seen. It's the arachnoid and then the stalk comes over. So there was another lobule of tumor which was there above. I've done 3 of such cases. And then just fat. So in all these cases, it's just fat, no Haddad flap. Yeah, another one. Again, a true endonasal, non-extended endonasal endoscopic. Fracture the vomer with the perpendicular plate of vomer. I'm scrolling them to save time. And then the posterior wall. Then a solid drill for the septa, especially if they are going on towards the cavernous sinus. This posterior exposure is very important, this one, because this is where your curettes and all will be resting. Then a standard endonasal approach, complete cellular floor exposure. Look at the 4 blue lines, giving an incision there. This is a nice bipolar that helps actually. It's a EndoPen. I don't remember the name of the company, but it's nice. I'm extending the excision. The tumor is going up. There are again 2 lobules. There's a lobule above in the cella, the lobule above the diaphragma. Decompress that. Look at the cella. Sorry, it's the pituitary stalk. I show the pituitary stalk. That's the pituitary stalk. So no tumor is visualized. Then fat. Some fat and fascia, and some more fat. Well, coming on to larger tumors, giant tumors, I'll cover in the next one. These are the ones which are larger. I'll scroll this, and we've seen enough of nose. So I was doing maybe 15 years ago with my ENT colleagues. Now the nasal stage is done by me and my residents. We are much more midline oriented. The ENT surgeons are much more paramidline oriented. So that is sometimes I take off the disc of the bone, which can be placed back. Again, a smiley. Take off the 6 o'clock tumor, then a 9 o'clock, the 3 o'clock, and that's the tumor bulge which starts. The good thing about the endoscope is you can take a patty and push this arachnoid up and look at the tumor which is going up in the suprasellar system. And then you can deliver that. That was the tumor I sometimes had, unknowingly I would have left in the microscope. I'm not saying this for all. This is where I learned. And this is the large arachnoid bulge. We push it back again with the fat. So always do a fat packing. Residual tumor. I'll just switch on to the other one. Is it coming? Okay. Coming to the giant ones, these are the ones which are more than 40 millimeters in size, up from the jugum or towards the tuberculum sellae. Why do we need to operate giant? It is a life-saving surgery, it's a vision-saving surgery, it's a pituitary hypothalamus-saving surgery. Subtotal excision does not have any role in a giant adenoma unless in the cavernous sinus. Otherwise, there'll be a post-operative pituitary apoplexy. What about invasive? Nearly 2/3 of the giant adenomas are invasive, 1/3 of the acros are invasive. So you must have a knowledge about invasion into the cavernous sinus, in bone and sphenoid sinus. This is the NOS grading. Now, NOS grading talks about the 0, 1, 2, 3 going into the cavernous sinus per se. But they don't talk about going above the superior wall of the cavernous sinus or into subdiaphragmatic. Dr. Goyal is sitting here. So I love this classification actually. Why? Because this is the only classification which talks about both giant and invasive. NOS talks about invasion, but does not talk about giant at all. Well, nearly 70% of the giant are invasive. So this is only one classification which has a grade 1, grade 2 transgression, and the upper, my scroll is gone missing again. Can you enable my scroll from there? Yeah. My mouse scroll. And the grade 4 are the ones, supradiaphragmatic. Why do we need to operate invasive adenomas? Because we need to make them sizable for gamma knife radiosurgery or for medical therapy, especially if they are functional. If they're non-functional, they have very severe headaches. These patients have intolerable headaches. You have to decompress. You cannot eradicate grade 4 tumors. These are the ones which are giant with a huge subfrontal extension. You need to take off the tuberculum sellae and some of the planum. Take off this subfrontal remnant, otherwise it will be left behind. Again, a very big subfrontal extension. What about 3A between the two carotids? I showed that yesterday. You just need to change to a 30-degree optics and you'll be taking it out. You do not need extended approach for a 3A GOL2 tumor. Again, 3B. You do not need an extended approach. You just need an inferior extension, the inferior bit of the carotid and the Clival loop of the carotid, and then you can take off that tumor. Let me know when the time is up, I'll stop. And then what about the cavernous? Because this is a huge topic, so I'll just scroll through the videos. I'll just take another 4 or 5 minutes. And what about if it is GOL 3, 4 and NOS 4? So I now combine these classifications in whatever the cases I have. So these are the ones which are going beyond the 4 blue lines, sometimes beyond the carotid also, but they do not go beyond the arachnoid, subarachnoid. So these are the ones, scroll. So this is no longer a minimally invasive surgery. This is a maximally invasive skull-based endonasal surgery. So you have to do a middle turbinectomy. You have to take the Haddad flap out. And your skull-based drilling is actually much more than what is prescribed. So you have to take a nasoseptal flap, as was shown yesterday, inferior cut, a superior cut, and a vertical cut. And you have a nice nasoseptal flap that you can repair. The carotid, if you bare the carotid, it's not only CSF leak. CSF leak, you need a Haddad flap. But if you bare the carotid, you must cover it with a nasoseptal flap. Then dural opening is different. Rather than a smiley, it becomes a smiley with a cut above. It's an inverted T, and then maybe an H to expose the carotid. If you're taking so much of dural opening, you need a repair. Now it is no longer 3-layer repair. You need a fat, you need fascia, you need Haddad flap. It's a 3-layer repair with reinforcement. Glue and everything becomes more of a tamponade. You need to create a mass there. So these are the steps. I'll just scroll through them. What about these tumors? You cannot do half-hearted resection of these tumors. You'll be coming up back in the middle of the night with an M1, M2 patient. Believe me, it happens. Always keep these patients as the first patient in the morning and do an extended approach. You'll spend around a good lot of time taking these tumors out. NOS4 cannot be eradicated, but you can do a sizable decompression of them. A unilateral NOS4, do a middle turbinectomy. I'll just show that. Then take a Haddad flap, which I showed yesterday. Yesterday cadavers were very good. Thanks, Dr. Rao. They were actually bleeding. And this is based on the neoseptal branch of the sternopalatal artery. Here the drilling is also more. You drill the dorsum, you drill the planum, you drill the tuberculum. And do a tumor decompression. After that, we actually see the carotid. Our navigation failed. Our navigation was not showing the exact place for the carotid. So now we realize that we need to do some more drilling, as I showed yesterday. So all this drilling has to be with a coarse diamond drill. Yesterday we used the upcut. I'm just closing off. I'll skip the rest. And then you do an incision on the dura lateral to the carotid and take off the tumor from there, take off the bridge. And I think I'll just skip all of it. It's a huge list for microscope. When endoscope should not, because it's a skull-based meeting, not an Indonesian, they're not a nesting meeting. So so to conclude, so I feel that pituitary tumors, pituitary adenomas is a big versatility. For microadenomas, for Cushing's, this is what we have. High remission rate is directly related to primary surgery with respect to redo surgery. Adult patients do better than pediatric age group. The post-operative POD1, cortisol, and ACTH are the determinants. Lower, this is a new molecular marker that has a significant value. Endoscopic endonasal transsphenoidal approach, I feel, is the best approach for that with high remission. And there must be a histopathological evidence of an adenoma. If you have that, the remission rate climbs down to 80%. This paper is just granted permission to publish in World Neurosurgery by my resident, Nidisha. And this is the algorithm for MR negative, which I showed you, that you have to do an IPSS, and there are new adjuncts like the perfusion MR and all that you have to do. For giant adenomas, you must do a good preoperative planning. An endoscopic endonasal approach has a better extent of excision. The poor extent of excision is directly related to retrocellular, subfrontal, and cavernous sinus extension. Plus, our publication in Neurology India showed that if the tumor is T2 hypointense, going to the cavernous sinus, the extent of resection is poor, then you can do an extended approach, but do not start pulling on the perforators from because otherwise you'll have a carotid injury. You must never do a half-hearted decompression, otherwise you'll land up with a post-operative pituitary apoplexy. This is a very important slide as a conclusion. What to do in which invasion? If there's a GOEL2 NOS3AB, a standard endonasal endoscopic approach with a 30-degree, 45-degree scopes, visualizing as those extension can give you complete resection. If you have a NOS4, GOEL2, small hyperintense T2 lesion, then extended endoscopic endonasal approach is good. This is optimally invasive, but you need a good knowledge of the repair and exposure. If you have a GOEL4, GOEL3, NOS4, large hypointense on T2, you please do not do an endonasal approach. You do resort for a transcavernous approach, because here carotid is the most important, and you'll be all, and there, a transcavernous with Dolenz of opening the Parkinson's triangle, and the oculomotor, I didn't show the video. Extradurally, the Parkinson's triangle between the fourth and the V1, and intradurally, the oculomotor trigon. If you open the oculomotor trigon, you can actually, that is the superior wall of the cavernous sinus where it extends to. Thank you very much.
Thank you very much, Dr. Suri. Can we take some questions from the audience or comments?
Ashish, I enjoyed your presentation. Like always, you are a fantastic teacher, and you have actually, through your work in the lab, you have promoted not only microneurosurgery, but also endoscopic work for the entire country and for others from other parts of the world that you are training.
That's following your inspiration, sir. Thank you.
So congratulations to you, and congratulations to your work, and I wish that you continue with the same spirit and same enthusiasm. That is one. Second thing is, you're saying endoscope is good for this and microscope is good. There is no question endoscope has given a bigger vision, given, look into the corner and all those things. There is no question about it, no question. But you know what? In my experience, which is more than nearing 5,000 pituitaries
On microscope, sir.
on
I beg to
microscope,
differ.
all under microscope. I have actually never regretted or never found the need. I am not saying endoscope is not good.
No, I'm also not
But
saying so.
I am saying for pituitary, you can you can angulate your speculums and angulate, and you can enter into cavernous sinus, you can go lateral to the carotid, and you can do whatever, even with an endoscope, with a microscope. But I agree that endoscope gives a very wide vision, nice pictures, look into the corner and all those things. Other thing which I just want to make a smallish little point. When you were showing the pituitary tumors, you were saying arachnoid is coming down. Actually, you know what, that is, as you have mentioned later in your talk, that is not arachnoid, that is diaphragm, that is dura. And understanding that the dura covers the dome of the tumor has completely revolutionized pituitary tumor surgery. Otherwise, many of the tumors that you have shown 25 years ago, all those tumors were done transcranial.
Absolutely.
The fact that they are under the dura has made people do it from the nose, whether it is microscope or endoscope, that is immaterial. So I think it is not correct to use the term arachnoid bulging.
Absolutely.
The thing is, it is a continuation of dura, and dura is the proper term. And that is why pituitary tumors are within the confines of the dura, majority of them. And that understanding is absolutely crucial for large and giant pituitary tumors.
Yeah, absolutely, sir. All the points well taken. The first one, thank you for the nice comment. I'll come to the third one first. I completely agree. It is the dura. What happens, what we've realized with that the margins in which, because of splaying, the dura has some boundaries. The arachnoid actually merges with that, and that gives the thing. And it's absolutely clear. So the main conclusion, you're absolutely right, that 90% of the pituitary adenomas can be managed through the nose, whether you want to do it from the microscope or endoscope. That's the main conclusion. Regarding the other part, the transcranial, it is not only pterional, it is an extended pterional, and if you're going to do that part of the tumor, you better attack the cavernous sinus and the nosophore and those areas, rather than just doing a pterional craniotomy and then opening and shutting and taking a biopsy. That is what my intention is. Regarding question number 2, I completely agree with your extent of experience, sir. So I was trained by the best of the best. I was trained by Dr. Banerjee in 1993, 94, 95, and Dr. Mehta. Till even after faculty, I was following him. And I was so good in microscopic surgeries, and I'll show you my videos. I used to do the complete pituitary adenoma in 15 to 17 minutes, from mucosa to mucosa. I used to do 3. Dr. Mehta used to compete with me, used to do 4. It was always faster than me. So, and I started doing this collaboration with Martin Bittak in 2006-07. We wanted to adopt some of the endoscopic modules, and they wanted to share our microscopic modules, especially of the cavernous sinus thing. And I'll be very frank with you, we had a lot of teleconferencing, and he did some surgeries at AIIMS, and he and his team. And I changed over to endoscope, sir. It is a magnificent tool, believe me.
No question.
And it took me time.
Ashish.
It was a learning curve. And here I would like to give credit to Dr. B.S. Sharma, because there was a lot of resistance from my department also, believe me. And there was a lot of support in that direction. But I've realized, especially in for microadenomas, the Cushing's, that is where it is so remarkable. I can see the cavernous sinus. I can actually see there, especially our last publication last year, in which we found it on the stalk. That is something I could never do with the microscope, sir. Believe me. At that time, maybe the now new NC4s and NX5, the Leica OH5s and all, I've not seen the optics of that. There's definitely better optics. But the other one is the subfrontal extension. I can actually climb over the subfrontal extension. And the last one is the NOS4. I can mobilize the carotid, go lateral to the carotid. But yes, nonetheless, I shared with you in the last week meeting. I've done more than 500 of them from the nose, endoscopic. I'm fully convinced that it is the tool. But yes, I completely disagree with people who say this is the same tool for suprasellar meningiomas and for craniopharyngiomas. There's a different pathology and a different orientation altogether. This which I feel. And maybe the world comes, it's a circle, we are moving around. Maybe we'll have some balancing equations after maybe 10 years.
I will just give you one small little, we have 1 or 2 minutes. I was recently in China, 5 days ago, and I found some beautiful endoscopic work being done there, beautiful.
Overtime, sir.
Should I stop, eh?
Yes, sir. The chairman says we have to stop.
Chairman says stopped.
Thank you so much, Dr. Suri. It's a fantastic talk. I'd like to invite Dr. Vijay Sarathi, former professor and head of neurosurgery at NIMS and now senior consultant at Yashoda Hitec, to present a memento to Dr. Suri.
No. Can you take this?
Thank you, sir. Our next speaker is Dr. Ravi Mohan Rao, senior consultant neurosurgeon from Apollo Hospital in Bangalore. He will be speaking on anterior petrosectomy or Kawasse's approach.
Good morning. I thank Dr. Narsingh Rao and his team and the chairman Krishna Reddy for this invitation to speak in this interim skull basecon on anterior petrosectomy approach. Both Professor Atul Goyal and Professor Ashish Suri are sitting here, and they are the doyens of this approach, and I am sure they will have something to tell about their variations after my talk. So I'm approaching this slightly differently. I'm showing the bony anatomy first. This is the petrous apex, middle fossa, foramen ovale, foramen spinosum, foramen lacerum. So this is the facial canalicculus from where the GSPN comes. It passes over the carotid canal. This is the arcuate eminence. And the anatomy of the petrosal bone is between. So you draw a line along the GSPN long axis, and the long axis of the arcuate eminence, and the internal auditory meatus and canal is at that bifurcation between these two angles. And this internal auditory meatus and the external auditory meatus are in one straight line. So the external auditory meatus serves as a bony landmark external landmark for the location deep inside of the internal meatus and the internal auditory canal. So the anatomy between the two, you have the external auditory canal, internal auditory canal with the 4 nerves, and then in between is the middle cavity, which is the beneath the tegmen tympani, the arcuate eminence, and then you have the labyrinth, posterior and anterior to the internal auditory canal. So we'll look at that anatomy later on, and you have the GSPN which comes out of the facial canalicculus and travels in the major petrosal groove covered by connective tissue. And this needs to be separated, otherwise traction on the major petrosal groove may cause a facial palsy. And marker for the petrous carotid, as I already told, is the GSPN. This is a wire placed over the in the facial canalicculus along the major petrosal groove. The GSPN goes under the 3rd division to form the Vidian nerve with the LSPN, and this is the petrous carotid, which is just underneath it. And as I told earlier, the long axis of GSPN, long axis of the arcuate eminence bisection is the internal auditory meatus and canal. And this is the quadrangle of bone which has no neurovascular structures. The markers for this are the 3rd division of trigeminal nerve, which forms the anterior border, the petrous ridge, the medial border, the internal auditory canal is the posterior border, and the medial border is the petrous carotid underneath the GSPN. So this quadrangle of bone up till the clivus can be removed without any neurovascular structures. The advantage of removing this piece of bone is from the middle fossa you can look into the posterior fossa for some of the cases where required. You don't need to do a petrosectomy for a large trigeminal schwannoma because it does the petrosectomy on its own. If you have to do petrosectomy, it is for lesions like low-lying basilar bifurcation aneurysm, petroclival meningioma, which is straddling the middle fossa and the posterior fossa, but located above the line of the internal acoustic meatus. Because from this you cannot look below the internal acoustic meatus from the middle fossa. And external landmark for the IAM and canal is the external auditory meatus. The posterior root of the zygoma is in line with the foramen spinosum, and the anterior root of the zygoma is in line with the foramen ovale. So these can be used as landmarks to go directly through the required landmarks, and Professor Goel has shown with a very small exposure he can reach there. I usually do a bigger exposure. And marker for the cochlea, because cochlea is in front of the internal auditory meatus, when you are drilling the petrous apex quadrangle, you have to be very sure where the cochlea lies. The cochlea lies between the genu, the posterior bend of the petrous carotid, and the internal auditory canal. So it's in the medialmost part of the posterior and medialmost part, which I will show in one of my videos. So the first patient is a 7-year-old girl who presented with squint due to 6-nerve paresis, diplopia and headache. And this is the scan which showed a hypointense lesion in the petrous apex, which was enhancing quite well all along the petrous apex. In fact, it was going into the middle ear too. And you see almost maybe going into the infratemporal fossa, and this is the dura which is seen above covering it. So there is no intradural component. Some big vascular channels seen within the tumor, and this is the destruction of the bone which is seen, and very tight narrowing of the ICA, which during surgery I found there is no flow in the internal carotid artery. And this is the position. A young patient, very flexible neck, so supine lateral with lateral flexion of the head, intraoperative neuromonitoring. This is the incision I use. This was actually marked by my junior colleague, and you can use a U-shaped flap centered over this. You can do it with a vertical incision. So this is the video. So you go to the temporal base. The craniotomy is done 2/3 in front of the external auditory meatus and 1/3 behind. You start stripping the dura from the temporal base. I use the nerve stimulator frequently to find the location of the GSPN. This is the petrosal groove with the connective tissue attached to the dura between the petrosal groove, which houses the GSPN and needs to be sharply dissected. Cutting the GSPN may cause dryness of the eye, and traction on the GSPN may cause facial paresis because it arises from the geniculate ganglion. This is the arcuate eminence. This is the arcuate eminence, GSPN coming out from the geniculate ganglion, stripping the dura. The skull base here looked abnormal with a lot of small fleshy lesions being present in the skull base between the dura and the bone. That is the petrous ridge. So this is the arcuate eminence, the geniculate ganglion, and the IONM confirming the presence of the facial nerve. This is the coagulation of the middle meningeal artery. Suri does this differently. He drills around the middle meningeal foramen spinosum and then coagulates. I generally don't do that. This is the middle meningeal artery cut. This is the arcuate eminence, and this is the internal meatus, the cistern. The lesion was elevating the 7th-8th nerve complex, and it was very easily, it could be stimulated by the stimulator in low current. This is the line of the internal auditory canal. This is the arcuate eminence where the facial nerve takes a bend around the superior semicircular canal and then dips into the fallopian canal to behind in the mastoid. So you can actually, because it's very close to the bone surface, you can trace out the facial nerve using a stimulator. So we have reached up to the geniculate ganglion. I'll just move it forward a little bit. And the carotid artery was bare. So you see the carotid artery with no bone over it. This can happen in 10% of cases, and in this case, I'm not sure whether because of the pressure of the tumor there, whether the carotid artery was bare. So one need to be always cognizant of the fact that bone can be missing over the carotid artery when doing a Kawasai's approach. And this is the foramen ovale with the 3rd division trigeminal nerve entering there. So you can go up to the foramen rotundum and strip the dura by incising the superficial layer and pull back the dura from the temporal base and also from the temporal pole if required. So this is the foramen ovale, and stimulation there got contractions of the temporalis muscle. So I'll fast forward it a little more. Cutting the dura, first stripping and freeing the 3rd nerve. So the dural retraction becomes easier, and the advantage of doing an extradural approach is the vein of Labe is inside the dura, protected by the dura, and you don't put undue traction on the junction between the sigmoid, transverse sigmoid junction where the vein of Labe enters it. So venous injuries are less with an extra interdural approach. This is the 3rd nerve which is being mobilized, no, I'm sorry, the 5th nerve which is getting mobilized. And this is the mandibular nerve, contractions, 7th nerve. Because there was no gap between the carotid artery and the petrous edge as seen during surgery, I decided to enlarge the foramen ovale, free the 3rd nerve a little bit so that the dura can be retracted. So this is enlarging the foramen ovale. This is the this is the 5th nerve. That's tracing the 7th nerve in the canal behind the superior semicircular canal where it dips down into the fallopian canal. So the drilling is started. This is behind the V3, 3rd division of the trigeminal nerve. Lateral to the carotid artery is the eustachian tube and the tensor tympani muscle. Medial to it is the structure of bone which has no important neurovascular structures. I will just fast forward again. So that is the eustachian tube with the tensor tympani muscle lateral to the carotid artery. The space available for drilling the bone between the carotid artery and the petrous ridge was very small, just a few millimeters. And anterior to that, where it goes under V3, if you drill in that region, you reach the petrous apex and then reach the compact bone of the clivus. There was no flow in the carotid artery, Doppler showed it. So drilling beneath the ICA, till now after removal of so much bone, except for small bits of what looked like tumor, I couldn't get anything. Only after drilling underneath the ICA, then I exposed a fleshy tumor which looked like muscle, very firm, vascular, difficult to biopsy with forceps, not suckable. That's the Petrus apex. The ICA getting elevated out of the Petrus carotid was easier in this case because one, it was narrow, and second, there was no blood flow through it. And then the tumor is getting exposed. You see this fleshy tumor which looks like muscle. And this is the tumor which is getting removed. Even with the dissector, breaking it apart was difficult. Professor Goel has a magical way with these tumors. And for me, it was difficult to break this tumor. I had to use CUSA. I used rongers, grasping forceps, biopsy forceps to remove it. One, it was vascular, very firm. And then started using CUSA. So you see the bleeding which occurs. So all throughout the tumor decompression, the few millimeters of tumor removal with CUSA, heavy bleeding which required pressure to arrest it. And then since the preoperative radio diagnosis by our neuroradiologist was a rhabdomyosarcoma, so I stopped at this level because it responds very well to chemotherapy, and 5 and 10-year survivals are known in rhabdomyosarcoma. So fat graft, because I had opened the dura while drilling, fascia, and the post-op scan, and the histopathology is a malignant small round cell tumor compatible with rhabdomyosarcoma. So I did this last week, and the patient has been referred for chemotherapy. The next case is that of a Clival meningioma, which I did 15 years back. So this is a old video, and the same steps, exposing the GSPN, middle meningeal artery being cut, LSPN and GSPN. This is the LSPN, GSPN, and underneath that is the Petrus carotid, and the IAC. This is the acute eminence. IAC can be found out through stimulation. The facial nerve becomes more superficial near the fundus of the IAC. This is the internal carotid artery which is exposed. The advantage of doing this, defining the cochlea and internal carotid arteries, you can remove maximum bone, like in a pterional craniotomy where removing extra bone gives a wider angle of approach. This is the fundus of the IAC. This is the bone housing the cochlea. And then you see the cochlea exposed here. All the bone can be removed, and the posterior fossa dura, middle fossa dura, and can be cut, and superior petrosal sinus is ligated, and you see the trigeminal nerve with the tumor beneath. So this is a video, I'll quickly forward it. Since I've already shown the steps, I'll go fast through this. So the same steps were found, defining the margins of the quadrangle, which can be resected safely without damaging any of the neurovascular structures in the internal auditory canal, and the carotid artery is done. And then the dura is exposed, cut. Posterior fossa dura exposed, petrosal sinus being ligated and clipped. and the tumor being decompressed with CUSA. This is the trigeminal nerve. And then you see the brainstem, fifth nerve. And this is the post-op CT scan showing excision of the meningioma, the MRI scan. This patient had one problem. She had pain in the trigeminal nerve distribution, which was extremely resistant to treatment after the surgery. Now I come to a low lying, I'll just take 1 or 2 minutes, basilar apex aneurysm. This is the angiogram. This patient had SAH. The neck of the aneurysm is below, at the level of the dorsum sella, nearly at the level of the sella floor, and the clivus and the dorsum opens up more towards the right side. I chose to do a right-sided approach. The right PCA was hypoplastic, left was, and the right PCOM was dominant, fetal PCOM. And this is the surgery. I used a combined approach, a frontotemporal and subtemporal approach, a pretemporal corridor. Because this frees the temporal lobe with its draining veins and draining sinuses, so you can retract them without damaging any of the draining veins. So usual interdural approach done over third division, second division, exposing the lateral wall of the cavernous sinus, doing a clinoidectomy which unlocks the internal carotid artery and the optic nerve, and then an anterior petrosectomy. Tried initially through the transilian route, but couldn't see the aneurysm well, and then went on to a subtemporal. There the aneurysm neck was hidden by the tentorium. This is the third nerve being dissected. So you see the aneurysm neck is hidden by the tentorium. So doing the anterior petrosectomy, this could be cut. It was a big superior petrosal sinus which bled, but could be controlled with pressure and stitches. And then the fetal PCOM, the hypoplastic PCA being dissected, a clip initially applied, a tentative clipping done. It was going across the opposite P1, so it had to be revised. A fenestrated clip applied. This is a perforator being dissected from the back of the basilar artery, the neck of the aneurysm. Damaging this perforator can be very dangerous. And then a revision clip applied to spare the opposite P1 and its perforator. This is the opposite P1 here, and the perforator coming. This clip was removed. And then after dissecting the hypoplastic P1 and the perforator, a straight clip was applied to occlude the patent neck in the fenestration of the previous clip. So post-op angiogram. So these are the applications: petroclival meningioma, low-lying basilar apex aneurysm, chordoma, chondrosarcoma, multi-compartment epidermoid, petrous bone tumors. I have not done a Fukushima bypass graft, but it can be used for a bypass graft from the petrous carotid. And trigeminal schwannoma, of course, it does the work for us by doing a petrosectomy on its own. So using this technique, you convexitize a deep-seated lesion, devascularize a meningioma early. Extra interdural approach offers brain protection, venous protection, detethering of the ICA optic nerve, the third division of the trigeminal nerve, gives a wider angle of approach, and of course, proximal control of basilar artery when required. Thank you very much.
Thank you, sir, for the fantastic talk with spectacular videos. Any comments or questions from the audience?
I'm sure Professor Goel does it totally differently. In fact, I learnt it from him in one of your workshops in KEM.
I just want to ask you, this so crystal clear videos you record, and these anatomical points are very small, tiny points. As you see the temporal bone, so many structures are there and there. When we do these procedures, we always have a doubt. Where is your arcuate eminence? Where is your petrous artery? all these things. Where I'm just asking, the concepts are there in the books, but how you exactly, what is your learning process? Did you practice in cadavers first, or it came by experience of doing so many cases?
Yeah, very good question. I did cadaver work in Professor Goel's lab initially, and then the arcuate eminence is the most prominent eminence in the middle fossa. So you start from there. Navigation helps, of course, and the two external markers, the anterior root, posterior root of the zygoma, and then the external auditory meatus, they tell where the structures are. So you start from there, go to the arcuate eminence. It's easy to identify GSPN, that way you can confirm with neurostimulation. Preserve the GSPN because that lies over the petrous carotid. What is medial to that is the safest area to dissect, and V3 is a very big nerve. So that's the anterior margin. Posterior margin is the internal auditory canal which you define. Medial margin is the petrous carotid. And lateral margin is of course the petrous ridge. So you can go through this quadrangle of bone till you reach the clivus.
I'd like to invite Dr. Ram Krishnamurthy to present us a memento to Dr. Ravi Monra. Dr. Ram Krishnamurthy is a senior consultant neurosurgeon in Hyderabad with Yashoda Hospitals. Thank you, sirs. Our next speaker needs absolutely no introduction. He is a mentor and inspiration to almost every skull-based surgeon in the country. Dr. Atul Goel, please.
Not here? Here also you can make. And I have a pointer here? Okay. Pointer will work there, right? Thank you, Dr. Narsingha, for all the hospitality, all the affection, and all the respect that you give me always, and today and yesterday. You have given me a title on spine in a skull-base meeting. Skull-base has been my workhorse for such a long time. Ashish, president of Skull-Base Society of India. I was the president about 15 years ago. Cavernous, sinus, petrous, apex, Clival, meningiomas are difficult issues. We have to learn, we have to dissect, we have to keep on dissecting. That is the message. There is no shortcut to doing Clival, meningiomas, and cavernous sinus tumors. But today what I'm going to talk to you about is spine surgery. And most of you, if not all of you, have heard me several times, but listen to it again, because it is a revolution. It is the future of spine surgery. It is different. When you talk to any spine surgeon of the world, leave apart tumors. Compression is the issue, and decompression is the treatment. That is the issue in spine surgery. I'm saying you can look beyond decompression. And I'm giving you some radical statements. Compression is not the issue. Compression is never primary. Compression is secondary to segmental spinal instability. Compression is protective. Compression is reversible. Compression indicates unstable spine, and decompression is never the treatment. So this is quite a revolutionary statement which I have been making for last several years. I'm not sure how many of you have been hearing about it, and I'm sure none is really into it. So human body is different. Human body, we stand on two legs, all our muscles are focused on the back of the spine. There is nothing in front of the spine. You put your finger, you can feel the odontoid process. You put your finger here in the neck, you can feel the vertebral bodies. You can put your finger deep into, put the endoscope right, you will feel the vertebral bodies. All our muscles are focused on the back of the spine, and they are all focused on the facets. There is no muscle in relationship to the vertebral bodies. There is no muscle in relationship to the disc. So there are several articles of mine where I am talking about what is the role of the disc and what is the role of vertebral bodies and what is the role of the muscles. My concept is clear. Everything is related to sitting position, standing position, running position, and the weakness of these muscles. Disuse, abuse, injury to these muscles is the problem. And when these muscles become weak, the problem is there is a vertical facetal instability. So this is a new concept which I will like to explain. And there is a telescoping of the spine. And this telescoping cannot be seen on dynamic imaging. You cannot see. In the craniovertebral junction, where the atlantoaxial articulation is flat, muscles of the nape of the neck are huge. Chronic instability is one thing and acute instability is different. In a chronic situation, there is a concept of central or axial atlantoaxial instability. Several years ago, actually in 1999, for the first time we said that basilar invagination is due to listhesis of the facets. And we introduced this treatment by distraction, and this is not a fixed anomaly. Before that, most of the senior people will realize that only decompression was the treatment, either from front or from behind. For the first time we said that this is unstable and you can actually do realignment and there is no need for decompression. And you know now, a lot of waters have passed over it. This kind of basilar invagination, nobody will now like to do transoral decompression, reduction, realignment, and fixation. So instability is the issue and stabilization is the treatment. In 1999, actually first time we said muscle weakness related issue leads to listhesis of the facets and basilar invagination. So this was the first time. So basilar invagination, Chiari, syrinx, basilar invagination, listhesis is the problem, instability is the issue, and stabilization and realignment. You must mark my words, stabilization, that is the bottom line. If necessary, if possible, realignment, but stabilization is the main issue. So there is no hesitation for me to say that we just demolished transoral surgery from the books of neurosurgery. When there is a chronic instability, there are several natural reparative mechanisms that happen. Nature comes into picture, God comes into picture, and this article says what are the various issues. So this concept, in my estimation, there is no hesitation for me to say complete revolution in craniovertebral junction surgery. You will ask me what and why. And if you read these sentences, I am saying in this article that central instability is the cause of caries, central instability is the cause of syrinx, cause of basilar invagination. Also, if you realize, I have introduced degeneration, OPLL, Hirayama disease in this article, which is quite a heavily cited article now in the literature. Now, I want you to see carefully these slides. In 1999, we said listhesis, C1 over C2 is the problem of basilar invagination, compression is not the issue, instability is the issue, and stabilization is the treatment. Sorry for that, sorry, yeah, here. No. What is happening here? So here you see listhesis of C1 over C2. Now if you see this slide, This is basilar invagination. Today also, I will say whole world will do foramen magnum decompression for this because there is no instability documented. This is the only parameter of unstable spine. But if you look at the facets, there is listhesis of C1 behind this. So this is retrolisthesis, different from this. Stabilization is the treatment. No question, decompression is a negative form of treatment. This is what I understand. The next issue is, even when the facets are in alignment, presence of Chiari, presence of syringomalia, presence of assimilation of atlas, presence of clipal file, presence of platybasia are all definite, clear indicators of unstable atlantoaxial joint, and atlantoaxial stabilization is the treatment. So in chronic atlantoaxial instability, Dwarka, look here. Enjoy this beauty. In chronic instability, all these things that you are seeing here are secondary to chronic instability. They are natural, they are protective, they are reversible. Decompression is not the treatment. For all these, currently in the literature, decompression is the treatment. And several more. The other thing which I want to say is, when Chiari is present with basilar or without basilar, syringomalia is present alone, or there is short head without any other problem, or in cohort like bifid with C2, C2 with clipal file, with platybasia, any of these things are indicators of unstable atlantoaxial joint, and stabilization is the treatment. So basilar invagination is one of those secondary manifestations of chronic instability, chronic atlantoaxial instability. Stabilization is the treatment. So you can see how the whole world has changed in the 20 years from decompression to stabilization. And there are several articles of mine for both group A and group B basilar invagination. So when there is Chiari and syrinx, these are secondary to chronic atlantoaxial instability. Look at the facets. Even when the facets are in alignment, instability is the issue. Even when there is no compression, no atlantodental interval disturbance, stabilization is the treatment, and there is no question, no doubt in my mind. Even when the facets are in little bit malalignment, no problem here, no compression here, Chiari and syrinx, you do stabilization. Syrinx will reduce in 100% of patients if you do a scan after 6 months, and in 30% of patients you do a scan after 15 days. Even no problem here, no problem here. Problem of Chiari is indicator of unstable atlantoaxial joint. Mark my word, atlantoaxial joint, and stabilization is the treatment. So Chiari, syrinx, do fixation, no decompression. All these things that you are seeing are secondary. They are chronic. They are due to unstable spine. They are protective. Decompression is not the treatment. Stabilize and see the magic. Clinical magic is absolutely out of the world. So here I reported 388 cases. I request you that please go and see this article. Now my experience is nearing 600 cases. If you ask me today, why decompression, not decompression, I'd say this is the treatment and this should be done. Otherwise, it is not a correct form of treatment. No question, no hesitation. So Chiari is secondary, it is natural airbag, it is protective. Syringomalia is secondary, it is not harmful. Do not drain the syrinx. For the first time we said it is a natural protection. Do not do any kind of syrinx shunt and things like that. So I said when Chiari with syrinx or syrinx with or without basilar invagination or in isolation, it indicates unstable spine. Even when the facets are not in too much malalignment, you stabilize and you see the magic. There is no question in my mind. Cervical fusions like C2-3 fusion, assimilation of atlas, clipal file abnormality are all protective and they are secondary, and they indicate unstable atlantoaxial joint even when there is no compression. No compression at the craniovertebral junction. You do atlantoaxial fixation and you see the magic. Bifid is secondary, it is protective. Os odontoideum is secondary, it is protective. Bifid with fusion, without fusion, they are, whether it is in cohort or not in cohort. C2-3 fusion. So all these things indicate one thing, that is atlantoaxial instability. Musculoskeletal abnormalities like short neck, torticollis, even if there is no radiological problem, means of course you have to monitor here and there, you stabilize and you see this beautiful smile. Here smile is not so beautiful, but hands and legs have become complete. In this situation, in this kind of torticollis, this kind of imaging, do not do any kind of decompression, that is final. So short head, short neck, short spine are all indicators of unstable atlantoaxial joint. Over the years, a lot of things have happened, but I have now enjoyed this subject. Kyphoscoliosis, with Chiari, without Chiari, syringomyelia, this is a complex issue, but if there is Chiari and do C1, C2 fixation, this will reduce in the very immediate postoperative period, and you please look at this article in World Neurosurgery. Central instability can be present in isolation, and it can, when there is bifid, when there is basilar invagination, C1, C2 fixation is the treatment. So whether foramen magnum decompression can become historical, no question, it will become historical eventually. Now I go to another very little bit fantastic subject of subaxial spine. If you see spondylosis, the whole literature is disc-centric. Disc is the problem, disc water reduction is the problem, disc herniation is the issue. Whole spine surgery is focused on the disc. But we have, you read this article, we have said disc is divine, disc can never go wrong. Craniovertebral junction instability and degenerative spine, nobody has discussed in the literature. When you talk of degeneration, you talk of C5, 6, C6, 7, never C1, C2. C1, C2 degeneration, in my estimation, is the most frequent degenerative osteoarthritis and related instability. I want you young fellows, Ashish, just, you know, I don't know whether you had a little bit more drink or I had a little bit more, but I see some faces not looking at me. Ashish particularly, Ashish, how many drinks you had last night? Tell me the truth. I know, but enjoy it because this is different. Ashish, look here, okay? Reduction in the joint space. You are seeing this reduction in the joint space? Buckling of this disc, this ligament, osteophyte formation are due to vertical instability. If you see your grandfather, he's shorter than you. Why he's shorter than you? Because there is all his segments, there is a vertical instability. He's not unstable. You see his imaging, dynamic, no unstable. Presence of osteophytes in front of the odontoid, behind the odontoid is not, this is not primary. They are secondary, they are protective, and they are reversible. This is the concept. Retroodontoid pseudotumor, the whole world was doing transoral surgery, lateral. For the first time we said this is an indicator of unstable atlantoaxial joint and only stabilization, no need for decompression from front and from behind. And many people now follow this concept. So facets are the strongest part of the human spine, much stronger than pedicle, much stronger than vertebral bodies, much stronger than any other part of the spine. Listhesis of C1, C2 is the cause of basilar invagination and several other issues in craniovertebral junction. Nobody has discussed about subaxial facets and its relation to degenerative spine. Carefully look at these slides, my dear friend. Reduction in the interbody space. Bulging of this disc, ossification of ligament, calcification of ligament, bulging of ligamentum flavum, osteophyte formation are not primary events. They are due to vertical spinal instability. They are secondary, they are protective, and they are reversible. And they indicate unstable spine. So vertical facetal instability is the genesis of degenerative spine. So some years ago, about 15 years ago, we introduced this intrafacetal distraction fixation technique. And this from here introduced my new world of spinal surgery. I was not really interested in spine surgery, but here I went into a different platform. Distraction without reduction reduces all these things in the immediate postoperative period. Like you see here, bulging disc, bulging ligamentum flavum. This is immediate postoperative, no decompression, and we talked about beauty of the results and beauty of things on several occasions, and most of you have heard me. So no decompression, but distraction fixation is the treatment. This is what we described 15 years ago, not now. And this is several cases we did at that time. And this was published in Journal of Neurosurgery as a cover page illustration. Same concept we use for lumbar canal stenosis. Distraction cages, no direct decompression. And this was also published in Journal of Neurosurgery with a, and very highly cited article now in the literature. Now I came into a different world. I came into a different era. See, decompression is the whole world is doing for several decades. I did indirect decompression and fixation. But then I realized even direct and indirect decompression is not necessary. Even facetal distraction is not necessary. Only fixation is necessary. And then we talked about this experience in World Neurosurgery, and you see the title. Muscle weakness related spinal instability is the cause of cervical degeneration, and spinal stabilization is the treatment. You see, this is the in World Neurosurgery. And now I will show you few cases, multisegmental degeneration. There is no question many people in the world will do corpectomy or anterior decompression. Some will do laminectomy and laminoplasty. I was also doing for several years. But these are secondary, these are protective. You just stabilize and they will disappear. And the patient will recover in the evening of operation. Mark my word, when I say I am doing this for last 15 years or 16 years, and if you ask me and question me, no question, this will happen, at least in my experience. You see multisegmental degeneration here in front, and the whole world will do anterior surgery or posterior surgery by decompression. So compression is the issue for the world and decompression is the issue for the world. But I am saying that is not correct. Instability, multisegmental muscle weakness is the issue. You stabilize, this is after 18 months of surgery, the entire architecture has changed, and so we should look into degenerative cervical myelopathy in a different perspective, with a different eye. Instability is the issue and stabilization is the treatment. Not neural deformation or compression, but instability is the cause of symptoms. And I use transarticular Camille's technique of fixation, which is a fantastic issue. If you ask me what is the most critical issue in degenerative spine, it is to identify which segments are unstable and which segments need stabilization. Here, if you see, there are 2 segments of compression, but I have done 4 segments of fixation. Why 4? Why not 2 is the most critical issue, and I wish that you please read this article. And after 16 months of surgery, you see the whole thing has changed. You cannot wait for 16 months for patient to recover. I am saying patient will recover in a magical fashion in the evening of operation, only fixation, no decompression. This is another case, multi-segmental. Now I have cases after cases. There is no question about in my mind. You see this multi-segmental, the whole world will do anterior decompression and things like that, and posterior laminoplasty, but there is the real issue is unstable spine. These are compression, these are secondary, these are protective, these are reversible. Multi-segmental. Now I come to another chapter. Like whenever we talk of instability, C1, C2 we ignore. Atlantoaxial instability is very frequent in multi-segmental degeneration. You see there is compression here and all those things. There is no problem here, but see, look at the facet, whether the facets are abnormal or not abnormal. In severe myelopathy, More often than not, atlantoaxial instability is almost always associated. You have to include atlantoaxial fixation in your fixation construct. And magic. You must read this article here. I don't remember how many, but if there were some 40 or 50 patients coming on wheelchair, all the 40 are now walking. So you read this article. So multi-segmental, no problem here, no problem here, but I have included C23 in the fixation construct. Why C23 I have included? Because this is an alternative way of doing atlantoaxial fixation. Lumbar canal stenosis. If you ask me lumbar canal stenosis, what is the treatment in the world? There is only one treatment, decompression. And you read the title in Neurosurgical Focus, Role of Stabilization and Futility of Decompression, quite an aggressive in Neurosurgical Focus. So this kind of lumbar canal stenosis, my concept is clear. My concept is that it is unstable, multi-segmental instability. Identify the unstable segments and stabilize. There is no need for any kind of decompression. Is osteophyte resection necessary? My answer is clear. My answer is definite. There is no need to remove the osteophyte. The whole world of spine is focused on the osteophytes, and you please read this article in World Neurosurgery where I am talking what happens to osteophytes after 6 months or 1 year. And my answer in that paper will be clear. Osteophytes disappear. Osteophytes reduce in size in not 10%, not 15%, 100% of patients if you do an imaging after 1 year. So these are the multi-segmental issues where there is no need for any kind of decompression. Deformities are secondary. Deformities are a result of unstable spine. Identify instability. In this case, you do C1, C2 fixation. In this case, you do multi-segmental fixation and involve the atlantoaxial joint. In this case, you do not involve the atlantoaxial joint. Which segments to fix and which segments not to fix is the issue. Herniated disc, now another controversial and confusing and maybe dangerous to listen also, not to follow, listen. But I am saying prolapsed disc is due to sudden instability, sudden injury to your spine. Disc herniation is secondary to unstable spine, or unstable spine is a cause of disc herniation. Only stabilization is the treatment. For this single segment, what the whole world will do, you know what they will do. ACDF, I was doing ACDF for several years, but here, identify unstable spine, stabilize. This will definitely get resolved in few months. So this was the article in World Neurosurgery about only fixation of herniated discs. Lumbar radiculopathy. You see, now this is a little bit difficult issue for you to even hear, not to follow. This kind of herniated disc is the instability is the problem. Stabilize and this herniated disc will disappear in very quick time. OPLL, in spinal parlance of spine surgery, if you ask what is the most controversial, most difficult, dangerous issue in spine surgery is OPLL. And if you ask anybody who's doing spine surgery, decompression is the treatment. I describe oblique corpectomy for the first time in the literature. I was doing oblique corpectomy, this corpectomy all the time. But now I say today in front of you and in front of various people all over the world that OPLL is secondary to unstable spine. Identify which segments are, and only stabilization is the treatment, not any kind of decompression either from front or from behind. So these kind of OPLLs are very dangerous and difficult, you know, and those who do know, because if you have done 10 cases, if you say, somebody says to me, I have done 10 cases, and if he says not even a single patient has developed quadriplegia after surgery, I will not believe him. I am saying you do only fixation, don't worry about anterior decompression and posterior decompression, and you see the magic, a magic that you will never have realized following decompression. Atlantoaxial instability is very frequently associated with OPLL, and this kind of OPLL, you have to include atlantoaxial fixation in your fixation construct. This kind of OPLL, severe compression, multi-segmental, don't do any kind of laminectomy, do fixation, and this is the treatment, this is the future, this is definite, positive, and 100%. So atlantoaxial and subaxial fixation, can it revolutionize the surgical treatment of myelopathy related to OPLL? My answer is clear and my answer is definite, yes. Can decompressive laminectomy for degenerative spine, lumbar spine and all those things can become a part of history? My answer is clear, my answer is definite, yes. So my dear friends, my understanding on the subject is that compression is never primary and decompression is never the treatment. Thank you very much.
Thank you so much, Dr. Atul Goel. As always, your talks are a paradigm shift in neurosurgical concepts. I invite any comments and questions from the audience.
Dwarka, but you were sleeping.
I'm not sleeping.
Ashish, you don't ask me any question. Eh?
Sir, why camel screws? Why not this one, lateral mass screws for cervical fusion? Why did you select the facetal screws?
Screw, see, facets are the strongest part of the spine. You can use lateral mass screws with rod if you think you are more happier with that. But I find this camel's technique such simple, such strong, and such safe. You see, you put the screw, and I do sometimes 5-level fixation or 4-level fixation in 15 minutes. And you know, and if you read one of my articles where I have elaborated my experience with several screws, beautiful experience. You read that article.
But they also say that when you, when you dissect the muscles of the the lamina and the spinous process, you are also contributing to the weakness of the neck, and probably that also is helping and post-operative pain. So what's all your comment on that?
See, the thing is, like for atlantoaxial joint, instability is the issue and stabilization is the treatment, okay? Now, if you leave the muscles attached to the C2 spinous process, they will keep on pulling, you know, they will keep on pulling. And you put any kind of implant, any kind of solid implant on the lateral mass or wherever, but if the muscles keep on pulling, they are so strong, they will break the implants in next 6 months. So you have to demolish the muscles, you have to make the bone, decorticate the bone, you have to put bone graft, you have to fuse that segment. If one segment is not working properly, the answer is fix it, fuse it and finish it. You don't try to work on retaining the movements. I have also introduced one more article. If you want to see, I have introduced some spacers which are giving movements, and this is my patented product in US, but I have never promoted it because I don't think it is necessary. Even for atlantoaxial joint, you must have read my article. This is also US patent, where I have put an artificial joint on C1, C2 in the subaxial facet artificial joint. But I don't do it because we have not even manufactured it, neither I think it is necessary.
Regarding this Roy camel screws, you are stabilizing 2 levels. In between those 2 segments, is the instability not a concern?
Which 2 level means 2 segments.
Yeah, your segment 2 segments, and again 2 segments. So between the first segment and the second segment, instability should be, if you do a lateral mass, then all are stabilized.
Now, another very beautiful thing in spine surgery is adjacent segment instability. This is a very big concept in spine surgery. Like you do fixation on 2 segments, there can be adjacent segment instability is a very common issue. But if, you know, what happens is when you are doing, there are some radiological markers, like osteophyte formation is a marker of unstable spine. Clinical markers like radiating pain, weakness, quadriparesis, spasticity, they are indicators of multi-segmental spinal unstable spine. Intraoperative observation, you can move the spinous process and you can find an unstable spine even when there are no radiological or clinical parameters. So you have to read my article on which segments are unstable and which segments need to be stabilized. The other thing that you are saying that I am doing 2 and 2 down and I am leaving 1, I never do that. I don't know how you got some, maybe you have not seen it properly. If I have to do 2, I will not leave 1 segment, I will fix that one also.
Between those 2, so suppose 3 and 4 years facetal screw, again 5, 6 facetal screw. Between 4 and 5, what is
so 4 and 5 also I will fix. I will not leave that.
between those two segments, the question is, two bones have facetal screw stabilizers across the facet.
Yes.
And again across the facet, but there is no connection between the upper and segments. That's what is my question. So there will not be an instability between, suppose
No,
3,
you are
4, 5,
stabilizing
6.
the entire segment. There is nothing, if you have done C2-3 and then you have done C3-4.
C4.
C3-4 also you will do. You will not leave C3-4.
Okay.
We will talk about that. I know, my dear friends, you may not be asking me questions, but the controversy in your mind will be very rife and very, it must be hitting you, like lumbar canals. I don't agree. How can you agree with this concept which is dramatically different from what is conventional, instantly? But I will suggest to you, you think about it. Now I have to also tell you, for Chiari malformation, many people in the world are doing fixation. 15 years ago when I said no decompression, there were many people who were having one big controversy and discussing and arguing and ridiculing, like they do to me now for lumbar canal stenosis and degenerative spine, ridicule, argue, discussion, no, this and that. But believe me, my dear friends, I am a part of you. I am a part of Skull Base Society. I am your, if you want to call me older brother, younger to Dr. Shastri, but others can call me older. You listen to what your brother is saying, okay? Don't wait for some international person to bring in this concept and then you say, yeah. Thank you very much.
Thank you so much, sir. So I request you to stay on stage. I invite Dr. Purohit, one of the senior most neurosurgeons in this, to...
In August, we are organizing one conference where I'm doing live surgery workshop, and all of you are heavily invited. And here we are also having Indo-Japanese conference. Dr. Shastri knows about it. This is Indo-Japanese friendship meeting, which we want to showcase Indian work in that conference. You have to come. The other thing is, in this, there is International Meningioma Society is participating, International Society for Neurosurgical Tools and Techniques, and also a little bit Asian Society of Neurosurgery, and also a little bit ISNO, Indian Society of Neuro-Oncology. So you must attend, and those who want to have early registration there can be all done complimentary, and stay and all can be done complimentary. You please contact me, but you have to come. That is the bottom line. And if you have controversy regarding these concepts which you have heard, then you must come. You cannot just ignore for others to tell you, okay? Thank you very much.
I'd like to invite Dr. Purohit to present the memento to Dr. Atul Goyal. Our next speaker is Dr. Anand Balasubramaniam, Professor and Head of Department of Neurosurgery at Amrita Hospitals in Faridabad. He will be speaking about intraoperative imaging in pituitary macroadenomas.
Hello. Yeah. Good morning, everyone. Thanks to the organizers for this opportunity, my respected teachers and colleagues in the audience. It's very difficult to follow Dr. Atul Goyal's talk with his revolutionary concept, and revolutionary that he finished on time today. So big applause for him, because he always has so much to say that it's very difficult to condense it in half an hour. I'm trying to go into condense what I need to say. I think Savit has made it 18 minutes. It was supposed to be 24. I'll try to show intraoperative imaging in pituitary surgery. Considering that this is a CME, there will be certain basic concepts. You have already seen beautifully Dr. Ashish Shuri demonstrating the pituitary surgery steps, and a person of his expertise and his level of experience may not need any intraop imaging to help. But intraop imaging helps a lot for beginners and for people who are experienced to further their resections if required to achieve better safety. So what intraop imaging was available and what is available today has been in this spectrum. So we used only dental mirrors initially to look around corners. Then we had intraoperative, maybe radiofluoroscopy like CIAM. Pneumoencephalography was a big thing to look at the descent of the top of the diaphragm, injecting it through a lumbar drain. Endoscopy revolutionized the whole thing. Dr. Ashish showed beautifully how all of us have literally converted from microscope to endoscope. Then we have the intraoperative actual imaging in the form of, say, virtual navigation, intraoperative CT. Some of the centers have started having now intraop MRI, more increasingly available, and intraoperative ultrasound becoming more familiar. These require special modification. Intraop MRI need not necessarily be within the operating theatre. For a pituitary surgery, it may be easier to even wheel your patient in between surgery down to radiology and come back with just a packed nose, which may be easier than doing it for a craniotomy. So you can have image guidance if you want and if you feel it's essential. So let's see where there is a use here and where they have been making a difference. So this is all the CIAM view we had just to show us that we are bang on the cella. We are not in the ACF base or in the clivus, so that's all that it could show. And then if you injected air, it could show the descent of the diaphragm. Microscope was giving us this kind of a view. Endoscope has visualized it much, much better. We can see the normal pituitary much better now. We can even save these structures much better than before. Intraop CT, just to show you, this in pre-op MRI, intraoperative CT does have ability to show you residues above the diaphragm, even in the cavernous area, which can be safely removed. Of course, resolution is an issue. Blood within the field is an issue. So, and radiation exposure becomes an issue. Ultrasound, you need special probes. These are side-directed probes which are becoming available, maybe expensive. You have to have an inverted image with the stalk and then the diaphragm and then the structures above. You can see the cavernous area, ICA and the adenoma, and you can measure even the size of the residue there with showing a distance of 15 millimeter. So you can have as many tools as you want which is available with you, but the point is utilizing them for the benefit of the patient, and does it really benefit the patient is the question. Intraop MRI, as you know, was the double donut model. We have open MRIs, we have these low Tesla, low field MRIs, but the most popular is these models, which is the more expensive moving magnet model, which is probably not in use in many centers now. This is the most economical model where the patient transfers on to a MR compatible trolley, which goes to the adjacent operating room. And this gives you ability to do the MRI in the same operating position of the patient and use of the adjacent MRI room for diagnostic purpose. So I think this is the most cost-effective model, and this can be easily incorporated if you are planning to construct a theatre and a radiology suite next to each other. That would save the purpose for both without increasing the cost to the patient. I'll quickly show you some videos here, if they work. It did work. Yes, there it is. So you can see here, there is a residue out in the cavernous region on the left side, across the carotid. There's like knobs, almost 3, not going to the lateral part, but in between. So you can confidently curate within the carotid siphon. If you know where you are curating, you can use, of course, navigation to locate that part, but you need to know whether there is tumor still left there or not before you can put a curate confidently in the side. We saw a giant adenoma, Dr. Ashishwari showed. So these type of tumors can be removed safely with no residue left behind. If you have intraop imaging to guide you, I'll show you shortly how else that can be done. This is paracavernous spread, invasion into the cavernous sinus where you had to leave behind tumor. But you see that the optic tract is still compressed, and you can modify that by squeezing in some fat in between and confirming with intraop MRI that your optic tract is away, and the amount of tumor you are leaving behind laterally can be safely radiosurgery without disturbing the optic tract. So you can modify post-operative treatment by using these intraoperative imaging techniques. Coming back to the tumor that I showed you, it's huge, multi-compartmental, gone into the third ventricle. It is not difficult to reach inside, but it is difficult to know where you are. I'm not able to see the fast forwarding button. How do I don't want to see the whole video. Can I fast forward the button? So you can see here, once you have decompressed the tumor, the suprasellar part is going in much deeper, and we know it's entering into the third ventricle, and we did not know how deep this part is before we can start doing a extracapsular dissection. So if you have an imaging at this point, you can see that the superior part, still about 1.5 to 2 centimeter of tumor is left. So you can now proceed comfortably, and I'll show you here. You can decompress more confidently within the center that we are decompressing, and as you are decompressing more, the tumor comes down, and then you can start dissecting it from the optic nerve on top. Now it's much safer because you are surer that you are not pulling down on the optic nerve on any suprastructures, and then finally you have removed completely. You can see the third ventricle with the mammillary bodies and the opening of the fourth ventricle clearly. Otherwise, we would leave behind tumor thinking that we may damage the patient. So this is a post-operative scan, and there is no residual tumor out there, completely removed, third ventricle. This is the follow-up scan, contrast, no suprasellar residues. This is a tumor with a paracellular suprasellar extension, which may be very difficult to remove from transnasal approach, but if you know the direction and location of this, then exactly in that direction you can remove, and you can see the blood after the removal with the intraop MRI showing no residual tumor there. So these difficult to remove tumors can be made approachable through transnasal route. Now I'll just quickly show you normal pituitary preservation. We see it more often in the endoscope. You can see here superiorly that pituitary is preserved. So sometimes we do have a doubt what we are seeing is tumor or is it pituitary, and then if you do the intraop MRI, you do see the stalk and the pituitary enhancing differentially. So you can leave the normal pituitary behind without having to remove it. And it becomes a problem, especially in functioning adenomas, because you don't want to leave behind tumor. So however large the tumor is, you can preoperatively be able to see that the pituitary is in this direction and superiorly, and intraoperatively you can do the MRI and check that it's only that stalk and the residual pituitary that you are leaving behind, and not any tumor tissue that is being left behind. So these are residues. So here is a nice laterally placed growth hormone secreting adenoma with normal lobe on the other side, and after resection of the tumor, we can do the intraop image and check that you're leaving behind only the normal gland and no part of functioning adenoma is left behind, because we know this is very critical in functioning adenomas to have total excision, otherwise they are going to have more issues post-operatively. Diagnostic, intraoperatively, you can have complication like this. You can see that there is, after tumor removal, we thought the diaphragm should fall down, but intraop MRI shows that the diaphragm is still held up high there. And then when we did the contrast, lo and behold, you could see contrast leaking into the cavity. So this was active hematoma. This is probably the case which would have had a blown out pupil by the time you reversed and shifted to ICU. You can diagnose it on table, then we could save this patient's by removing that hematoma and then repacking the cavity completely. So there is no, intraop imaging is not an excuse for meticulous hemostasis, but you do need to, if you have it, you can use it to prevent complications. So what type of cases it's really useful? So quickly I'll go through here. You see in our own experience of about 30 cases, which we did initially, the symmetric tumors, the primary gross total resections are very good. The asymmetric tumors are lesser, and then the residue detected can be further gross totally resected, and you see that there is a clear advantage in the asymmetric tumors. So in symmetric tumors, probably they all come down very well. In the asymmetric, it's a problem. So the point is, if you expect a tumor, you see preoperatively, this is a tumor which I can remove completely, expected gross total resection. We know some of them with extensive extensions, you are going to leave behind some tumor along the cavernous sinus. So at least with the help of intraoperative imaging, this 26 cases should be able to remove completely. So that is the aim. Now, use of MRI, does it help? Of course, statistically it becomes significant, but the point is not that. There are plenty of cases, case studies showing that primary resection is getting you only about, say, 40%, and secondary resection takes it up to 70 or 80%. So still we are not achieving 100% resections. Mind you, another study from Switzerland showing the same primary resection about 40%, additional resection takes it up to 80 or 90%. this benign tumors, so they don't damage, they don't restrict the life of the patient. So you have to be careful to chase 100%. But intraop imaging gives you that safety when you are trying to chase as much as possible. So there's again a combined series of meta-analysis, 7,000 patients. You can see that endoscopic alone gives you limited. With intraop imaging, endoscope has a higher percentage of resection, microscopic lesser, but microscopic will benefit more if you use with intraop imaging. Now I'll quickly show that this paper for recurrent pituitary adenomas, how intraop imaging has been useful, and they have concluded that remnants along cavernous sinus, clivus, and perforations across diaphragm. You can see this is along the cavernous sinus, this perforation across diaphragm, this is along the clivus. The size of tumor are significant variables where intraop imaging is very useful. Now this is an interesting score I came across, very similar to what Dr. Goyal has classified, but a little different in the sense the intercarator distance to interlateral margin of the tumor difference, just to show which tumors benefit more from intraop imaging. So if the ratio is less than 0.75, that means they are within the two carotids, then the resection rates are very good. If they are almost equal or a little larger, you tend to have lesser, and if you are going more lateral and more beyond the carotids, then the residues are more. So you see that the first two you can do very good resections, but you do get residues which do benefit from intraop imaging so that your resections are complete. So this is the gap between expected resection to postoperative image, showing an unexpected residue can be reduced with intraop imaging. Coming to functional preservation of the pituitary, if you use intraop imaging, they have found that more recovered axis in the intraop MRI group, less axis is lost in the intraop MRI group, and less patients with loss of axis of a particular axis intraop MRI group, all being statistically significant, which is pretty interesting. If you see that in the intraop MRI group, the control compared to the control patients, the number of patients with a new deficit are less, and number of patients who are having functional recovery are also more. We could argue that using good endoscopic technique, we can identify the normal gland, but when there is a doubt, if you have an imaging, it confirms it to the better. So in our own experience with functioning adenomas, we have found good results using intraoperative imaging, good chemical control, both in growth hormone and Cushing's, and replacement doses. The patients tend to have normal thyroid and steroid function more than 80% of the time, so they don't have to be on lifelong thyroid and steroid. And mind you, if there is a residual tumor and you're radiating them, you are going to make them hypopit. Even though there are advanced ways of radiating them nowadays, the chances of hypopituitarism is still higher. So if you don't want the morbidity of lifelong treatment, challenging stress steroids to be taught to the patient when he has to take during intercurrent illness, it's in our interest to preserve the normal gland as much as possible. So postoperative hypocortisolemia, hypothyroidism, or panhypopituitarism can be reduced significantly using good imaging techniques as adjuncts. So this is a paper which came across for functioning adenomas. Again, in functioning adenomas, after the initial surgery, reinspection had to be done following resection, and you can see additional tumor resection helped a considerable number of patients. One important point that came out of this paper is persistent hormone excess was 7-fold higher in complete resection. So in functioning adenomas, surgery is the best option unless it's medically manageable. So when you're doing surgery, the first time is the best time, and it's good to have as good a result as possible. So I think in these cases, you'll prefer to do with image guidance. So as I made a point, is gross total resection so very essential? The progression-free survival, is it the right endpoint to analyze pituitary tumor outcomes? Or it should be the functioning outcomes? We still don't know. It's not like an acoustic tumor where you are very clear that 7th nerve outcome is the gold standard. Tumor recurrence, we are not worried about. Pituitary, we are not worried so much about tumor recurrence, but if you are going to give additional radiation, or if you have not decompressed it adequately for return of normal pituitary function or the ophthalmic compression, then it doesn't make sense. So it is going to be a big controversy. What is adequate pituitary resection? Do you need imaging to have while doing the operation? I think there are lots of studies to show that yes, imaging increases. So here, about 1,000 cases using various types of MRI, unexpected residue in 42%, and cases re-explode and further resection achieved further. So definitely imaging helps in resecting more. Whether it is required in a particular case, does it increase the safety is the question. I think in large tumors, asymmetric extensions, recurrent adenomas, and functioning adenomas, they are very valuable. So this is a message I would like you to take back so that you know where an imaging may be useful, where that extra 1 hour you want to spend packing the nose, taking the patient to MRI and bringing back may be worthwhile for these patients. So in conclusion, I will say residue identification maximizes resections and cures, increases safety of resection, more important, towards especially cavernous sinus and in giant adenomas, it's a useful guide. You can tailor the resection for adjuvant therapy like radiation, gamma knife, etc. Picking up early complications, it's again very valuable. You can avoid unnecessary radiation in this benign condition. Preserving normal gland and function must be more valuable now rather than just getting the whole tumor out. Use endoscope, intraop CT, intraop ultrasound, or intraop or extraop MRI, but make it worthwhile for the patient so that our effort gives them some meaningful advantage with surgery. Thank you so much for your attention. I'll take any questions if there are. Savit shortened my time. I still managed to finish within time.
Thank you, sir. Any comments from the audience?
Now, newer techniques of radiation and also the cost involved in having all this infrastructure vis-a-vis, do you think there is a place for post-op radiation in a pituitary tumor if there is a residue?
So, very good question, sir. But point is, radiation is harmful, even if it is fantastic techniques. It's an invasive technique, all said and done. And if you can avoid radiation, is wonderful. But radiation, using imaging is not necessarily expensive. You can take the patient down to radiology, do an MRI and come. It will add you 1 hour extra in your operating time, that's it. I think that is a small price to pay than pay extra for radiation later and keep doing scans to check whether radiation has been effective or not. So I think it balances off. Intraop MRI is not any more expensive. You don't have to have a dedicated suite. We just have to plan it in such a way that radiology is nearby. Or for pituitaries, there is no harm in just packing the nose and taking the patient down for an MRI. We need good anesthesia support. We need good teamwork.
Thank you.
It's very difficult in institutes because there is shortage of time. We can understand places like NIMANS, places like All India Institute, where you want to turn over time fast. But if you can plan it in some way, probably in those cases where it is useful, we can still do it as an extraoperative imaging.
No, I'm discussing from a broad perspective of the country. All centers do not have MRI, but people are doing surgeries in a very good way, with a good microscope, good endoscope. They are doing a good surgeries.
Avoid radiation as much as possible. Don't radiate because there is a residue. Only if a residue is increasing in size, we can think of radiation. That would be better than putting patients for radiation, however good the radiation technique is.
Not immediately, but instead of going through all this.
The only point here is that it's not an alternative to leaving behind a residual tumor. Because residual tumor thinking that I can radiate later, that would not be an ideal situation.
Not like that. Aim is to remove it
inadvertently left behind, small residue, can be waited and watched. They are absolutely benign tumors. And you can still get them back with a quick MRI done on the same day. That is possible. You don't have to put more money. The point I want to convey is if you want to do it, you can do it without putting additional expenditure. We can find ways and means of doing it. We have to be first impressed that yes, intraop imaging helps.
If there's no further questions, I'd like to invite Dr. Sanjay to present the memento to Dr. Anand.
Thank you.
Our next program will be the inauguration of the conference. I request everybody to please be seated.
We welcome our beloved director, Dr. Pavan. Now the inaugural function will start.
As we start the inaugural function, I'd like to invite the President of the Skull Base Society of India, Dr. Ashish Suri, to come up on stage. I'd also like to invite Dr. Jha to present him with the memento. I'd like to invite the Secretary of the Skull Base Society of India, Dr. Rupesh. I'd like to invite Dr. KVRS Shastri to take his place on stage. I'd like to invite the organizing secretary of the Interim Skull Base Conference, Dr. Narsingh Rao, to take his place on stage. And last but not the least, I would like to invite the chief guest of this program, the young, energetic, and dynamic director of Yashoda Hospitals Group, Dr. Pavan, to take his place on stage. I would like Dr. Narsingh Rao, the organizing secretary, to present the dignitaries on stage with their mementos. I request everybody to stand for our invocation song.
Shah
I now request the dignitaries on stage to declare this conference open by lighting of the ceremonial lamp.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु दीपनमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Thank you, sirs. The year 2024 has only just begun, but in the last month, we have lost one of the visionaries in skull-based surgery. We would like to pay homage to the memory of Dr. Takanori Fukushima, and we bid farewell with heavy hearts to this remarkable soul. He was a distinguished neurosurgeon whose legacy transcends the boundaries of medicine. His passing leaves an indelible void in the field of neurosurgery and the hearts of all those who had the privilege of learning from him. He was a pioneer in the field of neurosurgery, renowned for his contributions in skull base and cerebrovascular surgery. His visionary approach to complex neurosurgical procedures, coupled with his meticulous attention to detail, earned him the respect and admiration of colleagues worldwide. To pay homage to this great neurosurgeon, I would like everybody to rise and have 2 minutes of silence, please. Thank you, ladies and gentlemen. I would now like to invite Dr. KVRS Shastri to give us a small speech inviting all of the delegates to this conference.
The chairman of Yashoda Hospitals, Dr. Pavan, Dr. Narsingh Rao, Dr. Suri, and Dr. Rupesh, senior neurosurgeons of the country, and colleagues. It is a great privilege and pleasure to be associated with this interim meeting of Skull Base Society in Hyderabad, which is organized by Dr. Narsingh Rao and eminently supported by Yashoda Hospitals, Gandhi Hospital, and the Brain and Spine Society. Yesterday we had a beautiful pre-lunch didactic lectures and post-lunch cadaver dissections covering important operative procedures. And I am sure all the delegates are looking forward for further lectures this afternoon. I thank the Yashoda Hospitals for immense support. Thank you.
I would now invite the Secretary of the Skull Base Society of India, Dr. Rupesh, to present his address.
Namaste and warm welcome to all the members of this meeting. Skull Base Surgery Society of India is now stepping onto the 25th year. This is the silver jubilee year after starting the society way back in '92. We had the first meeting in Delhi, and this again 25th meeting the Delhi team is doing. And Dr. Anita Jagatia, I request all the members to participate in large numbers and make this even a very memorable one. The entire motto of Skull Base Surgery is training and education, and the society never fails in doing that by doing regular cadaver dissection programs, interim programs like this. And all the delegates should utilize this opportunity. We had this beautiful meeting yesterday again and today. I hope many of you will enjoy. And there is another interim cadaver meeting at Chennai in July. So those who are interested, it's already distributed in the groups. So if you are interested, you can participate, and we look forward to the 25th meeting. So the society is growing in strength. Now we have more than 750 members, constituted majority by neurosurgeons, but there are also a good fraction of ENT surgeons and head and neck surgeons. So this is a true multidisciplinary team, and it's straightforward to attain success in this difficult specialty. So I think you will enjoy today's program with the entire video sessions, and we should have conducted a live surgery today, but due to some government regulations, we had to drop it in the last minute. Otherwise, this program would have been a live surgery workshop. But said, nevertheless, the video sessions will replace those live video session, and I believe that you'll learn a lot through this video session. Thank you again for joining us.
Thank you, sir. I now invite the President of the Skull Base Society of India, Dr. Ashish Suri, to present his address.
Good morning. Dignitaries on the dais, Dr. Shastri, Dr. Pawan, Director of Yashoda Hospital, Dr. Rupesh, the Secretary of the Skull Base Surgery Society, and Dr. Narsingh Rao, our EC member and also the organizing secretary for this meeting. My seniors, Professor Purohit, Professor Goyal, Professor Reddy, and my friends, Dr. Anand, Dr. Ravi, Dr. Dwarka, Dr. Deepak, and all my friends and students. Welcome to the interim meeting of the Skull Base Surgery Society of India, being held in Hyderabad. And the last two days have been very hectic, and except for the problem of the Hyderabad traffic, I spent a lot of time in the car actually yesterday. So, but I think all the Indian cities are becoming like that. So we had a wonderful time yesterday. There were lovely directed lectures, wonderful cadavers to dissect on, and the dignitaries had a wonderful exposure of the anatomy. Today, like Dr. Rupesh said, would have been a remarkable operative session, live operative session. But yes, I think it's more than an operative session. We're learning a lot of things. And this society, this is the 25th year of the society, and this event marks the first event of the silver anniversary of the society. And I joined this society around, I think, more than 20 years ago. And I was just past my MCH, more than 22 years ago. And I think this is one society which has a maximum attendance as far as membership is concerned after NSI. And my personal experience is that so much to learn. This is one society where you actually learn from the conferences the techniques. And that's very important for neurosurgeons. And the evolution has been the microscopic skills. Now we had a lot of very good skills, the endoscopic skills and the adjuncts, the imaging techniques. A lot of operative virtues you'll be learning here and today as well. So I welcome you all here, and I think we should continue the tradition of teaching. That is very important. Teaching the skills, teaching the limitations of your skills and the limitation of your personality as well. So we should not be we shouldn't become over ambitious after seeing the skills here. People have burnt their fingers, their hands, their forearms once they've done that, and don't think that if he can do it, I can do it. You will have to take time and expertise into it, and then you may not be burning your fingers. Learn from the experts here. Thank you very much.
Thank you so much, sir. I now would like to invite the chief guest of this program, Dr. Pavan, to present his address to the gathering.
Thanks, Sumit. But I think the real chief guests are all of you neurosurgeons. I think Indian doctors are maybe the hardest working doctors in the world, but I would say like neurosurgeons are the hardest working doctors among the doctors in India. So yeah, just take a moment for yourself because when I went from Osmania, like I did MBBS and then I went to Manipal to do general medicine. There I was struggling from morning 7 to next day evening 5 and again 7 to next day evening 5 and again. So every alternate day sleeping in the hospital and alternate Sunday only we used to have a little time off. I thought, wow, what is this kind of work? But then I happened to be across some surgery resident rotating in neurosurgery. So I said, what is your work schedule? So completely 30 days he was in the hospital itself. There were no off time. So then I felt better. Okay, somebody is worse than me, so I felt better. Okay, that's great. So, but amazing work you do. I don't know how the amount of work and the amount of hours and the complexity of cases. Like my own classmates are here, Venugopal and Srinath is here too. I did 5-year neurosurgery residency. I don't know how people do. I would have quit long time ago, but I think because of your amazing perseverance, I think because the kind of complexity required and the patience required is amazing. So great. We thank all of our team. Many people are familiar here. Dr. Anand, welcome back. We're missing you here. I think all the people were working hard. I'm not sure about Savit, though. He was, in his spare time, he's diving in Indonesia and Caribbean, and also, I don't know about the hard-working part of neurosurgeons. No, just kidding, but in your time you do, but you're also having a good schedule of time. To many of you neurosurgeons, I don't know how you find time. Dr. Rajesh here is doing amazing work in artificial intelligence. As if you're not busy in neurosurgery itself, he has time to think about how to attach the amputated limbs. And initially the plan was to open this Hitec Hospital with somebody who had like an arm attached, amputated with pure, before the Neuralink became famous with Elon Musk and all, Dr. Rajesh had already given this idea about 2 years before that too. So, and all of our Dr. Vijay sir has joined us recently, Dr. Nursing and all of our people, and Dr. Suri wonderfully said, but these kind of conferences, I would say, many of these things may be there in YouTube and all, but I think it's really, really important to have a discussion too. In theory is one thing and doing is a different thing is what I realized. Even during bronchoscopy and all, first they say, how do I do a bronchoscopy in US? Oh, imagine it's like a video game and that's it. It was not that simple, so it needed practice, and instead of on a real live patient, I think it's always better to practice on maniquees and videos and take the input a bit. Many of these practical tips will not be there in the textbooks, and also I think any kind of question, any kind of approaches. I picked up a lot in these kind of conferences where practical tips, and including how do you talk to patients. That's a very, very complicated art. How do you get more patients? So if you scare them too much, probably they'll not come and do a surgery. But at the same time, we need to tell about the risks of surgery and all. So I think that's a complicated arc. And this, amazingly, this kind of conference, all the leading lights of the country seem to be here. So it's in a small focused auditorium like this. I don't think you'll get an opportunity to ask questions or interact with all of these famous people here, and they are famous for a reason. So please, before you go, any kind of interactions, feel free. I'm sure everybody is open to share their knowledge. And skull base, I think this seems to be, must be the in thing in neurosurgery, because pulmonologists, they always used to intervention pulmonary and how to do those EBUS, bronchial thermoplasty, navigational kind of thing was there. And then as a critical care doctor, most of the interest was in ECMO and these kind of things. So, but skull base, I don't know too much about neurosurgery, obviously, but whoever I asked, almost everybody seems to be interested in skull base. So maybe that is the most advanced things or the in things. So I think it's great that all of you are attending a wonderful conference, because nowadays I'm only in my admin hat looking at what specialty has the best revenue, best EBITDA and all. And neurosurgery is and always will be among the top. So I think you're in a great field, and and I think the skull base also is in a good field to keep up to date with the latest. And thank you all. Once again, I'll not take too much of your time in this high quality sessions, and have a good one. And feel free to walk around the hospital too. This is our flagship hospital. And if you're wondering, this was supposed to be a DNA shape too in this one, and there was supposed to be a DNA monument in the front, but I think it did not work out exactly. So and in the hospital itself, we have ICU, I'll take a little credit in this ICU designing. We have some 200 individual room ICU kind, like US kind. There is no curtains and these kind of things. And OTs also, we had I think 30 plus OTs, all state of art. And this 7th floor here, we have private suite room. So out of town faculty was come. If you did not get hotels, or if you wanted a cheaper and better one, I think you can stay in the suite room, but just ask the nurse, don't bother checking my blood pressure and also. I think that's what people were commenting. So feel free to walk around the hospital and have a good time. Thank you.
Thank you so much, Dr. Pavan. Our next event is the felicitation of a very special person in the audience, Dr. Krishna Reddy. I would request the dignitaries to come off stage. While we get the stage ready, I'd like to invite Dr. Suchanda, Head of Department Neurosurgery, NIMS, to give us a small presentation about Dr. Krishna Reddy.
Good morning, Good afternoon, everybody. It's my privilege that today I've got the opportunity to talk about our dearest Professor Krishna Reddy sir. And I'll just start with a small anecdote. When I came from Delhi to Hyderabad to do my residency, the very second day when in this ocean full of male people, I'll say, that I entered and I was doing an EVD, the first thing what happened was that the twisted, the drill bit, the half rusted one broke off and went in the ventricle. As a young resident at that point of time, my only worry was what my colleagues would say, and I would be considered as not a competent candidate. I ran to sir at that point of time, and those comforting words which he gave me, nothing happens. It's okay, you go and carry on your work. So that respect which came in my mind when I was so distressed, I still remember, and I think I told to many people, and I hope I can give that comfort to the residents. I don't know I can do that or not. So with this, I would like to say that all of us who were trained under Krishna Reddy sir, we were all very blessed and fortunate because he has many rare qualities. And this is his biodata. He was born on the 5th of September, and what a great teacher was born on a Teacher's Day. In 1947, his parents were Ranga Reddy Garu and Saraswati Devi. Again, Saraswati is goddess of education, so a great teacher born to name-bearing a goddess of education. And he was had his schooling in Delhi Andhra School. His MBBS and MS were from Gujarat, and he did his MCH from AIMS. And his father was a border roads engineer, and probably the discipline in him came from that strict discipline which probably his father carried. And his neurosurgical career extended from Delhi to where he started in JB Pant, and then to Bangalore, to Nimhans, and then in between for a short period of time he was abroad in Libya. Then he came back to Hyderabad. And now, right now, he lives with his with ma'am, that is his wife, in Hyderabad. Son and daughter-in-law shuttles between USA and Hyderabad. So that's in just a little bit. I would like to play a video which we made by collecting some testimonials, whoever has given us. And I would like to thank all my colleagues who have contributed to this video. And bright as the sun, I would say, and he always remained peaceful. Whenever he sits, you see him, he's always calm and composed. Those were some of the pictures that is he on the right side as a young person, and then his marriage photos, and that is his current photos with his son, daughter-in-law, his son's marriage, and then of course his brother-in-law, who is a noted politician over here, and then his whole family we can see here. And then those are his some child, like older photos, retro photos, you can say, where with his son and other related family members he's driving. And I think he's making an omelette here, demonstrating the fact that he can cook as well. And then you can see, I think the child is very scared, and we were used to be scared of him in that particular photograph with his friends. And this is with his brother-in-law and his wife. And here you can see enjoying his family time with his brother-in-law and his wife. And so with one of his favorite friend, Professor Mohandas sir, and with Bhaskar Rao sir, and here this is his contented family with his son, and here we have Shastri sir speaking for him.
Of the Skull Base Society conference in Hyderabad is honoring Dr. Krishna Reddy. It's a very good gesture. I know Dr. Krishna Reddy for the last 40 years. As a colleague, he is a good administrator and a good surgeon. He is very helpful for the juniors and encourages them to hone their surgical skills. Dr. Krishna Reddy is, above all, a very good human being. I am very happy to be associated with him for so long. I wish him.
Those were his names there. Those were 2015 NS Icon in Hyderabad, where he was the organizing chairman with all the whole team who worked in that conference with the dancers in that particular NS Icon. And then a testimonial
I know
for
Professor
him from
Krishna Reddy since I was a resident at NIMHANS, Bangalore. Later, I worked with him at Nizam's Hospital and Kim's Hospital also. I like to tell few things which probably many of you do not know, because I have worked with the longest duration among all of you, amongst all of you. I'm grateful for having him as my mentor and hope to make him proud as I continue on my journey. When he joined at Nizam's in 1997, he always had futuristic ideas. He had thought of Gamma knife for Nizam's at that time, and he did not hesitate to order any equipment for the department. And at that time, Nizam's had the best equipment in the twin state of Andhra Pradesh. He had the ability to motivate people and bring out the best performance, especially in the workplace. I'm sure all of you will agree with me. I'm grateful for his guidance, both professionally and in organizing multiple conferences.
I wish him all the best for his neurosurgical development of neurosurgical programs, including becoming the future president of Neurological Society of India.
So this was the video done in 2019, and he had the ability to see the potential in a person that the person himself cannot realize. I never thought that I will be nominating myself for the president-elect, and because of his inspiration, I did that, and his wishes was fruitful for me. Though he pushed others to be in limelight, but he refused to receive the Lifetime Achievement Award and gave me the privilege to accept it on his behalf. He always pushed everybody in the department to go for press meet, but he always was there in the back door. I'd like to thank him for his mentorship and for helping me to become the best version of myself. Thank you, sir. Thank you for being with me
that
all
was
throughout.
Professor Manasa, who is unable to be present here. And this is Dr. Venugopal Reddy, who is a consultant in Hyderabad and a teacher student.
I was very fortunate enough to be associated with Dr. Krishna Reddy as a resident as well as an associate consultant in the early part of my career. He is a very pragmatic neurosurgeon. He is a complete volte-face to a typical neurosurgeon who is heading a university.
That's one of the NIMS exam.
I was asked by Dr. Narasimha Rao to kind of say a few things for the
Dr.
felicitation.
Reddy is a
Professor
consultant
Krishna Reddy,
in US,
sir. I'm
did from
personally
NIMS.
very sorry that I cannot be there. This is the time of the year when we're professionally busy. But what do I say other than the fact that you have been the most influential person in my life, as a young physician who just graduated from medical school. Other than knowing a few facts written in books, I don't think I knew much in life. I've learned a lot from you, from the simple fact that you always showed up for every conference on time, to being one of the most impeccably well-dressed, most respectful human being that you've been. You are absolutely a phenomenal role model for all of us, and I think at least from my standpoint, I give you credit for all the success I've had in my life, and also want to say personally thank you for being such an amazing influence for me, and I'm sure pretty much.
One word to aptly describe Krishna Reddy sir is God. There was this anecdote where Swami Vivekananda was in search of wise men to find an answer for his question, has anybody seen God? He finally found his answer in Ramakrishna Paramahamsa, who replied, yes, I have seen God like I see you and anyone else. Similarly,
hello everyone, I am Dr. Srinath, consultant neurosurgeon at Yashoda Hospital, Kopali. Today I am here in front of you to express my gratitude towards Dr. A. Krishna Reddy sir. Though I have had the opportunity to work under him only for the first 3 weeks of my neurosurgery journey, and I have had the privilege of being his last ever MCH student, I have had the knowledge of his era at NIMS and laid before me by my seniors. I have only seen my respect of him grow as I went ahead in my career, listening to his feats as a great human being and as a great neurosurgeon. I think I would be very fortunate to achieve a part of what he has done for his colleagues, peers, students and staff. I wish Dr. A.K. Reddy continues to inspire all of us as we move forward in our lives and careers. Thank you.
So here comes our organizing secretary, and let's see what he has to say for Krishna.
Namaste. My association with Dr. Krishna Reddy is in various forms, in various parts of my life. I was a resident to start with, later on became his colleague. He has always been my mentor, and later on I started seeing a best friend in him. Whenever I had some issues or problems in my life, whether it is professional or personal, he would be the first person to be approached for me. The best part in him is that he would advise what is best for the situation and what is best for me. There are many people down to earth, approachable, and gives the best advice whenever it is required and extends a helping hand.
Namaskara, this is Dr. Jagdish Chatnalli here. Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Gurave Namaha, Tasmai Shri Krishna Reddy Sir Namaha. Krishna Reddy Sir not only has taught the best possible neurosurgery to me, but also the great life lesson. You are a great teacher, Krishna Reddy Sir. I am very grateful to you. Thank you so much. Thank you.
I am Dr. Sonilal, practicing at Vijayawada. I am proud to say that I am one of the students of Professor Krishna Reddy Garu. He is a great man with great heart and good discipline. I owe my neurosurgery profession to him. I remember the words exactly said by him, that a donkey can be a neurosurgeon, but a neurosurgeon to become a human is very important. And that has changed my perspective towards life. I wish Professor Krishna Reddy Garu with long life and good health. Thank you very much, Krishna Reddy sir. Thank you.
Namaste to all the delegates. I am very happy to say a few words from my heart of heart that I had an extremely fruitful, assimilating relation with Dr. Krishna Reddy for more than 6 years out of 30 years of my right and left brain journey in the Nizam's Institute of Medical Sciences. An assimilating relation, I mean he, as my immediate senior colleague, never posed himself on me. We went ahead hand in hand to develop the department for a greater cause. I would like to mention that we were seriously happy in the department. At the same time, we were jovially happy outside the department too. This relation still continues even after we not working at the same place in Hyderabad. I must acknowledge today an instance of his jovial way of delivering the qualities of heart. In one of the conference in Rajasthan, during gala dinner party, I was standing with my wife and suddenly we heard a long sharp whistling sound from behind. We both turned to see a man with 2 fingers pressed between the lips was walking towards us. This was Dr. Krishna Reddy. Dr. Krishna Reddy's intentions at that moment were, let my wife feel elated, happy and young when she was facing an extremely challenging convalescence phase of her severe head injury. Thank you, respected Dr. Krishna Reddy. I salute you with great gratitude and will remember you till I keep breathing on this planet. Wish you a very happy, healthy, another 101 more years to come with your family and with we, the extended family of yours, the neuroscientists. Namaste. Thank you.
Working in MSICU, in that time, Dr. Krishna Reddy garu Nizam's Institute of Medical Sciences ki neurosurgery head కింద వచ్చారు. ఆ రోజు నుంచి ఆయన తర్వాత నేను థియేటర్కి రావడం జరిగింది. అక్కడి నుంచి ఆయన ఎట్లా చేశారంటే అంత సపరేట్ స్టెరైల్ టెక్నిక్ కానీ ట్రేస్ సపరేట్ చేయడం కానీ, అంటే ఎవ్రీ టేబుల్ దే ఆర్ గెటింగ్ సపరేట్ ఇన్స్ట్రుమెంట్స్ అండ్ ప్రాపర్ ఇన్స్ట్రుమెంట్స్ చేశారు. తర్వాత సర్జరీస్ కూడా సిట్టింగ్ పొజిషన్ అన్నది ఫస్ట్ సార్ చేయడం ఎక్కువ కేసెస్ ఆయన ఎక్కువ చేయడం మొదలుపెట్టారు. ఆయన సిట్టింగ్ పొజిషన్లో అసోసియేటెడ్ ఎస్పెషల్లీ అసోసియేట్ కేసెస్, సబ్ హాస్పిటల్ క్రేనియోటమీ కేసెస్ చేయడం మొదలుపెట్టారు. తర్వాత ఆయన కొన్ని రోజులకి సారు కిమ్స్కి వెళ్ళడం జరిగింది. అదే ప్రోటోకాల్ మేము ఇప్పుడు వరకు మేము ఫాలో అవుతున్నాం.
You always spoke the correct thing and always advised the correct thing and always
to a great dad and
That's his son and daughter-in-law.
And I just want to reach out from here saying congratulations on 50 years of great work. I think it's time for you now to soak in all these accolades and enjoy the rest of your retirement. Really proud of you, Dad. I know how much neurosurgery has meant to you and how much you dedicated to this. And I'm sure everybody around you really appreciates what you've done.
Hi, Kitty Mama. Wish we were there to celebrate with you. Like Amit said, we're just so proud, and it's so nice to see you be recognized for the work that you've done. I know you've taken great satisfaction in the work that you've done over the years, and you've been good at it, and you've moved the field forward. So we're just really, really proud, and wish we could be there.
Okay, love you. Bye.
And here comes Madam, who sums up everything about Sir. And with this, we'll end up.
Little nephew came running to me, a 4-year-old, saying, "Atama, you know what Kittu Mama said?" He said, "His wife is his life." But today, after 47 years of our togetherness, I still feel neurosurgery is his life. I would just like to tell you a little about his dedication towards his profession and his punctuality. You see, he would rather miss his breakfast and to be on time at the hospital even before his juniors or his seniors arrive. That is his punctuality, and I'm proud of that. Profession-wise, he never consulted me regarding his shifting of places or hospitals. Like from Delhi, we came to Bangalore. From Bangalore, again we went to Libya. From Libya, we came back to Bangalore. But the only time he consulted me was when he decided to shift to NIMS, Hyderabad, because he loved teaching. And perhaps another thing was because of the financial restraint we are going to have once we come here, because he was at the peak of his practice in Bangalore. But no regrets so far. Everything has been fine in NIMS. His passion for teaching, he could achieve that. And I'm very proud when some of his students come and say that they have been very happy with him. Like one Dr. Praveen, a couple of days back, he was here. He visited us and he said that today, madam, still I practice what doctor preached and taught us in the hospital. So I feel very proud of him, and we are very happy also. Dedicated to his profession, he was still a family man. Once at home, it was family, friends, and relatives. He loved entertaining anybody. And today, even today, he still gets me groceries from Kumar, from Ratati, etc., etc.
That's, I think,
So I'm
everyone should
really
invite,
proud
that he
of
still
him
gets
and
groceries at home, and that's the high point I would like to say.
it is because of you students he is there today. Because he told me this morning, I'm going for this function because of my dear students. So that was Dr. Krishna.
Guru Brahma, Guru Vishnu, Guru Devo, Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Gurave Namaha. Guru Brahma, Guru Vishnu, Guru Devo, Maheshwara,
love you, sir, and stay happy and
Parabrahma.
Thank you, madam, for that wonderful presentation. I would request the chief guest and the executive committee and the local organizing committee to take the stage to felicitate Dr. Krishna Reddy. I also would like our organizing secretary, Dr. Narsingh Rao, to accompany Dr. Krishna Reddy to the stage. I invite our chief guest to drape the ceremonial shawl and felicitate Dr. Krishna Reddy. I also invite the President of the Skull Base Society of India to give President Dr. Krishna Reddy a small memento from the society. I request the audience to give Dr. Krishna Reddy a standing ovation for his amazing career and for the wonderful human that he is. We will break for lunch. Lunch is served outside. I request everybody to be back here by 2 so we can start the afternoon session on time. Thank you. But just before we leave, I invite the organizing secretary to present his vote of thanks, after which we will break for lunch.
Yeah, I'll be quick and I won't take much time. First of all, let me tell you that I'm thankful to all these people. It's only the order which I have selected to not to forget, but all have equally contributed and I want to thank them all. So first of all, I would like to thank Dr. Pawan, who is our dynamic director of the Yashoda Hospitals, who is young and energetic and who always inspires us to do the best work and the best work possible in the respective fields. And I really appreciate him for the kind of freedom which he has given in organizing this kind of event for me. Though I joined less than a year here, I'm able to do this because of his support. And Dr. Pawan has always been supportive. We don't get time to talk to him. But whenever I could meet him, he has always been supportive about my ideas and my thoughts and whatever I had, he was always been supportive. Next, I would like to thank Dr. Krishna Reddy, who, despite his busy schedule, and many times I know personally that many of my seniors have called him for felicitation. He has never accepted, and I really thank him for giving us an opportunity. It's a matter of honor and a privilege for us to felicitate Dr. Krishna Reddy. I thank him for giving the opportunity that we could do this to him. And I like to thank Skull Base Surgical Society, who has given an opportunity for me to do this interim Skull BaseCon. Especially I should mention Dr. Suri, Dr. Rupesh. I know Rupesh, I have disturbed him in the middle of the night several times to how to go about this program. He was continuously answering with all the questions patiently. I thank him for the I thank him as well as the entire society for giving this opportunity to do this interim con. Next, I would like to thank our COO, local COO, Dr. Srinivas Reddy, who starting from the starting of the account for this program, every time he was checking me, everything is fine, everything is going okay. So that kind of a support, what he gave was remarkable, and I thank him for all that support. Then the organizing committee members, local organizing committee members, BJ Rajesh, Ravi Suman, of course myself, I have to thank myself for doing this event, and also then our marketing team, are especially not to mention the least is our residents, our students, DNB students, Dr. Sharavanan and Shrikant and Vijay Kumar have helped me a lot, and I want to thank them. And not the least is the audience who took all the time in the weekend on Saturday to gather in large numbers and make the event successful. And most importantly, the backbone of the entire event is the financial support by the pharma companies. I would like to thank Sun Pharma, as well as Intas, Manman, AVM, Medtronics, Starch, and few other companies, MSN Pharma. So all these companies, I want to thank them for their timely support, financial support, as well as helping in the executing the event in a big way. I thank every one of you to make this event a big successful. Thank you. We can go for lunch. Lunch is available. Lunch is ready. Thank you.
1 2 check 1 2
జస్ట్ ఇక్కడ కూర్చున్నా కానీ మనము ఆ మైక్ అడ్జస్ట్ చేసుకోవాలి. ఆ మైక్ ఇప్పుడు దేనికి పెట్టు
Should I display all these things?
Only this thing, only the logo. Only Sky Society.
Is it done? Is it done? I'll just.
Thank you.
హలో మైక్ టెస్టింగ్ 1 2 3 అరా హలో హలో ఓకే నమ్ము కదా క్లారిటీ వస్తుంది కదా ఒకసారి బయటికి వెళ్ళి ఒకసారి ఒక్క నిమిషం సార్ నీ వాయిస్ రావట్లేదు ఇక్కడ ఏ రాలేదే మనకు స్పీకర్ కావాలి కదా अना मेरे माइक आप माइक म्यूट करो ना एंथोनी जी को अभी वो दे दो ना ऑलरेडी पैनलिस्ट లో ఉన్నాడు ఓకే ఓకే एंथोनी నా వినిపిస్తుందా క్లియర్ గా
హలో శరత్ ఓకేనా ఆడియో
yes అన్న క్లియర్ గా ఉంది ఆడియో మాది క్లియర్ గా ఉందా అన్న ఇక్కడ ఆడియో
మీది క్లియర్ గా ఉంది మీ మీ ఇమేజ్ నాకు రావట్లేదు నా ఇమేజ్ మళ్ళీ ఏ అని వస్తుంది ఇమేజ్
అన్న ఇది
మీ ఇమేజ్ పెట్టమని
అదే అదే వీళ్ళు వెబినార్ లో మీకు అది యాక్సెస్ ఇవ్వాలన్నా
కాదు ఇక్కడ ఏమైపోయింది తెలుసా ఇట్లా పెడితే ఇప్పుడు ఇప్పుడు నువ్వు మాట్లాడు
వినిపిస్తుందా అన్న
అదే నువ్వు ఎట్లా అంటే ఇప్పుడు ఆడియో ఒక దాంట్లో కనెక్ట్ చేసినావు వీడియో ఒక దాంట్లో కనెక్ట్ చేసినావు జూమ్ ఎట్లా తీసుకుంటది అంటే ఆటోమేటిక్ తీసుకుంటది ఎవరు మాట్లాడితే వాళ్ళ సైడ్ వెళ్ళిపోతుంది అనమాట
ఇప్పుడు
అర్థమైందా
జూమ్ లో ఒక ఆప్షన్ ఉంటుంది అన్న జస్ట్ పిన్స్ చేసుకునే ఆప్షన్స్ ఉంటాయి అన్నమాట
అదే ఇప్పుడు నీ వీడియో కెమెరా ఒక సోర్స్ లో ఉంది ఆడియో ఒక సోర్స్ లో ఉంది
సరే
నువ్వు మాట్లాడితే ఆడియో వీడియో ఒక్కదంట రాదు ఇంత ముందు ఉన్నదే బెటరు ఇప్పుడు నేను మాట్లాడుతున్నప్పుడు నీ వీడియో కనిపించట్లే నేను సైలెంట్ గా ఉన్నప్పుడు నీ వీడియో కనిపిస్తుంది
ఇప్పుడు కనిపిస్తుంది చూడనా
ఇప్పుడు ఆడియో వీడియో రెండు కనిపిస్తాయా
ఇప్పుడు నీకు కనిపిస్తుందా నా ఆడియో నా వీడియో కనిపిస్తుందా
ఓకే ఇప్పుడు ఓకేనా
ఓకే
ఇప్పుడు ఆడియో వీడియో ఓకేనా
ఓకే
ఓకే ఇప్పుడు ఇట్లా ఉండాలన్నమాట
అదే ఇది స్పాట్లైట్ ఫర్ ఎవ్రీవన్ పెట్టినా అట్లనే ఫారెన్ గెస్ట్ జాయిన్ అవుతాడు కదా జాయిన్ అవ్వగానే అతని గిట్ట స్పాట్లైట్ ఫర్ ఎవ్రీవన్ పెట్టేస్తే ఆ 2 వీడియోస్ మన ఎక్స్టర్నల్ కెమెరా ప్లస్ ఫారెన్ ఎక్స్టర్నల్ కెమెరా రెండు సైడ్ బై సైడ్ గ్యాలరీలో వచ్చేస్తాయి
ఇట్లనే ఓకే
ఓకే అన్న రైట్
ఓకే ఇది పర్ఫెక్ట్
ఇప్పుడు ఇంకోళ్ళని నువ్వు కెమెరా ఆన్ చేసినావు కదా నేను గిట్ట స్పాట్లైట్ పెట్టేస్తా ఇప్పుడు ఫుల్ స్క్రీన్ వచ్చింది కదా
ఫుల్ స్క్రీన్ అయినది వెళ్ళింది అది ఆడియో సైడ్ వెళ్ళింది ఫుల్ స్క్రీన్
ఇది సామ్సంగ్ ఎవరు ఆడియో
అంటే వేరే పార్టిసిపెంట్ ఏమో ఇప్పుడు మనం ఇద్దరమే ఆడియోలో ఆన్ ఉన్నాం
ఓకే ఓకే అన్న ఇప్పుడు స్క్రీన్ షేర్ చేసి చెక్ చేస్తా చూడనా
చెక్ చేయి
మీరు షేర్ చేస్తారా ఏమన్నా స్క్రీన్
నేను స్క్రీన్ షేర్ చేయాలా
ఇది జస్ట్ ఏంటంటే ఎవరన్నా మన కెమెరా అంతా జూమ్ అవుట్ అవ్వదని మనం ఎక్స్టర్నల్ కెమెరా పెట్టేసి స్పాట్ లైట్ పెట్టి చెక్ చేస్తున్నాం అన్న
ఓకే ఒక స్క్రీన్ షేర్ చేసిన చూడు
ఓకే ఇప్పుడు వచ్చిందన్న మాకు వ్యూ వచ్చేసి ఓకే ఓకే అన్న మీ ప్రజెంటేషన్ కూడా కనిపిస్తుంది మాకు ఇప్పుడు ఒకసారి నువ్వు మైక్ మ్యూట్ చేసే లోపల రాను అట్లనే పోడియం ల్యాప్టాప్ అయిపోతుంది
Good afternoon. We'll be starting the afternoon sessions shortly. This is an online presentation from Dr. Goto from Japan. I have a couple of housekeeping announcements to make before that. The Skull Base Society has a stall right next to the registration stall. If anybody would like to become a member or register for next year's conference, that's the place to go to. And for the Zoom sessions, we have two of them. The first talk will be by Dr. Takeo Goto on extended endonasal approach to skull-based lesions. I request anybody who has questions at the end of the talk to come up to the podium, or at least to the front of the podium, and ask the questions there so the camera can capture what is happening. So we will start sharp at 2 o'clock.
Hello. Hello.
Yes, Dr. Goto, we can hear you.
Yeah,
If you
yeah.
can turn on your
Yeah.
camera and start your presentation.
Okay.
Good afternoon, Dr. Goto. You're on mute and...
Okay. Can you hear me?
Yes, sir.
I already sent my recorded video to you, so please start our video.
Yes, sir.
Hello, can you hear me?
Yes. Hi,
Okay.
Atul.
Yeah. So I have to introduce you, my dear friend.
Thank you.
Takio Goto is the professor and chairman of Osaka City University Hospital Department of Neurosurgery. And this hospital is a very famous hospital in Japan and in the world because of his predecessors. One is, you might know, Dr. Ohata, Kenji Ohata, who was one of the very prominent skull-based neurosurgeons of the world. And then before that, Dr. Akira Hakuba, who was a pioneer skull-based surgeons. And if you know that he introduced Petrosectomy approach, he introduced orbitozygomatic osteotomy, he introduced several things in cavernous sinus surgery. And now Dr. Goto has taken a step further from skull-based, purely microscopic neurosurgery. He has introduced endoscopic neurosurgery and minimal invasive transcranial surgery. And of course, his work is based on a lot of anatomy, lot of dissections. And I'm sure every one of us listening to you, Professor Goto, will enjoy what you have to tell us. And are we ready to put? So we still have 2 minutes. In the meantime, Dr. Goto, you want to say some nice words to the people who are watching you?
Thank you, Professor Atul, for kind introduction for me. Today, I of course feel very honored to present my work in front of many friends of Indian neurosurgeons. And today, my topic is about the surgery to skull-based tumor. As Professor Atul already introduced, I use both techniques of the skull-based surgery, microscopic surgery and also endoscopic surgery. In some situation, endoscopic endonasal approach very useful to resect the skull-based tumor, especially central skull-based tumor. So today, I will show my several surgical technique and concept to central skull-based tumor. This is my comment to this presentation. Already the prepared of my recorded video or not?
Yes, they are running it. Just hold on. So Dr. Goto is now a very famous man in India. I saw him recently. Where did I see you, Goto, recently? Yeah, in Mumbai Endoscopic Conference. And then also I saw him somewhere else recently. I think in China I saw him 2 weeks ago. So he's traveling and quite a bit. And he's, taking the legendary Osaka City Hospital department further. Professor Hakuba, many of you may not know because many of the people here in the audience is very young audience. But Hakuba was one of the big pioneers of skull-based surgery. And he used to, all the time thinking about various concepts, cavernous sinus. he was dissecting the fish cavernous sinus. Goto, you know, he used to dissect cavernous sinus of the fish. Professor Hakuba? No, he cannot hear. He used to dissect the cavernous sinus of fish, and also I must tell you that he was very close to me. He was many years senior to me, of course, and many memories I have about him. He was a great friend of India. Like Goto, many times he used to come to India. Like Ohata, he's a boss. Also,
Goto has taken over. So Ohata's retirement, Goto has taken over, I think.
yeah, after Ohata retired, Goto is the professor and chairman. And Ohata is organizing Indo-Japan Society Friendship Meeting, where Goto is also coming in August. Dr. Shastri, of course, is one of the founder members of this society, and he has to be there, there is no question. Manas Panigrai, Manas is also one of the big participants of Indo-Japan Friendship Society. Then there's many senior Indian neurosurgeons. We will have to showcase our work. So here we start with Goto's presentation. Go ahead. Play.
I'm Takeo Goto from Osaka, Japan. Today I feel very honored to have the opportunity to present my work in front of many friends in India. At first I will share my slide. I'm Takeo Goto from Osaka, Japan. Today I feel very honored to have the opportunity to present my work in front of many friends in India. Okay, today I will share my slide. Extended endonasal approach to skull-base regions. Endoscope recently. I'm Takeo Goto from Osaka, Japan. Today I feel very honored to have the opportunity to present my work in front of many friends in India. Okay, I will share my slide. Extended endonasal approach to skull-base regions. Classical microscopic skull endoscope recently. I'm Takeo Goto from Osaka, Japan. Today I feel very honored to have the opportunity to present my work in front of many friends in India. Okay, I will share my slide. Extended endonasal approach to skull-base regions. Classical microscopic endoscope recently. I'm Takeo Goto from Osaka, Japan. Today I feel very honored to have the opportunity to present my work in front of many friends in India. Okay, I will share my slide. Extended endonasal approach to skull-base regions. Microscopic.
Professor Goto, can you present from your laptop? There's some audio issues here. Is it possible? Professor Goto, can you unmute yourself? Are you able to hear us? No, they're meeting. That hall. But that is showing as mute. Okay, Professor Goto, can you hear us?
Yes.
Yes. There is some problem in the audio here of your recorded version. Can you present from your laptop?
Yeah. I can present at in using my laptop.
Yeah, please.
Is it okay?
Yes, yes, Professor. Please.
Okay. Can you hear me?
Yes, Professor. Just change to Zoom.
Can you see my slide?
Yeah, one minute, Professor. Yes, we can see.
Can you see my slide?
Yes, we can see your slide and we can hear you.
Okay.
Yes, Professor. Thank
so
you.
that today I will explain our extended endonasal approach to skull-based tumors. Endoscope recently can offer the panoramic wide and clear view. So to some central skull-based tumor, endoscope can offer very good view. For example, if we see the central skull base through the endoscopic endonasal route, central skull base looks like this. The only obstacle to the central skull base is bony structure such as Clival's pterygoid process or Petrosectomy bone. So if we just master the drilling technique to expose the skull base, we can directly access within this circle without any retraction of the cranial nerve and vessel. I will show the several cases of our endoscopic endonasal approach. This is a retrochiasmatic craniopharyngioma. In case of the craniopharyngioma, endoscope can offer the direct view within the circle of Willis, and also sometimes the posterior clinoid process can be the obstacle. So if we drill out the both posterior clinoid, we can widely expose around this area. So I will show our surgical video. Already the bony structure around the cella floor was drilled out, and this is a posterior clinoid process. I carefully drill out the posterior clinoid and dorsum cella. And then we gently retract the pituitary gland from the medial side of cavernous sinus. And then we go into the subdural space. Using the endoscope, we can directly go within the circle of Willis. So in this view, all critical structure is surrounding the tumor. So it's relatively safe and easy to confirm the border between tumor and pituitary stalk or optic chiasma or perforator from ICA. So we perform the careful dissection from the surrounding structure using the whole hand technique. We use the 3 instruments to dissect the tumor. And finally, all tumor was nicely dissected out like this. This is another case of the craniopharyngioma occupies the third ventricle. I used to the interhemispheric approach to reach the third ventricle, but recently I use also endoscope. This is our surgical video. Our procedure almost same. I widely drill out the bony structure around the cella floor, and then this is the dorsum cella. I drill out the dorsum cella like this and remove the posterior clinoid. To master the bone work, we can get the very wide view around the central skull base. After that, I cut the dura and expose the pituitary gland like this. And then we mobilize the pituitary gland from the medial wall of cavernous sinus like this. And then we can go into the subdural space. Using this approach, we can observe the clear border between the pituitary stalk and the tumor, so we can carefully dissect the tumor from the pituitary stalk. So we understand that to the region around the cella turusica, endoscope can offer good view to between the tumor and critical structure. And finally, all tumor was nicely dissected out, like this. This is a pituitary stalk and PCOM also confirmed. Postoperatively, pituitary stalk and gland was anatomically preserved, and we can prevent the DI. But in case of the craniopharyngioma, even preserve the gland and the stalk, but we need additional replacement to control the hormonal condition. This is another case of the also large craniopharyngioma, occupies the third ventricle and posterior fossa, and the central part was calcified. But endoscope also can offer the good view to the around the cella area. So our surgical procedure is the same. I use the endoscopic endonasal, extended endonasal approach, and mobilize the pituitary gland and perform the tumor removal. The central part was calcified, but QSA was very effective to perform the internal decompression. And finally, we perform the careful dissection. And this is the floor of third ventricle, and remove the old tumor like this. To prevent the CSF leakage, we put some suture to dura mater and put the fat tissue to subdural layer to prevent the CSF leakage. So suture and finally cover the large septal flap is also very useful to prevent the CSF leakage. Postoperatively, all tumor was safely resected out. In addition, we can preserve the pituitary function in this case. So, to resect the various kind of craniopharyngioma, bilateral posterior clinoidectomy was very useful. We published the technique to JNS. This is another case of the diaphragmacellar meningioma. Attachment of the tumor is diaphragm. So attachment is here. So endoscopic endonasal approach also very useful to directly access the attachment of the tumor. I mobilize the pituitary gland and observe the attachment of the tumor. After detach the tumor, we can carefully dissect the tumor like this. Endoscope can offer very good view around the cella turusica, so we can finally resect it out all tumor, and then we perform some suture to dura mater. I put the fat tissue to the subdural layer and put some suture to fix the fat tissue. We make the knot outside the nostril and then slide in the knot to the deep area, and finally cover the mucosal flap like this. So, tumor was nicely resected with preservation of her function. How to make the knot outside the nostril and slide in to deep-seated area, also very good technique to prevent the CSF leakage. We published the technique to World Neurosurgery. If you have the interest, please check this paper. This is another case of the tuberculum meningioma. Of course, I prefer to use a transcranial approach to the tuberculum meningioma, but some case attachment was small. In such situation, also endoscope was very useful. After drill out the old bony structure around the tuberculum sera, we can cut the dura like this. Tumor was already devascularized because attachment of the tumor was a tuberculum sera. This is a pituitary gland and this is a tuberculum sera. So after completely detach the tumor, we can just dissect the tumor from the optic chiasma or optic nerve. If attachment was tumor was small, in such situation, endoscopic endonasal approach also very useful technique to resect the tumor totally and decompress the optic nerve like this. Of course, we need the same technique to prevent the CSF leakage. But if you master this technique, we can also apply this endoscopic technique to some kind of tuberculum meningioma. Tumor was nicely resected. This is another case of the posterior clinoid meningioma. Attachment of the tumor posterior clinoid. So in such situation, also endoscope was very useful. This is a pituitary gland, and this is a cavernous sinus, and this is a posterior clinoid process. Attachment of the tumor was posterior clinoid. So after remove the posterior clinoid, we can directly reach the attachment of the tumor. Then finally all tumor was resected. This is another case of the Clival meningioma. If we choose the lateral suboccipitال approach, we have some risk to damage the lower cranial nerve. And then if we choose the anterior transpetrosal approach, we have some risk to damage the sixth nerve. But if we choose the endoscopic transclival approach, we can directly access the origin of tumor. So I perform the endoscopic transclival approach. I prefer to use the transcranial approach to the petroclival meningioma, but if attachment of the tumor is pure lower clival area, in such situation, endoscopic endonasal approach was one of the options for safe resection of the tumor. Brainstem nicely decompressed. Also, we can reach the medial side of sixth nerve and seventh and eighth nerve. And finally, all tumor was nicely resected out through the endoscopic endonasal route. This is another case of the lower clival meningioma. I skipped the surgical video, but tumor was nicely resected out. So we measure which area or where we can reach through the endoscopic endonasal approach using the voxel-based region mapping using the MRI. Red area show we can reach this area by the endoscopic endonasal approach. So attachment of the tumor is around here. Endoscopic endonasal approach will be very useful option. This is another case of the cavernous sinus chondrosarcoma. The tumor looks occupies the cavernous sinus, but actually attachment of the tumor is the inferior wall of the cavernous sinus. So endoscopic endonasal approach, very reasonable procedure. So I choose the endoscopic transpterygoid approach to reach the inferior part of the cavernous sinus. We expose the tumor like this and careful dissection. This is a carotid artery and this is a tumor. Using the endoscope, we can directly access the origin of tumor. Access the origin of tumor is a basic concept of this approach. So we can carefully resect it out all tumor like this. We can preserve the carotid artery like this and resect the tumor totally. This is a post-op. Tumor was resected out. This is another case of the cavernous sinus chondrosarcoma. Some part was very calcified, but concept is the same. We use the endoscopic approach. We can directly access the inferior wall of cavernous sinus. So we can safely resect it out. We skip the surgical video, but resect the tumor very nicely, and we can preserve all the neural function. And this is another case of the carotid sympathetic plexus schwannoma. Tumor occupies the inferior part of the petrous carotid artery, but if we choose the endoscopic endonasal approach, we can directly access the attachment of the tumor and we can safely resect it out tumor. How to expose the cavernous sinus? How to expose the carotid artery? Of course, some technical tip. So we publish this technique to also World Neurosurgery. This is another case of the lobulated pituitary adenoma. Some tumor protrude to the subdural space through the superior wall of cavernous sinus. When tumor extend to the subdural space through the superior wall of cavernous sinus, always the tumor protrude through the oculomotor triangle. So I usually cut the diaphragm like this and then cut the intercrinoid ligament to open this foramen. After that, we can safely resect it out the tumor. Now, this is a surgical video. Cell part already removed. And this is the tumor in the cavernous sinus. I completely resect it out. And this is a carotid artery. This tumor protrude to the subdural space through the oculomotor foramen. This part was the oculomotor foramen. I cut the diaphragm like this. And then I cut the intercrinoid ligament very carefully. This is the intercrinoid ligament. I cut this ligament. Like this. After cut the ligament, we can open the oculomotor foramen and then remove the tumor like this. So opening the oculomotor foramen was a nice technique to remove the tumor, extend to the subdural space. I finally hold tumor nicely using this technique. Tumor was totally resected. This is another case of the cavernous sinus meningioma. I skipped this video, but also use the same technique and remove the almost tumor through the endoscopic endonasal route. So the opening of the oculomotor foramen is very useful to resect the tumor in the subdural space. I also published this technique to World Neurosurgery this year. So, of course, endoscopic endonasal approach now the new procedure, and we need the additional modification for safe resection of the central skull base tumor. But in to some skull base tumor, endoscopic endonasal approach can be very effective procedure for removing the skull base tumor. Thank you for attention. Sorry, today my recorded video did not work well, so I used my laptop. Connection, I'm not sure connection is good or not, but I hope my concept will send to you. Thank you.
Thank you, Dr. Goto. That was a fantastic presentation. I think the problem was at our end, and we apologize for that. If there are any questions, I would request whoever wants to ask a question to come up in front of the podium and ask any questions.
Dr. Goto, can you hear?
Professor Lau.
Hi, thank you. See this bloodless field, what I see in your surgeries, they are very conspicuous. So can you highlight the techniques by which you manage this totally bloodless field, crystal clean videos? How do you do that? How do you?
Sorry, your voice is a bit small, so I cannot catch. What do you say?
Yeah. Can you tell us how you develop this kind of a bloodless field during your surgery? Totally avascular.
Thank you. Usually, of course, we perform the careful stop of the bleeding step by step. But most important part is the nasal part. I usually make the bloodless field through the nasal part. It's very important. I use adrenaline-soaked gauze to contract the vessel around the nasal mucosa. It's very important step for bloodless surgery in case of the endoscopic endonasal approach.
Professor, it was an excellent video demonstration. As usual, we enjoyed in your regular conferences of endoscopy and skull base. Yet another marvelous technique. We want to know, how do you dissect the cavernous sinus? You showed the lateralization of pituitary gland. And so how do you manage the cavernous sinus bleed?
Thank you. At once, of course, we have to understand the anatomy of the cavernous sinus. When for example, when we plan the mobilization of the pituitary gland, in case of the craniopharyngioma, cavernous sinus is usually intact. So don't open the medial wall of cavernous sinus. If you open the medial wall of cavernous sinus, you encounter some venous bleeding. So it's very difficult to find out the border between the medial wall and the pituitary gland. So we widely anyway open the, makes a wide surgical space after drilling out the all bony structure around the cella floor, and also anterior and inferior bony wall of cavernous sinus should be drilled out for smooth mobilization of carotid artery and pituitary gland. In such situation, we can detect the intact medial wall of cavernous sinus and carefully dissect the gland from the medial wall. In such situation, we did not encounter venous bleeding. So as present today, we make the very bloodless field or mobilization of pituitary gland. It's my idea. Thank you.
Yeah. how do you handle the inferior hypophyseal artery? From the carotid, usually you get into the, how do you coagulate and divide that?
Yeah. To mobilize the pituitary gland, we have two methods, epidural procedure and intradural procedure. If we dissect the pituitary gland from the epidural space, we not need the coagulation of the inferior hypophyseal artery. But if we just use the subdural procedure, I mean when we go into the cavernous sinus, we have to coagulate the inferior hypophyseal artery around the posterior part of the pituitary gland. So, of course, anyway, the anatomical understanding is very important.
Thank you very much. We would request you to show that video next time. How do you do that? That will be very useful for all of us. Thank you very much.
Okay.
Yeah.
Sorry that today my video was not good.
Thank you so much, Dr. Gatto. It was a fantastic presentation. See you, sir. I now request Dr. Dwarkanath, Professor and Head of Unit in Neurosurgery of NIMHANS, and my teacher, to give us the next presentation on microsurgical approach to central skull-based lesions.
Thank you, and huge thanks to Narsingh Rao, my friend, my colleague for so many years, for a wonderfully organized meeting and for inviting me also. So I was thinking what to speak, and then finally I settled down on this one, clinoidal meningiomas and medial sphenoid wing meningiomas. Why? So these are among, in neurosurgery there are 2-3 tumors which are really tough, and on the top two lies the Petroclival and the clinoidal meningiomas, primarily because more than the nerves, the vessels are completely encased by these tumors many a time, and dissecting not only the major vessels but also the perforators, the veins, is a very important ask, otherwise you will end up with significant deficits. So this is the anatomy of the sphenoid. Of course, you have the greater wing, the lesser wing, which goes into the anterior clinoid process here. You have a pointer, huh? Point. And so the traditional classification of Almefti was the type 1, type 2, and the type 3. And this was further here, huh? It's coming? Okay. Okay. So this is the type 1, the type 2, and the type 3. So this, we have Professor Goel here, and the problem with this was, of course, the encasement of the vessels, which had a direct impact on the extent of excision. And if you see Sir's paper here, you can see that once the ICA becomes encased and narrowed, the total excision actually comes down. And the ones which are not encased or which are just lying on the surface, it is easier to remove them totally. So the various classifications have been given based on visual involvement and extent of tumor resection, based on tumor size and resection, and based on the carotid anatomy on angiogram. So then I came across this paper, which is a very nice classification of the types of clinoidal meningiomas, which are from type 1 to type 4, and depending upon the origin where they arose. The whole idea is, even though the clinoid is even though it's a small organ, depending upon small bone, depending on where it arises in relation to the ICA is involved accordingly. So some clinoidals may not involve the ICA at all. What we used to classify the medial sphenoid wing meningiomas before, but all of them have been brought together into the clinoidal meningioma category, but with differentiation, because some of them do not encase the carotids, while the type 4 always encase the carotids, and also the branches of the carotids depending upon the size. So this is the clinoidal type 1. If you can see, the base is narrow, it's arising directly from the clinoids. This is a relatively, can we go back to that? I cannot use the fast forward in this. I cannot, this one doesn't come in. I'll have to take out that. You take out the laser pointer. Remove the pointer and go back, because that you cannot fast forward it otherwise. Okay. Yeah. So this is the type 1 medial sphenoid wing meningioma, or the type 1 clinoidal meningioma. So the first step, of course, what I do is I always do a extradural clinoidectomy, and then follow it up with a certain amount of peeling of the anterior of the dura from the cavernous sinus, or basically what we call the anterior transcavernous approaches. Take out the take this out, because what it does is it gives you a good visualization of the extradural ICA, and as well as then you come back, then you open the dura, open the Sylvian fissure, follow dissect from outside to inside. I'll just quickly run through this video. This is the tumor which is being devascularized, and these are relatively safer because they do not encase, or not very do not encase the ICA, so they're little easier to dissect. And this is the tumor being mobilized, and you can see it's completely devascularized, and this is the ICA over there. This is the optic apparatus. So you see, once this is done, you can just go around the tumor, do a decompression of the tumor. This tumor is very hard, so we have to use loop cautery. And these are the final dissections where you have to sharply dissect them from the ICA and its branches. You have to be careful. Mere pulling of these vessels will cause it to rupture, especially the vein. So you need to have a sharp dissection, take a bit of the arachnoid away from that. And this is the tumor. You can see it's attached to the MCA over here. And because they're not encasing, the main attachment is due to the arachnoid, so which can be sharply dissected and cut. And then the this is from the last bit of the tumor, which is from the ACA, and the tumor is out. So these are the easier type of tumors. I mean, you can get gross total excision most of the times. Again, type 2, again, even though they appear quite scary, in fact, most of them are completely removable, primarily because the ICA is not encased. Similarly, type 3, again, can be removed. Here you can see the ICA not being encased. These are some of the type 3 clinoidal meningiomas. But what is really difficult are the type 4 images, in which you can see the ICA is completely encased inside the tumor. Not only the ICA is also narrowed. It is irregular and displaced. And apart from the ICA, the branches including the MCA and the AC are also inside the tumor. So these are the difficult type of tumors. So again, what we do is, I do a large FTOZ, either 1 piece or 2 piece, and then again you peel the dura of the cavernous sinus. So why is this step important? This step is important primarily because it gives you a good view of the cavernous sinus as well as the clinoidal segment of the ICA from outside, and also gives you orientation as to the optic nerve where it is. So these are fixed landmarks. So when you are going from outside to inside, the optic nerve is not a fixed landmark. You don't know where it comes, so you are blindly searching it. So if you come from the other side, the optic nerve and the ICA are always going to enter the dura at a particular place only. The optic canal can always be drilled out, and this is where once these two landmarks are identified, your identification of these vascular structures become very easy. So here I have peeled off the dura of the cavernous sinus, and then we do a dural opening. I do a T-shaped opening nowadays. So then you see this, you start seeing the tumor. So I'll just quickly run through this. So this is the dural opening, then the Sylvian split. You identify the MCA. You can see the tumor is already here, and all you can see is the MCA branches, MCA trunks. So now we are trying to demarcate the tumor margins, both medial and lateral to the MCA. The MCA acts as a landmark which splits the tumor into two. So you work on either side of it. So here we are demarcating the tumor margins. And again, another important step is to make out the difference between a tumor feeder as well as an en passant branch of the MCA or the ICA, which goes through the tumor but does not feed it. So I'll be showing that to you later, but this is what we are doing. We are demarcating the tumor margin. As you see, the brain is invaded. This is a type 2 meningioma. So you can see so once you start dissecting, you see these are the MCA M2 branches. So now you are coming back, and now you are devascularizing the tumor and taking out the attachment from the dura. So you work back and forth. This is the devascularization of the tumor. And this is what I was telling you. So now the optic nerve always enters through the optic canal into the brain, and that's a fixed landmark. You can see over here. You can see this is the optic nerve. It's always going to be there. This position will not change. So if you have an extradural exposure, then cut, you can see the optic nerve over there, and then you cut the falciform ligament and skeletonize the optic nerve slightly outside. And so if this is the optic nerve, the ICA is always going to be over here. So this anatomy does not vary, and this is a fixed point of both the ICA as well as the optic nerve. So now once we have dissected the optic nerve, the second step is to identify the internal carotid artery. So the internal carotid artery, like I said, once you start dissecting along it, you see the internal carotid artery. So this is the attachment between the ICA and the optic nerve. You can see the ICA which has come into view, and you can see the attachment. So this is going to be your ICA, and this is where your optic nerve is going to be. So that part we are going to coagulate and cut, which I am doing over here. And you see, if you can make out the anatomy over here, this is where the optic nerve is here, and this is the ICA, and this is the tumor, and this is the part which is going between in the opticocarotid system into the posterior segment, where you will see the pituitary stalk. So I'll come back to that later. So once that is done, you have to see the tumor is a ball which is divided into three segments. One is the lateral segment and one is the medial segment. The medial segment is further divided into two, one which is anterior to the ACA and the one which is posterior to the ACA. So these are the attachments to the sphenoid ridge which is being taken out. And this is the MCA and its branches. So now you have the ICA on one side proximally, and you have the MCA distally, and now you have to connect. So now if you can see some of these vessels, see, this is a vessel which is an en passant vessel. This vessel is not supplying the tumor, or it might have some small branches which is going to the tumor, but its main supply is to outside the tumor. So you follow the en passant vessel back to the ICA. So we are following the en passant vessel here, and you can see we are coming close to the ICA. Yeah, and there you see that's where it meets the internal carotid artery. Yes, so you can see the vessels arising from the ICA over here, and once you dissect this tumor off this one, you start seeing the choroidals, and behind the choroidals you see the posterior communicating artery. So this is the ICA, the anterior choroidal artery, and the PCOM, and these are the final attachment to the tip of the clinoid process, which has already been removed, the dura of the clinoid process. So this is the part of the tumor which is lateral. You can start seeing the posterior clinoid process over here, and if you dissect further, this is where you will see the P2 segment as well as the third cranial nerve. So this part of the tumor, now this part is peeled off. You can see the ICA, the choroidals, and the PCOM which is going over there. So now this part of the left side of the tumor which is lateral to the ICA has been removed. So I'll just skip that out, and this is taken out. So now I then transfer my attention to, basically now we have the tumor which has to be dissected from the ACA, but the ACA splits the medial part of the tumor into two. So you can see this is the ICA over here, this is the MCA, and this is where the A1 is starting off. So some of the tumor decompression to make your dissection easy. Yeah, and then we start off the ACA skeletonization. So you work along the ACA with a combination of sharp and blunt dissection. So again you have to be careful about both the recurrent artery of Hübner as well as the ACA perforators which go into the ACA perforators. Now you see the complete ACA has almost been skeletonized, and these are the final bits of the tumor. So now the tumor which is posterior to the ACA, that is between the ACA and the MCA, is being removed. That's the recurrent artery of Hübner and some more tumor vessels, and this is the part which is now being removed. So once that is done, I just turn my attention back to hemostasis. Just reconfirm the anatomy, the ICA, the anterior choroidal, the PCOM going into the P1, and this is the third cranial nerve over here. So this is the final bit of the tumor which lies between the optic nerve and the ICA. You will start seeing the superior hypophyseal branches here which can be coagulated and cut. See, this is the superior hypophyseal branch which comes here, this one, you see the superior hypophyseal branches. So those are coagulated and cut. This is the final dissection from the pituitary stalk and the ACAs and the optic nerve. So finally you can see the ACA laid bare. This is your pituitary stalk. I think I missed that. Just quickly run. You can see the pituitary stalk here, and this is the final just doing the hemostasis, and this is how the tumor after the tumor the whole ICA has been skeletonized, the pituitary stalk over here, and this is the optic nerve. So this is the post-operative imaging showing gross total excision of a type 4 clinodal meningiomas. Of course, again the determinant here is the consistency. If you have a reasonably accusa suckable tumor, the tumor can be excised in toto. These are some of the type 4 clinodal meningiomas. Sometimes you get a differential consistency. You can see this tumor in the cavernous sinus is of a different intensity on T2 compared to the one outside. So here we planned a subtotal excision For want of time, I think have time. I just quickly run through that. The same procedure: Sidman Fisher opening, tumor dissection, MCI identification, devascularization, decompression, and leave the tumor which is in the cavernous sinus. Here again, the ICA bifurcation has been identified, and decompression lateral. So the steps are the same. So the important here thing is one of the most important vessel here is actually the anterior choroidal. Any damage to the anterior choroidal causes hemiplegia, and you have to be very careful about it because many of these patients don't recover their power at all. So I just left the cavernous sinus part, which was given gamma knife, and this is the patient 3 years post gamma knife. You can see a residual tumor, but the patient is stable. There are some meningioma mimics. This we thought of a meningioma, gross totally excised, but turned out to be an IG4 disease. And some of the worst cases have been a sphenopetroclival meningioma, which go in both in the sphenoid petroclival region. This tumor, these are really formidable tumors. These I staged and did this. The first stage, removed the posterior fossa component to a posterior petrosal approach, then came back and did the FTOZ, transcavernous, and the removal of the remaining part, left the tumor near the cavernous sinus, and then gave him SRS, sorry, and this is the patient 2 years post SRT where the tumor is stable. So to conclude, in a clinoidal tumor, the ICA-ACA complex encasement is the most important predictor of extent of excision. Cavernous sinus involvement is important, but again depends on the consistency of the tumor. Sometimes we have opened it and taken out the tumor, sometimes we have left it, depending upon the consistency. Optic foramen I always open, cut the falciform ligament, because it does two things. One, it removes the tumor from the optic canal, and second thing, it gives you some space to move the optic nerve. Otherwise there will be too much traction on the optic nerve. So the nuances remain the same: devascularize, decompress, and dissect. So I think I'll end here. Thank you.
Thank you so much, sir, for enlightening us on an extremely challenging set of meningiomas. Any questions from the audience? If not, I'd like to invite Dr. Narsingh Rao.
Just one question, Dwarka. Just always, this is a challenging surgery, clinoidal meningiomas, we all know. Only thing is that how you are seeing these meningiomas when you preserve your main vessels, is it sufficient, or you need to preserve every perforator? That's what is described. So it is better to leave a lot of bits of the tumor around the ICA.
No, that's a fair point. I mean, again, the tumor itself decides how much tumor you are leaving behind. I mean, if the tumor is really hard and fibrous, it's very difficult. Actually, more than the ICA, I'm usually worried about the choroidal injuries. So that is where I am a little hesitant to dissect around the choroidals, because not only are they very important to the patient, they're very flimsy and get easily ruptured.
Absolutely.
So ICA, we can, I mean, even if there is a small rent, we can still repair it and all that. But choroidal is actually the more difficult vessel.
Now, I just want to know that you have preserved ICA, MCA, and ACA, but still the patient doesn't do well. Has it happened any time with you? Because
if the choroidal is gone, it has happened. I mean, you see a small infarct posteriorly in the internal capsule, and the patient remains hemiplegic. And some of these patients who developed post-ICHA injuries, that they do not recover their power very well.
Thank you.
Dwarka, you showed some beautiful cases and some fascinating surgery, and I'm very happy to see that. The anterior clinoidal meningiomas are one of the most formidable neurosurgical problems. Most important and most critical issue is you operate, you dissect, and beautifully it is going on. You're saying one choroidal. I will say even a single perforator you damage, normal vessel, you are then scared through the rest of the operation because you have created a disaster. And more often than not, you have created a big disaster. So from a beautiful surgery, which is very result-oriented, when you go and see in the evening a fantastic patient, and one perforator you take, you have almost damaged him permanently. So the entire surgery of anterior clinoid process meningioma is based on preserving of vessels. That is the major issue in anterior clinoid meningioma. And what I have realized is, as Dr. Narsingha also said, that when we are dissecting, go on dissecting, the tumor consistencies that matters, and that gives you the pathway to dissect. Whenever you have any significant issue in dissecting the perforator, a single perforator, it is better to shy away from that perforator rather than struggle, and by even a smallish mistake you create an error and have a bleeding, you are done with. You are done with. So you just don't do that. Dissect. If the tumor allows, dissect, but any issue with any perforator in that region, one has to be run away from that situation.
Absolutely.
Thank you, sir. I'd like to...
Sorry, any bypass is considered when the ICA or MCA is very much engulfed, or even the wall is invaded by the tumor?
No, sir. We did only one. I have done only one patient. It didn't end up well.
Okay.
The bypass worked, but the patient was, again, we tried dissecting the choroidal, the patient became hemiplegic and all that. So the thing is, sir, here, because these tumors are benign, and even if you leave a bit of the tumor around the ICA, here, there, as long as you have a margin from the optic apparatus, the results of gamma knife post surgery are very good. I mean, the long-term recurrence-free intervals are quite good. So I think discretion is the better part of valor here.
Better to leave a little
not
bit.
try to be too aggressive. The tumor allows you, take it out.
Right.
But the important thing is, intraoperatively, you should make sure that it is dissected away from the optic nerve. So some people, what we do is we keep a little fat. So the fat, post-operative imaging, if you're going to do radiosurgery, so that fat helps you delineate where the optic apparatus is. So it gives you a margin from the tumor. So
excellent idea. Very good.
I'd like to ask Dr. Narsingh Rao to present a memento to Dr. Dwarkanath. Speaker is Dr. Vishwanath, who is going to tell us on how to do these surgeries, making sure that we don't cause further morbidity to our patients. He's going to talk to us about intraoperative neuromonitoring. Dr. Vishwanath.
Good afternoon, everyone. So mainly any endoscopy surgery, whenever you do, there are two things are at risk. One is vascular injury can happen, and one is a mechanical injury. Vascular injury can be of the anterior circulation or a posterior circulation, and mechanical injury mainly to the brainstem and the cranial nerves. For vascular injury, for anterior circulation vascular injuries, we monitor the cerebral cortex, and for the vascular injury of the posterior circulation, we monitor the brainstem. For mechanical injury, we monitor the cranial nerves in these cases. So coming to the monitoring modalities, what we use. So for cerebral cortex, we usually use EEG, SSCP, and MEP monitoring. For brainstem, we use the 8th cranial nerve monitoring. For cranial nerves, we usually all the cranial nerves can be monitored. So we use EMG, corticobulbar MEP, and reflex monitoring in these cases. So coming to the cerebral cortex monitoring. So here we can see we usually keep the electrodes, corkscrew electrodes of our area of interest. Suppose the surgeon is operating, the ACA is at end danger, then we will put the cables at the midline. If the MC is at risk, so we will put the bit lateral to the MC territory. So we usually we monitor the EEG. During EEG, during intraoperatively, EEG have typical pattern because all our anesthetic agent produces signature kind of waveform. So in this, you can see the numerical values. We monitor alpha activity, beta activity, gamma, and delta activity. What we usually look for is a EEG suppression and slowing of EEG activity. We always compare the normal with the opposite side, with the affected side with the normal side, opposite side. So any deviation, any abnormal activity in the affected side, then we'll immediately inform the surgeons. The problem with the cortical EEG, the problem with the EEG is it is only measures the cortical blood flow, so it will not give the subcortical blood flow. So for subcortical activity, we usually monitor the SSCP. For SSCP, we stimulate the median nerve in the upper limb and posterior tibial nerve in the lower limb. So we record the signals from the primary sensory cortex. So this is how our waveform will look like. We usually monitor for this amplitude and latency in these cases. Any decrease in amplitude and increase in latency, it will give the information about the blood supply. So here they have studied the retrospectively analyzed the 13 cases where they have where they had intraoperative carotid artery injury. So the role of intraoperative neuromonitoring in the carotid injury. They concluded that SSCP and EEG monitoring can accurately detect the cerebral hypoperfusion and provide real-time feedback during the surgery. SSCP EEG changes predicted for neurological outcomes and guide surgical decision regarding the preservation or sacrifice of the ICA. In the same article, they gave the flow pattern of management of carotid artery injury with the help of IONM. So whenever you suspect there is a significant change in SSCP and EEG activity, so then you will look for the evaluate for the vascular injury. So vascular injury, ICA injury can be there. There can be a perforatory avulsion. So you go for bipolar coagulation or clip to salvage the vessel. Then you see for any EEG changes or SSCP changes. If there is a SSCP and EEG signals are coming back, then you can consider the proceeding the surgery. If there is a significant drop in the SSCP and EEG signals, then you can go for the immediate angiogram. If the ICA injury is significant, there is a large injury of more than 3 mm, then just pack it, or you can use the clip and you directly go for the immediate angiogram. If the direct injury is very small, like it is 2 to 3 mm, then what you do is attempt for salvage the vessel, and you will see for the EEG and SSCP changes. If your SSCP and EEG are coming back, then you can consider that the vessel has not damaged much, so you can think of continuing the tumor resection. If still there is a decrease in the SSCP and MEP, SSCP and EEG signals, then you can immediately go for the angiogram. In angiogram, you can have three kind of results. One is a vessel can be intact. If your vessel is intact and your SSCP and EEG signals are coming back, then you don't have to worry that repeat the angiogram after 1 week. So if your vessel is intact, still if you are not getting your EEG and SSCP signals back, so what you can do is you can go for CT, or MR perfusion scans to look for any occlusion. So if there is active exertion or pseudo-aneurysm, then you go do, there is a persistent significant drop in significant changes, then you can think of putting a stent or flow diverter in these cases. If there is a improvement is there in the SSCP and EEG after the angiogram, so then you can look for putting a ICA coil. So once you put the ICA coil, you can look for CT or MR perfusion. If there is a perfusion is there, then adequate perfusion is there, then you follow up the patients. If there is not, perfusion is not good, then you can go for ICA, ECA bypass surgery with the help of IONM. So coming to the brainstem monitoring, for brainstem monitoring, we usually do the 8th cranial monitoring. You can see whenever the 8th cranial monitoring, we get the 7 different kinds of waveforms. The first 2 waveform will be coming from the 8th nerve and the 8th nerve nuclei, and the 3rd to 5th or 6th waveform will be coming from primarily from the brainstem. This is what we are worried about. So we monitor during the surgery these waveforms. And one more thing, what you have to notice here is once the fibers of the 8th nerve, it is almost 80% are crossing to the contralateral side, and only 10% are going the ipsilateral side. So whenever you are monitoring the brainstem, so even if the patient has a deficit on the hearing deficit on one side, still you can go for the monitoring of the 8th nerve of the opposite side. It will tell the integrity of the brainstem. So usually we stimulate with the 80 to 100 decibels of single pulse click type of stimulation for 100 microseconds with the help of contralateral masking. So we give different special kind of earphones will be coming. So we'll stimulate with that, and we record the signals from the either in front of the ear or back of the ear. The reference electrode at the vertex of the head. So we create 2 channels here. So we will be getting this beautiful waveforms like this. This is 1, 2, 3, and 4, 5 waveforms will be coming. So we are mainly worried about the 5th waveform. So that is coming from the brainstem. So what we monitor during surgery, usually we look for the latencies in these waveforms, and inter-peak latency of 1.3 and 1.5. Alarm criteria, there is increase in 1 millimeter increase in the latency or 50% decrease in the amplitude, then we will immediately aim for the surgeon. That is, and one more problem with this in this is, if there is a vascular injury, we can see that all the waveform will disappear suddenly. If there is only compression on the brainstem, or if there is cerebellar retraction, the only wave, fifth wave will be affected, then you will immediately give a feedback to the surgeon. This is how we monitor the brainstem. Coming to the cranial nerve monitoring, so during endoscopic approach, so we usually monitor EEG and SSCP in all the endoscopic surgeries except Transpetrosal. So other than that, to selecting the cranial nerves mainly depends on the where is the pathology and what is the approach to the surgery. If the surgeon is trying to approach with the orbital apex root, then we add third, fourth and sixth cranial nerve. And if is trying to Clival or transpectoral route, then we will usually monitor 6th and 7th nerve monitoring. So if the surgeon is trying to operate with the transpterygoid route, then we usually monitor the 5th nerve. And in the cavernous route, again, as we are discussing, we will monitor 3rd, 4th and 6th cranial nerve. If the surgeon is trying to transcondylar or transjugular approach, then lower cranial nerves will be monitored during the surgery. So usually where we place for the needles for the 3rd, 4th and 6th cranial nerves, we usually prefer medial rectus for the third nerve and superior oblique and lateral rectus for the 4th and 6th nerve. So placing the electrodes become very challenging in these cases. We usually in the initial period we used to take help from the ophthalmologist, or the help of ultrasound guided can also be placed. What we usually do is we will push the eyeballs to the opposite side and we put the needles and we hit the orbital wall, and along the orbital wall we'll push the needle inside. So mainly in the 3rd, 4th and 6th cranial nerve, we mainly rely on the EMG activity of the muscles. So we don't have other options. So usually when the surgeon is operating, so this is how a raw EMG will be looking like. So raw EMG, this is how raw EMG comes. Whenever there is a firing, so when a surgeon irritates the third nerve or 4th nerve, they will get the firing and will immediately give the feedback to the surgeon. The problem with the raw EMG is, it will, even if the surgeon damages the 3rd nerve or 4th or 6th nerve, still the raw EMG will be coming. So what we have to do is, to know the integrity of the 3rd, 4th or 5th, 6th nerve, we have to ask the surgeons to stimulate with the triggered EMG and the medial part of the tumor and lateral part, proximal and distal end of the tumor. So if they are getting firing from both the ends, then the nerve is intact. So usually when we are doing raw EMG, we will usually get this benign kind of firings, burst or blur kind of short duration. So that can be because of the mechanical irritation or nerve retraction or cautery or thermal irrigation. If that irritation becomes continuous, so then that can be direct nerve compression or traction or ischemia. Then you will immediately give the feedback to the surgeon regarding the firing. So coming to the usually the problem with 3, 4 and 6 cranial monitoring, that is too invasive. You have to place there is high chance of we might rupture the globe. So what the other technique is, we use the oculography. So what they did here is, they placed 4 needle electrodes, one on either side of medial and lateral side of the eyeball and above and below the level of the eyeball. So what they did is, they created 2 planes, one is the horizontal plane and the vertical plane. So whenever third nerve is get irritated, the eyeball will try to move towards the medial side. So then we will get the negative deflection. If there is in horizontal plane, if you get the negative deflection, that is because of the third nerve irritation. So in the horizontal plane, again, if you get the positive deflection, that is mainly because of the 6th nerve irritation. So because of the eyeball is moving towards the opposite side. In the same time, if you get a positive deflection, it is because of the 3rd cranial nerve, that is the inferior rectus muscle. If they get the negative deflection, that is because of superior oblique muscle. So this is how we can also monitor the 3rd, 4th and 6th cranial nerves. So coming to the 5th cranial nerve has both motor and sensory path. For motor pathway monitoring, we put the cables in the masseter muscle and temporalis muscle, and we usually monitor in these cases of the surgeries. So for sensory monitoring, we usually stimulate the V1, V2 or V3 branch. Here you can see we have put the sticker electrodes for the V2 branch to stimulate, and recording from the contralateral cerebral hemisphere at the C5 and C6 face area of the brain. So this is how our waveform will look like. So this is the latency and this is the amplitude. We continuously monitor the SSCP of the 5th nerve during the skull-based surgeries. So coming to the facial nerve monitoring, usually facial nerve monitoring, the CP angle lesions, skull-based surgeries, brainstem tumors, and even MVD surgeries, we do the facial nerve monitoring. So in facial monitoring, the motor pathway, again, we depend on EMG activity of the nerve, and you can do corticobulbar MEP also for 7th nerve monitoring, and even blink reflex as well. So in this case, you can see the many times CP angle lesion, the tumor is engulfed by the tumor, the seventh nerve is engulfed by the tumor. So identification of the seventh nerve itself becomes a big task in the seventh nerve CP angle lesion. Once you identify and trace it out, the rest of the tumor resection becomes very easy. So here you can see the surgeon is operating and he is trying to stimulate here. So we are getting the firing from the orbiculus, oculi, oris and the ventalis. The biggest challenge is differentiate between the fifth nerve and the seventh nerve. So we have to look for the latency and amplitude. See here even they are getting a masseter reflex, but it is amplitude is very less and latency is more. So one more important thing is a blink reflex. So usually we stimulate with the fifth nerve, branch of the fifth nerve, and get the recording from the seventh nerve. So here when you can see that we have put the supra orbital nerve, we are stimulating the supraorbital nerve. So once you stimulate the supraorbital nerve, that will go, signal will go to the brainstem. From brainstem, again it will stimulate the seventh nerve. So from the seventh nerve, the signals come back and you will see the contraction of the orbiculus oculi muscle. So usually we can do all, wherever your fifth nerve and seventh nerve are in danger, you can do this monitoring. It's the best part of this monitoring, it is a continuous monitoring. It tells about the sensory pathway of the fifth nerve and motor pathway of the seventh nerve, along with the brainstem, integrity of the brainstem as well. So it's a continuous monitoring, very easy to monitor. So this is our waveform will look like. This is a continuous monitoring, a blink reflex of one's right side and left side. So we continuously monitor this amplitude and the latency in these cases. So coming to the lower cranial monitoring, usually we do all the surgeries with the medulla at risk or foramen magnum surgery, jugular foramen pathology, skull base surgeries. The monitoring modality, again we depend on EMG, and corticobulbar MEP and SSCP of the 9th nerve can also be done, and reflex monitoring of the laryngeal adductor reflex of the 10th nerve. So needle placement for 9th cranial nerve, we usually place the needles in the soft palate. For 12th cranial nerve, we place the needles in the tongue. For the 10th cranial nerve, usually above the level of vocal cords, usually that is too invasive. That's we have a separate different special kind of ET tubes where you have a strip electrodes over it, so that we can monitor the vocal cord movement during the surgery with the help of these ET tubes. So I was telling corticobulbar MEP. So as we have motor MEP, we have for bulbar muscles, for cranial nerves also we can do the monitoring of the MEP pathway. Monitoring can be done. So how we do usually, we stimulate the motor area, that is of the area of the face area, and we get the recording from the cranial nerve muscles, cranial nerve muscles supplied by the cranial nerves. The problem what happens is, once you stimulate here, the area is so small here, so the current may directly spread to the nerve, bypassing the your brain and the brainstem. So we can give the false negative response here. So what we do usually, double train stimulation. First we give the stimulation of 4 train, followed by a gap of 90 milliseconds. Again we'll go single stimulation. If you are not getting a response in a single stimulation, means the current is not traversing directly to the nerve. So we have to get the stimulation with the train of 4. Then in the single stimulation, if you are not getting, that is a correct response. So it is a continuous monitoring. As we said, MEP of somatic muscles if you are monitoring. So it is intermittent monitoring, where here we can do the continuous monitoring of the corticobulbar MEP muscles. So this is the integrity of the complete pathway, and you can use in the skull base surgeries. So coming to this laryngeal adductor reflex, what we do here, as I said, we put a special kind of ET tubes which has 2 cables, 2 pairs of cables. So one is on the right side, on the other left side. So right cables we stimulate, we connect it for the stimulation, and left cables will connect for the recording. So what we do, once we stimulate the right side here, so the sensory pathway of the 10th nerve we are stimulating, the sensory pathway will go to the brainstem. Again the motor, with the help of motor pathway, with the recurrent laryngeal, the vocal cord will contract. So this is how your signals will look like. Again we change the cables on the other side. So then we stimulate this nerve, cables. The sensory pathway will stimulate it, and sensory intactness of the sensory of the right side. Then again the motor pathway of the recurrent laryngeal of the opposite side can be monitored in these cases. So to conclude, INM in the transnasal endoscopic surgery lowers the majority of complication rates and enhances the safety of and efficacy of the treatment. And technical complexity, again it needs a skilled neurophysiologist to accurately interpret and mitigate the false positive and false negative. And the collaboration is always important for the optimal results, because always surgeon should tell what cranial nerves he is interested to monitor, because suddenly many times I have seen surgeon enter the OT and everything is done, draping is going out, the surgery, all incision is there putting, they'll suddenly come, third, fourth, sixth naga to acha rehta tha. So that will become very difficult. So if proper collaboration and it will help for the better outcome. Thank you.
Do you have any questions from the audience? Dr. Rupesh?
Vishwanath, it was a nice talk.
Thank you, sir.
The two things. One is when you are using the BAEP under microscope, not endoscope, how often you find noise? So many of the time our physiologist says when we get the microscope, there is not of noise. So how do you avoid that?
So usually, if your microscope is connected to the continuous electrical supply, sir, then we will get a noise. So intermittently, whenever we want to monitor, we'll disconnect. And sometimes even if without disconnection also, we'll ask the surgeon to move away the microscope for a bit to get a recording, then again we'll proceed.
Yeah, that is a major flaw in that. Second thing is, have you tried VEP monitoring?
VEP have tried, sir. We have got the VEP monitoring. VEP also we can get. VEP is...
how often you are successful? Still we are validating the data. We are not very consistently
we have many times, almost 10 cases we have done VEP cases, sir. 2-3 cases we don't get proper recording, but more or less we are getting, sir, because the main this thing is how you place your goggles. So we put the goggles and we strap it so that it will not move. So that will be beneficial, sir. Along with that, we put the corkscrew electrode in the occipital area.
Yeah, it will help us in how much we can pack the cella. So that step it is very useful, VEP.
Correct,
we have found 2-3 cases useful, but sometimes we are not getting the VEP signals properly. So something I think
we have got, sir.
Yeah, thank you.
It was interesting talk. So you said that the blink reflex is a continuous monitoring.
Yes, sir.
Do you give TIVA or muscle relaxant you give, or?
We don't give muscle relaxant during IONM, sir.
Does the
we
patient
only
keep
TIVA.
on blinking? How do you do that?
Yes, sir, because it's very mild current, sir. It will like a patient will blinking. It is not under awake, it's under anesthesia. So
Muscle relaxation.
Will not give muscle relaxant, sir.
TIVA.
TIVA, sir.
And you continuously keep on
continuously very low current, 5 to 10 milliampere current.
Response. So it will check 5th, 7th and brainstem.
Brainstem. So
that
it will
is,
help for CP
how
angle.
To use
regularly all CP angles we are using, sir.
That is a new thing which I learned. Yeah. It is interesting.
Can I ask
thing,
Dr.
Sir.
Bhavani to come up?
Even I did not realize, sir. It was a new thing for us also. It's a learning process from him.
I request Dr. Bhavani to present the memento to Dr. Vishwanath.
Thank you, sir. Thank you.
Our next speaker is Dr. Shyam Sundar, Lead Consultant, Department of Neurosurgery and Spine Surgery, Hyderabad City, Cochin. He'll be speaking on endonasal approach to an ACF-based lesion, the esthesia neuroblastoma.
First up, thanks Dr. Narsin Rao for great conference here, CME here. I have been asked to give a single case presentation on how I do a case of ACH neuroblastoma. So I'll be presenting on a single case. So it's a 55-year-old male patient who presented with a feeling of nasal block and left-sided proptosis, which was rapidly worsening of 2 months duration. Images, you can see it's a large nasal mass. It's buckling the periorbita inwards, causing maxillary sinus invasion, some frontal lobe invasion also. So it's a Carish type C. So because there is significant size for the lesion, we initially went ahead and gave chemotherapy for him. He underwent, nasal biopsy. The NT guys did a nasal biopsy. It turned out to be an olfactory neuroblastoma. And then we started on neoadjuvant chemotherapy with cisplatin, etoposide, 3 cycles was given. And then the repeat imaging, you can see the lesion has shrunk in size significantly. The lesion now currently is there in the middle turbinate region, the part of the left side septum, but the septum seemed to be free at that point. And then part of the frontal lobe, the cribriform plate and the frontal lobe was slightly involved. So the plan was to remove the left side, the septum, the bone, that be the second layer. On the lateral aspect, the orbit, the lamina papracia and the periorbita above the cribriform, including the dura. So that was a plan. So this is how it was done. This is a position I keep slightly more extended for these cases, so that my access to the frontal, the ACF is better. Use navigation routinely for this case, obviously. So we start off with the middle terminate resection on the opposite side, because anyway the ethmoids and all that will go, so there's no point in retaining the middle terminate on that side. And then we go on to create a large Haddad flap, because my coverage for this case is going to be on the anterior cranial fossa and laterally onto the orbit. So the Haddad flap is actually quite large, wide in fact. The flap goes all the way under the inferior turbinate. You can see that I'm taking the cut under the inferior turbinate, so that you get quite a broad flap. The uppercut also goes as near to the olfactory area as possible, without keeping too much of a margin there. So that gives a good, real wide flap. I'll show you why it is important. I'll just skip through this video. So that's how the Haddad flap is taken. I'll just fast forward through this. So once a Haddad flap is done, next step would be to start the resection. In this case, you can see, you can see the lesion is there on the middle turbinate region. The septum is, the lesion is just touching the septum. We have separately sent the septum for biopsy for margin. So we'll start resection of the lesion, take off all tissue, whatever is macroscopically seen from the middle turbinate, and then further laterally the maxillary sinuses will be opened. You can see using debrider, I'm taking off all the tumor from there. I'll move a bit fast. So all the tumor, whatever macroscopically seen, is being taken out. That's a maxillary sinus being opened, widely open, so that the lesion from within also comes out. And once that is done, the next step is to identify the frontal recess. You have to see both the frontal recess, so that when you repair, it doesn't get occluded. So the uncinate, the bulla and all that is removed, and the frontal uncapping is done. The agarnice is opened and the frontal recess is opened. And this is how it is done. You can see the frontal recess coming into view slowly. In the meantime, we have to, that's a sphenoid sinus. That's a sphenoid sinus coming into view. So that's a frontal recess on both sides, sphenoid sinus. We'll get a better picture slightly later. So frontal sinus is exposed on both sides, because the frontal sinus we thought was a bit narrow here. We did a draft to connect both the frontal sinus, expose it widely. The ENT surgeon helps me in this part of the surgery. The sphenoid sinus is open. You can see the optic here. The planum comes above, anterior to that. All the ethmoid tissue, the ethmoidal cells are removed on both sides. You can see the anterior ethmoidal artery coming up there. Both the anterior ethmoidal arteries are then dissected and coagulated early in the surgery, because if it breaks and retracts into the globe, we can actually have retroorbital hematoma happening. So all the ethmoid cells are cleared up. You can see the ethmoidal artery coming into view. That's the right side ethmoidal artery, anterior ethmoidal artery to be precise. And here you can see the left side ethmoidal artery. it will come up somewhere there. I'll just go a bit fast there. Yeah, that's an anterior ethmoidal artery on the left side being coagulated. Sorry, what did jumped? Okay. That's the left side anterior ethmoidal artery being coagulated and cut. The draft is then being performed. Both the frontal sinuses are connected to form a large opening so that the stenosis doesn't happen post-operative period during the healing phase. At this time, we also make sure we see the first olfactory nerve fibril so that your resection is actually anterior to that part. So that's the draft being done. Once the draft is done, you get a wide opening. That's the right side ethmoidal artery being coagulated. That's the right anterior ethmoidal artery. And once that is also done, so that's the next step. You clear up the sphenoid sinus. You can see I'm using a 30-degree scope. That's why I'm looking up. That's the sphenoid sinus being cleared, the anterior face of the sphenoid being resected to expose the plana. That's the optic coming there. So the planum has to be clearly exposed. Your resection has to be on both the lateral lamella, on the planum, and in just behind the crista, in front of the first olfactory. That's the posterior ethmoid being taken down. So both the ethmoids, anterior ethmoids and posterior ethmoids on both sides are coagulated and cut. Once that is done, that's a Then I do the osteotomy. Both these sides, the lateral lamella is drilled. I've already drilled on the left side. This is the right side being drilled, so that to expose the dura around the cribriform plate. So that's the dura being exposed. That's a horizontal osteotomy just in front of the first olfactory fiber, so that you go around the cribriform plate, and then the dura is cut. I'll just move a bit. Oh, sorry. And the dural cuts are made around the exposed area. You can see the dural cuts being made around the cribriform. And then the dissection is continued around the cribriform onto the planum. There's a drilling on the planum happening. You can do the drilling and then do the cutting also. That is either way is fine. That's the planum. You can see the optic there. It's a planum region. So whatever abnormal looking tissue on bone has to be removed. So I take a bit posterior to the what looks abnormal. So there will be a margin there. So the cut is then continued. You can see the olfactory coming into view there. So essentially what you do is you go around the cribriform plate and take it off. Then slowly you can see a small bit of tumor tissue adherent here. It is going under the frontal lobe. That also need to be taken out. I'll be taking it out later. So the olfactory is then cut. I take a small bit of olfactory for biopsy on this side because to make sure there is no tissue there, no neoplasm in that part. Then further drilling is done laterally onto the lateral lamella because the tumor essentially was on the left side. I drill further laterally on the lateral lamella and to remove whatever abnormal looking bone is there till I see normal tissue, and then further drill for a few more millimeters so that just to get some margin on the bone. Once that is done, once the keep on drilling, keep on removing the abnormal looking tissue. That's what is being done here. You can see the tissue being taken off. Now, after that, I go on to the orbit region. You can see the lateral lamella is still being drilled there. All the tissue what looks like abnormal is being taken out. The dural tissue which looks abnormal is being taken out. And once I feel that it is a normal tissue, I send the margin for biopsy also, so that I am not missing any tissue. Now I go to the orbit. As I said, the laminar papyracia was buccal, so I am assuming that it is infiltrated by tumor. So I am taking out the laminar papyracia and the periorbit, 2 layers, so that there will be margin. So that's the next step that I am doing. Just taking off the bone there. All the bone at the lamina has been taken off till I see a normal margin. Further, once the bone removal is done, I open the periorbita. The periorbita is also then removed because just want to have one extra layer of normal tissue before stopping the surgery. So that's the periorbita being removed. Layer by layer dissecting off the fat, and I'm using the cobblator to take it off from the lateral lamellar region. Once that is done, so that's the area of exposure. You can see the optic both sides. That's the planum. There were water remains of the planum there. There is a cavity, so when you place a flap, it will be going like this. So I will put a fat in the sphenoid sinus just to make sure that sorry. Oh God. Okay. Now a piece of this is how I reconstruct. I just use a bit of fat there in the cavity. I've taken multiple biopsy bits from the margins so that just to make sure that I'm not missing any tumor there. And then the flap is then replaced over the area. The entire area, the anterior cranial fossa and the orbit is covered by the flap. That's why I took a large flap there. I use a Duragen. So the repair that I do in these cases is just fat and one Duragen and a Haddad flap. So that's after the Duragen placement. As I said earlier, I keep a small bit of fat in the sphenoid sinus so that the flap remains flat on. Otherwise, the flap will have to go into the sphenoid sinus and climb up. So just keeping that small bit of fat helps the flap to remain flat. So this is how it will look like at the end of surgery. The flap covers the entire area, the anterior skull base and the orbit. So that's how it looks like at the end of it. You can see the entire thing covering the area. And I use nasostent to support the flap and Microsurgical just to hold it in place. I use a lumbar train for these cases. So this is post-op. You can see the amount of bone resection that has happened, the amount of resection of tissue that has happened. This much amount of fat is all that is required. You can see that fat in the sphenoid sinus which is supporting the flap. So the biopsy has come as again olfactory neuroblastoma. All the margins, the olfactory nerve margin, dural margin, mucosa overlying cribriform, all this were found to be free of neoplasm. So this is the post-op video at 1 month. Patient is this was done last week. So this is how it looks like in the endoscope in the OP. You can see how nicely the flap has taken up. That's the anterior cranial fossa, this orbit. The entire area is nicely covered. He's currently undergoing radiotherapy and cisplatin-based chemotherapy. Thank you very much.
Thank you very much, Dr. Shyam, for an absolutely fascinating video. Are there any questions from the audience? If not, can I request Dr. Dwarkanath to come up on stage and give Dr. Shyam a memento?
Thank you.
Sir.
Thank you.
Thank you, sir. Our next speaker is Dr. Rupesh Kumar, the Secretary of the Skull Base Society of India and the Director of Neurosurgery at MGM Healthcare in Chennai. He will be speaking of the endonasal endoscopic approach to a suprasellar lesion, a calcified craniopharyngioma.
Thank you, Dr. Narsingh and the team for giving this opportunity. I'll show you one video of large calcified suprasellar craniopharyngioma. So basically, this is endonasal anatomy for beginners, and we can see that the principles are the same. For an extended approach, you need to have a very wide cellar opening, wide sphenoid sinus opening to delineate the anatomy so that you can. So this is the picture. This is where you are going to work in suprasellar anatomy. So you have the pituitary gland, the stalk, and so you have to work on either side of the pituitary stalk to reach into the suprasellar, at the same time below the chiasm. So this much is the corridor for you to work. How Dr. Gota showed, if you can transpose the pituitary, then you'll have a little bit more wider opening. And so you need to be careful about the perforators to the pituitary stalk, which are also in this way. So all these extended approaches is always binostril technique. I always take the help of my ENT colleague. We work together, and so exposure is crucial. So this is a 17-year-old male who had headache, visual blurring. He had polydipsia and polyuria with weight gain. And so this was the craniopharyngioma. This is a calcification which is quite bright, quite chalky. But the cyst was not seen in the CT scan. There's a large suprasellar cyst which was better appreciated in the MRI. So this is the suprasellar. We can see that the large suprasellar cyst which was going into the ambient cistern and to the interpeduncular cistern, distorting the midbrain posteriorly. And so this is causing the obstructive hydrocephalus reaching till the foramen of Monroe. And we can see that in the plain MRI, the cyst was not very much appreciated. But however, if you do the contrast MRI, you can see that the large cyst wall, which was enhancing probably, so it is not, so the cyst wall was reaching and it was distorting the midbrain posteriorly. The cyst was more towards the left side and the solid component more towards the right. So I just take to this video. So this is a transtuberculum approach. This craniopharyngioma. The challenge here will be how to tackle the calcification. So again, just refreshing the anatomy. So we can see that this is a typical imaging findings. So we have to extend to our drilling to the tuberculum to get into the transtubercular approach. The caveat here is to handle the anterior intercavernous sinus, which always comes in the way. And so there are a lot of ways to deal with the anterior intercavernous sinus. So we make a T incision to handle it and then divide it. So once we have the good exposure of the bone and we need not open the sellar dura. we have to expose it, and the tuberculum sella dura has to be opened because we need to go primary or working horse will be in the tuberculum sella region. So we can see that the thick anterior intercavernous sinus, which is bluish, and that is where there will be torrential bleeding when you start opening. So when we open only one layer, it's like a cavernous sinus. We have to hold the two layers and coagulate otherwise. So what we can make is we have to cut above and below and then coagulate in between. So something like this. So a parallel cut inferior to the and superior to the anterior intercavernous sinus like this. So this is superior, and then again make another linear horizontal incision inferior to the intercavernous sinus, leaving behind the intercavernous sinus, and then finally you coagulate it, hold both the leaflets of the dura, then you can coagulate and cut, so you can avoid bleeding from the anterior intercavernous sinus. Otherwise, if you try to coagulate only one layer, it will open up the rent and it will cause more and more bleeding. So this is something which we have to do to prevent a lot of bleeding. So you expose the cellar dura, but we don't expose it further down. We just need to see the pituitary gland. Our primary opening up of the dura is on the tuberculum sella region. So this is some part of the video. I'll fast forward it. It will look little jiggy, but fine. So once we see that is the pituitary gland, the pituitary stalk which is seen. As you open the arachnoid on either side of the pituitary stalk, and already you started seeing this capsule, the typical glistening yellow color tumor, and try to dissect the plane on either side of the stalk, whichever side you have a better idea. At the same time, you should always try to preserve the perforatas as well as don't try to devise the stalk. So those are the perforatas which comes both towards the pituitary stalk as well as to the optic chiasm. So try and do a wide opening of the arachnoid there, like what you see in a microscope. Basically, essentially it is a microscopic. You extend the microscopic principles on endoscopic also. So here we can see that the space again is not very much wide. Because probably the cyst is compressing, but we're trying to get the solid component. We can see the calcification which is more onto the right side. So we make multiple attempts to try to remove and get the glimpse of the capsule, and we can see that the space. So this is a very patient procedure. We need to be very careful. We should not give any undue traction, undue pulling, so that we do not know how many perforatas are there behind which can avulse. So here we can see that the space is not much opening up despite doing a little bit of decompression. So we have to go on to the left side of the stalk and try and see we can decompress the cyst. So that will give you more space to work around. So that's what we did finally. So we can see multiple attempts trying to open the space was not enough. The space was not enough to go for us. So we opened the dura a little bit more onto the left side, and we could see that there is a lot of space there. So trying to do this step again, trying to get to the inferior part of the capsule and trying to dissect it out, and it was not soft. If it was soft, it would have come out because it's all calcified. So trying to deliver it out through that space. It is slippery and it is going back into the space. So try and seeing multiple maneuvers like this was not helping us much. So we went on to the left side. You can see that the cyst wall is quite bulged. It was bulging, that's why pushing the pituitary stalk, that's why the space was less. So once we opened the cyst, and we can see that the decompression of the cyst helped us to open up the corridors much better, and we can see that the surgical steps became much easier. So we can see that the cyst was collapsing well, and then we can see that the pituitary stalk could be manipulated a little better way than it was. So here it's not important to just open the cyst wall has to be excised, otherwise there will be recurrence, so you have to go for a graftotal excision. So you can see we have the pituitary stalk, we have the optic chiasm, we have the pituitary gland. On either side of the stalk we are trying to work. So now we can try and dissect the capsule of the left side cyst in piecemeal and try and dissect the plane. So we can see that the cyst wall is brittle and coming up. Again, there are some calcifications there also. But what has helped is that this maneuver, you can see that the pituitary stalk slowly started moving more towards the left side as the cyst got decompressed. So again, it's never pulling, it's always dissection. Try to dissect and see what is behind. And you have to have both the sides on either side of the stalk, and try to dissect with a dissector and try to always create a plane and try to dissect. So this, you can use either this dissector or a Capabianca pituitary site curette, which is also helpful. So both the dissectors will help us in trying to dissect the plane, trying to create a plane between the stalk posteriorly, because this is the anterior part of cyst we are not able to see much, so we need to be careful about. So you can see that the cyst wall is slowly getting delivered. Just we have to give some time for the pulsation itself will start pushing the capsule, and we can do that. So now we can see the space was much wider than it was before, and we can have a good amount of space to do our debulking. Now we can see this, it's quite now become simpler. So we're trying to do only thing, the calcification is quite very hard, very chunky calcification. To trying to remove the capsule calcification, but we can see that there is some calcification above, so the pituitary stalk, whenever we do that, it is getting stretched. We were afraid that it should not get damaged and get avulsed. So it's a gently trying to get, not pulling it out, trying to get it into the space so that the space opens up, so that we'll be able to do this, the Kappa Bianca. So trying to push the capsule from the left side towards the right side and trying to create the plane there. So because it was a mobile calcification, we couldn't use CUSA to reduce the things. If it was fixed, we can use CUSA drill to remove, but because the whole thing was moving, we were unable to use the CUSA. So we have to be very patiently doing it gently, the dissector. So again, using this side curette can try to dissect and create the plane anterior to that, so that we really attachments are freed and released, so we'll be able to get it in piecemeal. So all the soft part of the tumor we are trying to get it out piecemeal, so that we create more space, so that we finally will remove the solid calcification chunk. So we can see more and more tumors are started coming out. So even from the left side, we could push the capsule towards the right side of the stalk, and the tumor started coming up in a nice way. So you can see this is again a piecemeal delivery. So you can see that the brain pulsation helps us in getting this capsule also pulled out and pushing into the cavity which is created. So we are working between the pituitary stalk and the gland onto the right side, and we can see, though it was all calcification, but it was a soft tumor, it is coming out. So we left that small hard calcification towards the end. So we'll try to remove all the other soft components, so that we have more space and we can finally deliver the calcification finally. So we are proceeding in a piecemeal direction. So we can see that more and more calcification, more and more cyst wall from the left side also is getting removed, and now what we left with is finally is the calcification. That's a single solid chunk. We couldn't decompress it much. So in trying to multiple attempts to just get inside and go out, so that it tries to open up the orifice between the stalk and the dura, so that we are able to get the calcification out, and finally we could achieve that after multiple times maneuvering. So this is a very painstaking procedure, but we have to be very careful, because not only the stalk, the perforators also should be carefully handled, and the chiasm, the optic nerve just above that. So we need to be careful. So this type of side curette, always sweeping the arachnoid out, helps us in delivering more. So we can see that there's flimsy additions there. Then we are again releasing it and making sure that finally it gets delivered. So you can see that there is nothing much except the calcification, or rest all the tumor had come out. So you can see that. So we are inspecting inside the cavity, making sure that the additions are all released, attachments are all released, so that it is a free floating calcification chunk. So trying to get that out. So that is the only thing now pending. So trying to get it out, gentle twisting maneuvers, and so that we can see that the nice, so trying to rotate it and trying to reverse it, so that again multiple maneuvers, it's not a single time pull, so multiple to and fro movement, trying to engage the space, and finally we could get the solid calcification out. It was a single solid piece. A bone removing CUSA also was tried at that, not included in the video, it didn't come well. So we can see finally we could get the single solid chunk. So that is the final appearance of the cavity. You can see that the whole tumor had come out. So we could inspect with the side wings. So pituitary stalk is well preserved, including the perforators. You can see the perforators are lying along the floor and going away. And we can see that there is not much of residual capsule. The whole tumor was removed. And again, this is a high flow fistula, because it is in direct communication with the third ventricle. So we need to have a very robust, that's an aqueduct which you are seeing, both foramen of Monroe. And we can see that is a tumor bed, and we can see all the perforators beneath. So the multi-layered reconstruction is very important to prevent CSF fistula. So our protocol is to make a fasciolata first, and then the gasket technique. So always we try to get the nasal bone or the cartilage and create a gasket technique, so that it's a watertight packing, and then we use a Haddad frap to cover it, and then buttress it with overall the fat fascia. So this is the final. So you can see once the adequate length, the fasciolata which we keep should be a good length, so that we can do the gasket technique. If it is a very short one, then the gasket technique won't stay. There will be some rent, so that is the bone. You can see that this is a facial welding. So we can try and push and get the gasket technique out, and that will give a very robust reconstruction, and we are not afraid much of high pressure leak, because it is directly, if it is a cistern, it is fine, but if it is directly in the third ventricle, the flow of CSF is actually out of gravity, so we have to be very, very careful if we are opening the third ventricle. You can see this gasket technique tightly plugs the hole, and then we can do, this is the Hadad flap which is reflected, and then nasocircle flap, and then so I'll just take you to the, so that is the final appearance. And so that is the post-op MRI, which was done almost 6 weeks later. We can see there's not much of residue, almost a gross total excision. Still, we should do an annual follow-up MRI to make sure that there is no recurrence, because craniopharyngioma is always, even though complete excision, we should always reassure. If you have time, 5 minutes. So this is again 2 minutes, just a similar case. Again, a large supracellular cyst going up to the interpeduncular cistern and foramen Monroe, and this is an 8-year-old girl. The problem with the nostrils is that sometimes the nostrils are too small in children. We have to be careful. Again, extensive approach, opening the tuberculum sellae. Almost a similar video. You can see that the stalk is in the midline, trying to get on both the sides. Here we can see already the stalk is displaced slightly towards the left side. So we have already a good space between the stalk and our dura. So primarily we worked essentially onto the right side. So we can see that. So this is the solid chunk. This is again little fast forwarded video, so it will look little rough, but you can see we have fine maneuvers using the pituitary stalks trying to deliver. You can see that the pituitary stalk above the hypothalamic wall, which is seeing yellow. So we have all the corridors in our vision, so we can dissect and take. And you can see that the lilicus membrane is floating well and getting the tumor in piecemeal. So at every maneuver, trying to sweep with the side curette, trying to create a plane and then try to deliver the capsule. So these type of repeated cyclic movements should happen so that you're not damage anything. And the CSF pulsation also helps us in a big way, and we can see you can deliver this capsule slowly, bit by bit, slow by slow. So if here, unlike the previous case, it was not much calcified. It was a soft tumor. So you can see you'll be able to dissect it well, and we can remove it in small chunks. So here we can see that is the important thing, trying to sweep with the side curette and trying to create that plane. That is a crucial thing so that we don't create any damage to the hypothalamic structures as well as. This is a melanotic craniopharyngioma. You can see that melanin pigments over the capsule, and we can see, so lot of these tumors, so easy to miss out. So we should use 30-degree scope and make sure that we are not missing it out, because still after every point of time we thought the tumor is out, but there are a lot of tumor still inside. So we had every time, you can see the lot of melanin pigment. It was a melanotic craniopharyngioma. So here the tumor, the blind spot here is the one tumor anterior to the stalk. So that is, so we have to be again reverse sweep with our side dissector and trying to dissect. So keep your suction as a traction and your grasping forceps as a counter traction. So in that way, you'll be able to deliver the tumor without causing any major adverse events. So that is the final appearance. Again, a gasket technique. So same principle, same procedure. This is the melanotic. This is the post-op MRI. You can show you the complete excision. So to conclude, extended endonasal approaches are very useful, especially for retrochiasmatic craniopharyngioma. I was doing all these things in FTOEZ approach, but after doing endoscope, I was much convinced that in endoscope, this is much safer and easier than the extensive FTOEZ approaches. We can see in vision, and we can dissect it out, and we can preserve all these structures. A good colleague, ENT colleague is very important to help you in reconstruction. That is very, very important. Otherwise, a successful surgery can become a disaster post-op. Thank you very much.
Thank you, Dr. Rupesh. Any questions from the audience? Dr. Purohit, sir.
Congratulations, Dr. Rupesh.
Thank you, sir.
After seeing your wonderful hematomas, hypothalamic for the pathological laughter, I'm happy to see today the calcified craniopharyngiomas removal. So that 2-3 things. One is that once a small portion of the craniopharyngioma which you have dissected, you are able to see. After that, your gentle tractions and then removing. Will you like to push some patties or a small cottonoid towards the, from the side of the what you are seeing and going towards the base, instead of blindly, because we do not know what structure we will be pulling it out.
Understood.
That's good. You said that the suction is a traction and then your forceps is a counter traction. So that similar counter traction perhaps can also be by a lint piece or a cottonoid towards the base side.
Yeah.
That is the one part.
Yes, very nice suggestion, sir. The only problem is, unlike a microscope, if you are taking the cottonoid, we are taking it all along the dirty corridor, swiping all the flow, nasal mucosa, and then deploying it inside the ventricle. So that is a little, so that's why even with saline irrigation, we never irrigate from outside. All the saline tips, we use a suction, a tip, and the saline is irrigated only in the cavity. So there is no outside in, it's only the inside out irrigation, the flow also. So we are afraid that taking some foreign body from here all the way, putting it inside, may create a nidus of infection, especially in the ventricle. So that is why we avoid taking anything from outside inside, including saline irrigation.
That's good point. Another thing, do you want to give a message that when a calcified portion is attached to the neurovascular structures or even to the stalk, should we go ahead?
We should leave behind. Here, we could see that it was not attached to the stalk. It was not attached to, we have dissected it all around. Only thing, the space was not enough for it to come out. So that was that. So we gently tried to create that opening by repeated multiple movements. So if it was not coming, we would have stopped. We actually tried to use a bone removing CUSA, but it was so hard, it was not coming out. The space was not enough for that. The attachments were all released. Only thing, we couldn't deliver it because the space availability was less. Probably what I learned from Dr. Gatto's technique, in this case, probably if we could have mobilized the pituitary gland, did the posterior glenoidectomy, we could have widened the corridor, that could have come out. So that could have helped. In otherwise, we should have left that inside if you're not able to deliver that out.
Good, thank you.
I'd like to, I'll just get Vishwanath to give you a memento. Can I get Dr. Vishwanath to present a memento to Dr. Rupesh? Our next talk is by Dr. James Liu, who's the Chief of Cerebrovascular, Skull Base and Pituitary Surgery at the Coopam and Barnabas Medical Center. This will be a presentation on Zoom. So, and Dr. James is online, and we'll get him on just about now.
Thank you very much. Can you hear me and see my slides?
Just a second, Dr. James. We can hear you. We're just setting up the video.
Okay.
Yes, Dr. James, we can see your slides. You can start.
Okay. Well, thank you very much. Thank you for the kind invitation to speak. So I think we can all agree that the retrosigmoid approach is the workhorse for the vast majority of posterior fossa cerebellopontine angle lesions. And it really helps us get to lesions such as this petrotentorial meningioma, or even resecting lesions like this posterior petrous meningioma with IAC extension, and also for lesions like acoustic neuromas. I mean, these are really the workhorse for CP retrosigmoid approach. And even this large compressive epidermoid tumor, the retrosigmoid approach readily gets us here and provides us adequate access to remove these types of lesions. However, we do reach some limits of the retrosigmoid approach, and there are some certain pathologies where I think there are some limits. And for my own practice, the vast majority of my posterior fossa skull-based lesions are largely treated by retrosigmoid, but there's about 5 to 10% where you have to use transpetrosal approaches. And I'd like to take this time to show you certain indications and what are the limits and what are the advantages, and also some technical nuances of using the transpetrosal approaches. So when we're dealing with a variety of petroclival and CP angle lesions, I think it's important that we have more than just one approach in our armamentarium, and knowledge of these other approaches and knowing when and how to use it can be a powerful tool in your armamentarium. Let's take, for example, this epidermoid tumor. This was a tumor that you could see that was wrapped around the brainstem and lodged in front of the cerebellum. This tumor, I decided to choose to do a retrosigmoid, but I extended it to a far lateral because of this lower epidermoid component here. And you can see that it allowed us nice access to the tumor. You can see the cranial nerves, 9 and 10 and 7 here. But there was still a blind spot. I had trouble looking over the ridge of the cerebellum, and this was the residual tumor from the blind spot. And even with an endoscope, I could see it, but I had a difficult time reaching around the cerebellum to resect this part of the tumor. And so you could see at 9 months post-op, that residual tumor started to grow again. You could see it starting to get larger. And so I had to come back with a different approach. And if I used the same approach, I would be met with the same limitations. So as I thought about what approach would get me to this area and which approach can I visualize this area best, it would be an approach to look backwards on the brainstem. And if I can do that, that is best done through a Kawazi's anterior petrosal approach. So here you see a right-sided subtemporal exposure of the petrous apex. This is the borders of the middle fossa rhomboid, bordered by V3, GSPN, arcuate eminence, and the medial petrous ridge. And I added a mini retrolabyrinthian petrosectomy so that I can get not only subtemporal access, but also this presigmoid access looking in this direction. And so this Kawazi's approach gives you this advantage of looking backwards on the brainstem, but it also allows you to open up Meckel's cave and get great short distance to Meckel's cave. Even though we don't need Meckel's cave for this approach, or for this case actually, I'll show you other cases where it is helpful. So here we are going subtemporal. We're looking backwards on the brainstem now. You see how we're now able to see in front of the cerebellum. Here is 7 and 8, and here's that tumor that we could not see in the retrosigmoid, and now we're able to remove it safely. And then we have a spectacular view of the basilar 7 and 8 and cranial nerve 6. And then looking upwards, we see the 4th and the 5th cranial nerves. And then here's the post-op scan. You can see we finally removed that area that was the blind spot, and to now achieve a complete removal. Here's a retrosigmoid approach I used for this petrotentorial meningioma. At first glance, you would say, well, this is just a simple retrosigmoid approach. But as I studied the films more carefully, you could see the highest portion of the tumor is right where the SCA and the 4th nerve will be juxtaposed to the tentorium. And I felt that this was going to be a limitation of the retrosigmoid approach because unlike epidermoid tumors, meningiomas are a different animal. They're more adherent and they're not as suckable as epidermoid. And so we have to be ready for tumor in this area. So I went ahead and did a retrosigmoid approach, but I was prepared to have a plan B because I felt that the 4th nerve was going to be in danger from a purely retrosigmoid perspective. So I was prepared to go subtemporal, as you can see in my incision planning. So I'm just doing the retrosigmoid approach as usual. You can see we're devascularizing the tumor from the petrotentorial junction. And then there's the SCA vessel. Here's the 5th nerve that's coming into view. You can see the tumor is compressing the 5th nerve here. And then we're just debulking the tumor that's at the petrotentorial junction with an aspirator. And then this is the final deepest part of the tumor. You can see I'm having trouble safely visualizing the 4th nerve. So I did a subtemporal transtentorial approach here. You can see there's the 4th nerve coming into view. And there's the tumor that's right at the entrance of the 4th nerve where it's entering the tentorium. So this is the most dangerous part of the surgery. And you can see there's the retrosigmoid view. And that's the retrosigmoid view here. So you can see This resulted in a complete removal of the tumor, and the patient was neurologically intact. And I really wanted to get a curative removal on her for being a young patient. Here's another tumor. This was a smaller tumor, but this was growing, and the patient did not want to have radiation. So I went ahead and removed this, and I initially thought this is an anterior petrosal meningioma. You can see it's anterior to the IAC. I thought maybe a simple retrosigmoid approach would be adequate, but again, this is what I saw intra-op. You can see the tumor is in front of the seventh nerve. The tumor was firm. It was not very soft and suckable, and it was very challenging working with the tumor in front of the seventh nerve. This is the disadvantage, and even though I was able to get the tumor out, this patient was met with a facial palsy and also AICA stroke. So this approach was not so simple, and I feel that if I had done this through an anterior petrosal Kawasi's approach, I think I would have had a better result. So I think it's important that we maintain our transpetrous approaches, and we can divide the clivus into fourths. And then this is the general array of different approaches on how we approach various levels of the clivus. And let's not forget the retrosigmoid as well as the endonasal medial approaches to the clivus. So having all of these approaches in our armamentarium can really make you a versatile surgeon. We have to be like Michelangelo, as he carved out these beautiful statues. These are the unfinished works that you can see in the museum in Florence. But this is a nice quote where every block of stone has a statue inside of it, and it is the task of the sculptor to discover it. I saw the angel in the marble and carved it until I set him free. And so when we work with the temporal bone, we have to be like archaeologists and Michelangelo, where we're uncovering these critical structures and setting the angels free so that we can get the routes of access to various parts of the clivus and the brainstem. And we like to break down the approaches into anterior petrosal and posterior petrosal. You can see the anterior petrosal is primarily a subtemporal route that gets you from middle fossa to posterior fossa. And the posterior petrosal route is mostly a retrolabyrinthine pre-sigmoid transmastoid corridor. So let's start with the anterior petrosal. You know, as we navigate this, we have to have this, what Roten used to say, the X-ray vision, to visualize these structures deep within the bone and to know the landmarks, and so that you can get this beautiful access to the brainstem between the fifth and the seventh nerves, and to also access the lower basilar artery. This is an example where I used a Kawasi's approach. This is a video we published some years ago. You could see this petroclival meningioma is medial to the fifth nerve, which defines a true petroclival meningioma. We did this through an anterior petrosal approach. You could see here we are dividing the middle meningeal artery. And after we divide it sharply, we'll start to peel the dura off of the dura propria from a posterior to anterior fashion to expose the GSPN. And then we'll peel the dura off of the lateral wall of the cavernous sinus. This is interdural peeling between the dura propria and the periosteal layer of the dura. It's often adherent, so we have to use sharp dissection to lyse these adhesions. We then expose the petrous apex and the landmarks of the middle fossa rhomboid. We have an idea where that IAC is going to be by bisecting that angle at the geniculate ganglion. And then we mobilize the fifth nerve anteriorly to get the retrogasserian drilling, to get the true petrous apex that's hidden underneath V3. And then once we finish the petrosectomy, we'll open the dura and expose the subtemporal component of the tumor. This tumor will be readily removed through your traditional debulking and then extracapsular dissection. And then we have to think about accessing the posterior fossa by dividing the tentorium. Here we've identified the fourth nerve. You can see the fourth nerve is situated here. We're going to cut the tentorium, but we have to first ligate the superior petrosal sinus. You can do this with clips, and I'm using a bipolar here. And then we open up the posterior fossa dura. So we have control above and below the tentorium to finish the tentorial cut. And then you have to cut behind the fourth nerve. There's the fifth nerve coming into view. And if you follow the course of the fifth nerve and you go into the porous trigeminus, you can then open up Meckel's cave. Here's the tumor that's inside Meckel's cave right here. Now we're working in Meckel's cave, medial to the fifth nerve. Look how we're accessing the tumor that's medial to the fifth nerve. This is the major advantage of the anterior petrosal approach, is that you can have this working corridor working above and in front of the fifth nerve, whereas in the retrosigmoid approach, this tumor is ventral to the fifth nerve in the retrosigmoid approach and can be more difficult to access with the risk of more nerve manipulation. But you could see there's no touching of the nerve here. There's the basilar artery, and there's the final view. And the way I reconstruct these is I do a multi-layer reconstruction. I put a small Duragen and then a small piece of fat. Make sure you do not overpack the dead space. That temporal lobe will re-expand quickly once the bone is replaced. And then here's a pericranial flap. So you don't want to overpack the temporal fossa. You're going to get mass effect and run into trouble with temporal herniation. So here's the post-op scan, a complete removal, and the patient was neurologically intact. Here's another case. This is a dumbbell trigeminal schwannoma going into Meckel's cave that you see here. And here again, we do a anterior petrosal approach, because this approach, like I said, is going to give you great access to Meckel's cave, where that tumor is, and then also give you the CP angle component. So there's the final drilling of the Kawasi's approach. We're opening up the posterior fossa dura, the subtemporal dura, and then we're going to cut the tentorium to the free edge of the incisura. Make sure you cut it behind the fourth nerve. And then we're going to open up the porous trigeminus to get into Meckel's cave here. And now you'll see we have beautiful access to the tumor. And there's the posterior margin of the tumor. We're peeling it from what looks like the aica vessels. And then we'll go ahead and start debulking the tumor with an ultrasonic aspirator. And then there's the 7th and 8th nerves right here. You can see we're working above 7 and 8 from this perspective. We're able to peel the tumor off of the brainstem. And what we want to do is we want to preserve the 5th nerve and all the fascicles. There's the 5th nerve draped over the top of the tumor. And then here's a branch of the 5th nerve. Here's another branch. So we have to work in between these branches, paying attention to the tumor capsule, and then carefully dissecting the tumor from these 5th nerve fascicles. And the idea is to preserve as many of these fascicles as possible to prevent any facial dysesthesias. Here you can see there's the motor root, and then here's the sensory root. So the 5th nerve is nicely preserved. You can see this is a complete removal, and all he had was just minimal numbness in the V2 region. Here's a chordoma. You can see this is a purely intradural chordoma with 5th nerve invasion. If I had done a retrosigmoid approach, you could see there's a blind spot in the interpeduncular space. But coming in Kawasi's approach, you can now visualize this area in the interpeduncular fossa, and I was able to get near total removal here. This is another Meckel's cave tumor. I thought this was going to be a trigeminal schwannoma, but it actually turned out to be a Meckel's cave meningioma, a typical grade 2 meningioma. But look how I have complete access of this tumor. I have complete access of Meckel's cave. If I did this through a retrosigmoid RISA approach, a suprameatal transtubercle approach, I would be looking at the tumor in a very deep cavity, and I would not have this ability to peel the tumor directly out of Meckel's cave. And look how I can carefully separate this tumor from the nerve fascicles and get a nice complete removal of this tumor. Again, I have this excellent access and view of all these nerve fascicles, and I'm able to peel this tumor out. And there's the fifth nerve right into Meckel's cave. Meckel's cave is here, and a complete removal. So we can combine this with a posterior petrosectomy, and this is the combined Petrosal approach, which gives you this multi-angle of attack. You can have a subtemporal and retrosigmoid working corridors. Again, multiple variable angles of attack and preserving the otic capsule to preserve hearing. This is an example. This is a trigeminal schwannoma. Again, a large cystic one entering Meckel's cave. You can see Meckel's cave component right here. We published this some years ago in the Red Journal that you can access. But here is the approach. We've done the drilling here, and we've done a combined anterior and retrolabyrinthine petrosectomy. We're able to preserve hearing because we're preserving the otic capsule. We cut the tentorium to the free edge of the incisura, and then this is the exposure that we can get. Here's the fifth nerve that you can see, and then the tumor is exposed in the presigmoid region. And schwannomas, these tend to be a little bit soft, and then we can start peeling it from the brainstem. And you can see the seventh nerve will be on the bottom here. Here we are peeling the tumor from the seventh and eighth nerves. And then we can have direct access to the brainstem. We're starting to peel the tumor from the brainstem off of the fifth nerve. And then following the fifth nerve up into Meckel's cave. So here's the subtemporal component. You saw that was the fourth nerve in the SCA, but now we're opening up Meckel's cave. There's the tumor going into Meckel's cave. There's the tumor that's medial to the fifth nerve. And then the most dangerous part is usually the most medial aspect, which is the basilar and the sixth nerve. Those are always the hardest to see. And then there's the final peeling, and there's the basilar artery, abducens nerve. I left a little residual droplet of tumor on the sixth nerve to avoid injury, and a little bit of residual tumor that was left here on the seventh nerve. And then we'll do a dural reconstruction with fascia lata. We seal off the middle ear. We pack the area with fat in the mastoid dead space. Again, don't overpack the temporal fossa. You're going to result in compression. And this was a near total removal, but radiographically gross total, a very satisfactory result. Here's another giant trigeminal schwannoma, dumbbell shape, that I removed recently. This was a combined Petrosal approach, and the access to Meckel's cave was spectacular. I was able to get a complete removal using that approach. Now, just to comment on vascular lesions, these approaches are great for brainstem cavernomas, especially when they present between the fifth and the seventh nerves. This patient had multiple cranial nerve palsies from multiple hemorrhages. He had a failed retrosigmoid approach by another surgeon. They also tried to do this endonasally, Transclival, and they were still left with residual. There's a DVA. It's important to preserve the DVA when you're doing these approaches. And so here we are drilling the combined Petrosal. This is the retrolabyrinthine portion. There's the otic capsule. We'll then open up the dura. And then there's the fifth nerve. There's the cavernoma just below the fifth nerve. And then we just remove the cavernoma in a piecemeal fashion, carefully dissecting it from the brainstem. And then there's another portion of cavernoma that was hidden above and below the fifth nerve. So we're able to do this and work above and below. There's usually a lot of scar tissue here on these recurrent cases. And then we'll use an endoscope to look inside. There's the DVA. We have to preserve the DVA. And there's the fourth nerve. And this was a nice complete removal. He's been recurrence-free now for 5 or 6 years or so. And he recovered all his cranial nerve palsies. This is an AVM. This is a ruptured AVM. Look how it's deep in the cerebellum. And there's the draining vein here going into the Galen complex. The cerebellum is right at the quadrangular lobule. And where this is anatomically is in the deepest part of the cerebellum. And look how it's wrapped into the MCP here. So if we did this through a retrosigmoid approach, it's in the deepest part of the corridor, and you would have to either retract or resect this part of the cerebellum to get to this part of the deep AVM. And however, if we came at this with a combined petrosal approach, you could see I'm able to come in at a different angle. So this is the combined petrosal approach that I chose. And then there's the access to the AVM. Look how close the AVM is. I have beautiful access. I don't have to retract any cerebellum. And you can see I have easy access to the SCA early on to devascularize. You can also open up the horizontal petrosal fissure. This is the AICA feeder that I was able to take out early on. There's the basilar artery and lower cranial nerves. So I have great access through this approach, and we're able to devascularize this AVM. You can see there's the feeders. And then this is the top part of the AVM. This is the brains. The fifth nerve will be in this direction. And then carefully taking out each of the feeders here. And then once the AVM is largely devascularized, we can come around it circumferentially, come around the backside. And then once the AVM is completely devascularized, we will take it out in a piecemeal fashion and so forth. So here's the final view, and then the reconstruction with the fascia lata. And then I'm now using a cosmetic mastoidectomy. You can see we take off the mastoid plate, and then we can reconstruct it nicely, and then put some cement to get a beautiful reconstruction. So here's the post-op angiogram, a good resection of the AVM. This is a large epidermoid tumor. You can see it's involved in, it's wrapped around the brainstem here. So I didn't want to make the same mistake as before of a pure retrosigmoid approach. So we're going to do this through not only a retrosigmoid, but we're going to come at it, this portion for a combined petrosal to have triple avenues to the tumor. You could see here is the combined petrosal approach. And here's the portion going subtemporal. We're able to get this portion of the tumor. And why this approach is advantageous, you'll see in a moment, is that the cerebellum is here. This is the front of the cerebellum. And you can see I can look in on the anterior surface of the cerebellum very easily and peel off these very adherent tumor capsule from the front of the cerebellum. And this is the blind spot that you do not see with a retrosigmoid approach. And now we're going to come in through the retrosigmoid corridor to get the rest of this tumor. So here's the retrosigmoid corridor. You can see you have to carefully dissect these small capsules off the nerves and neurovascular structures. There's the AICA perforators, but you have to leave a little bit of remnant on these critical structures because it's very adherent. And so here's the final view. Here's the 7th and 8th nerves, lower cranial nerve, 6th nerve down here. And a beautiful, spectacular view. And this was a near total removal of the tumor. And then lastly, the challenging pathology that we always treat or consider treating on these approaches is the Petroclival meningioma. These tumors are often treacherous because they encase the basilar, invade the cavernous sinus, and they're cobblestoning. Pay attention to cobblestoning of the tumor. This usually means there's peel advasion of the brainstem surface. So you have to leave a microscopic residue on that interface so you avoid any brainstem strokes. But we can do variations of these petrosectomies by doing a transcrusal approach, by removing the superior and posterior canals to get better access. And if the hearing is completely gone, you can do a translab. And then in rare cases, we rarely do the transcochlear variant. But here's an example where we do the transcrusal approach for this large tumor. I think this tumor was better approached through a combined petrosal as opposed to a retrosigmoid. Look at how much compression there is medially. And so to do this transcrusal approach, you have to drill off the superior and posterior canals, but you have to plug the ampulated arms of the semicircular canals. So here is the drilling of the transcrusal. You'll see that we use copious irrigation to flood the field, and then we'll wax off the ampulated ends of the semicircular canals. And then by doing this, now we can drill off the common crus. And look how much access we have to the petrous apex. By getting rid of that superior semicircular canal, you have a bigger subtemporal window. And then we'll go ahead and incise the dura, cut the tentorium. There's the lower cranial nerves. And then we'll start working on the tumor, which is going to be just superior to the fifth nerve. And then we could peel the tumor off of the fifth nerve here. Here's the fifth nerve being pushed downwards. There's the brainstem being separating the tumor from the brainstem and the fifth nerve. There's the exposure of the basilar artery, and then we'll open up Meckel's cave as we did before, taking out the tumor that's in Meckel's cave. And then the last part of the surgery is usually the most difficult, is the area around the fourth nerve. Here the tumor is very adherent to the fourth nerve. There's the sixth nerve anteriorly as well. And then here's the last component of the tumor. Here we're sharply dissecting it off of the brainstem, the critical structures. Lysing, you don't want to pull, you want to use sharp dissection and lyse the tumor from the arachnoid adhesions. And here's the final view, beautiful view of the cranial nerves. I often use the endoscope, like I mentioned, to get a beautiful view of the sixth nerve, Meckel's cave, and so forth. So this was a radical near total. I left a small, tiny adherence to the trigeminal rootlets, but I was able to preserve the hearing in this transcrusal variant. So in conclusion, you can tailor these approaches, and I think it's a useful tool in our armamentarium, and it can provide a significant advantage, especially going in front of the brainstem and in front of the cranial nerves. And it can be a powerful tool when you use it in appropriate cases. Thank you again, and I appreciate this opportunity. I'd be happy to take any questions.
Thank you so much, Dr. James. Do we have any questions from the audience?
Hi, Dr. James. Hello. Are you able to listen to me?
Yes, I can hear you.
Yeah. And when you do these procedures, how much is the time duration? Do you stage the procedure in bone staging or bone work on one day and to reopen the same patient on the next day, or do you do it as a continuous process?
Yeah, thank you for that question. Very important question. So I can tell you, when I first started doing this, I was working with my ENT neurotologist, and I made the rookie error where he was done with the bone work late in the afternoon, maybe like 4 p.m. And I was opening the dura after 4 p.m. and working on these tumors from, 6 p.m. to past midnight. And then I switched to staging it, where we would stage the procedure one day and do the tumor removal the second day. But, as I developed more experience, I developed more comfort in doing the drilling. I became very fast at doing my own drilling. I studied the temporal bone, in the lab myself, and I studied, various surgeons. So now I do my own drilling, and I'm actually faster at it. So I can start removing the tumor at 1 o'clock. So now I do it in a single day because for me it saves time. But I think you have to you have to do it based on your experience. So certainly if you're just starting out and if you're working with an otologist, maybe you want to stage these. And then as you develop more experience, you become faster, more efficient at the drilling or the tumor removal, then maybe you can do single stage. But I think if you're starting out, maybe you want to consider staging it.
Thank you so much, Dr. James. That was a fantastic talk. Can you hear us, Dr. James?
Yeah. Thank you. Thank you very much.
Yeah. Thank you so much, sir. Our last speaker is Dr. Vikas, who's professor and unit head of neurosurgery from NIMHANS. He will be speaking on transcavernous approaches to brainstem tumors.
Hello. Volume up. Respected teachers, friends, last talk, 2 days of hectic material covered, a long way which has been covered, and I end the 2-day meet with a very controversial topic. We have brainstem lesions completely within the brain, and you have transcavernous approach, which is completely outside of the brain, a skull-based procedure. So how do you justify it, and what is the rationale and thoughts about it? So ventral brainstem, so that's a very difficult area. All of us are comfortable. It's one of the earliest lesions to tackle from posterior part of the brainstem. You end up into the fourth ventricle, third ventricle, some places, and you're comfortable with that. But the ventral part of brainstem is something which you don't generally see. But that doesn't mean that there are no lesions in the ventral side of the brainstem. Now, there are a couple of key issues with the ventral side of brainstem. So entry zones to the brainstem which are published are at very different locations, both on the horizontal part of the brainstem and in the vertical extent. Now, often it is understood after reaching the lesion that you need wide access, and the brainstem as it is small, and you have problems with that. And you don't see all the things which you want to see on the MRI. That is in general, but in specific for this. So this is a transcavernous approach, right side. This is the lag. This is the third now, carotid, thalamoperforatus, uncus, and the arachnoid in between. So this is the corridor which you would access, which you would get at the end of a complete transcavernous approach. This is incidentally an anterior transcavernous approach towards the midbrain cavernoma. So as you can see, in spite of this approach, there are a lot of structures over there. The corridor is very narrow, and there are simply too many structures which can cause major deficits. And as yet, we have not even seen the tumor or touched the tumor. So that's a key problem in this issue. So brainstem is a pain to operate. You need access, and access is key. And even with the best of approaches, you are not able to do things. And there are simply so many things which you won't be able to see in the MRI. So this video is actually to justify the findings which I just spoke about in the previous slide. So each one of that's a brainstem perforator, that's a thalamic perforator on top. So that's choroidal somewhere over there, and going a little, so this is reaching finally, The corridor is so narrow. In spite of the best dissection, you can't get away with these vessels. And what looks pretty simple on the imaging, that is you access the interpeduncular region to access the midbrain, becomes complicated because there is this last one perforator which is obstructing your view. And that is something which is not seen. What do? You abandon after doing all these things, or you go? So this is the problem with the lesions as such. So this is with maximum exposure, you have all these issues. So that's the first conviction, that you need to perform what is apparently a very morbid approach, transcavernous, through the cavernous sinus, through no man's land to another no man's land. It's a contradiction in itself. But you can see that at the end of it, you have clear visualization all the way to half of the brainstem, and you're able to actually take out the tumor with a lot of confidence. And it is right almost in the center. How about this? Brainstem glioma, whether to operate, not to operate itself is a controversy. Even if you decide to operate, you have to ensure that the morbidity of your surgical procedure should not exceed the morbidity of the tumor. So what the transcavernous approach actually does is it combines, like Dr. Liu spoke in the previous previous talk, it combines a lot of things. One is it gives you it gives you access in this blue region. So that's a very extensive region, which is, it is not something which you get with any other single approach. As you've seen in the previous presentation, you need to do multiple corridors to get the same amount of approach, which you would actually get with one single exposure. One single bony dural exposure can give you this much of exposure. What the transcavernous approach can be shown by that line. Everything outside of that line is taken out from your view. So that's the benefit. So you take out the entire temporal lobe with the dura outside, so that you have a corridor of that extent reaching all the way to any part of this brainstem, which is otherwise the most difficult part to reach. So brief description of the steps. It's a repetition from the previous presentations, but I think for the sake of repetition and completion, I would like to do that. So it's a terrenal craniotomy. Remember, it's not a massive orbitozygomatic anything, nothing. It's terrenal craniotomy. You can do an orbitozygomatic, but nowadays I find that zygomatic is more than sufficient to do the get the job done. Middle fossa flattening. Yesterday I've emphasized this. I've shown it on the cadaver, the necessity and doing it. Temporalis muscle reflection also is important, because that's how you do it. So steps, set of videos for the steps. Again, I emphasized this yesterday. The identification of the GSPN, that forms the key first part of the procedure, in which you have to identify the GSPN. The GSPN is sort of a pole. It's a landmark pole. It's a flag in the middle fossa. Once you identify the GSPN, most of the other structures can be identified in relation to that, and you're confident of where you're going. That's the middle meningeal artery. As I've shown yesterday, the entire artery is exposed. You don't go there and cut it. You expose, identify, coagulate it, and cut it. What that does is it mobilizes the temporal dura off completely from the middle fossa. So the GSPN and the middle meningeal artery are two tethering attachments of the temporal dura to the middle fossa, and once you separate it out, you have complete access to the Second step in this is the cavernous sinus dissection. So coagulation of the middle meningeal artery, GSPN done. What is followed later is the drilling of the inferior lip of the superior orbital fissure. So that's a key thing, because it gives you anatomical landmarks on which the further drilling and procedures can be done. So that step ensures that you get this clear plane. So meningio-orbital band is something which is almost considered mythical. It's always described very difficult to identify, and you feel lucky if you can identify it and cut it. Once you get that, you are in the plane. The reason why this step is important is because getting the plane ensures that you do not have the morbidity associated with the transcavernous approach. So that's the reason this is emphasized and shown over here. Once you get the V2, incision over V3, sharp dissections over the fourth nerve and V1, dural reflection, which can be done with relative ease over V3 and Meckel's scale. So again, next step is of course the anterior clinoidectomy. Professor Jha yesterday eloquently described how to be done. Lateral root, medial root, optic strut. Optic strut forms the stem. I think I quote you on that, on which the clinoid is based, and then you take it out. So showing the same steps in video. So this is the superior orbital fissure, left side. This is the sphenoid ridge. So you cut between the orbit over here and the temporal dura. So this exposure is feasible only after you have drilled out the bone over here. This is the inferior lip of the superior orbital fissure. So the drilling has been done here to expose this, and once you have done that, you can actually make out the plane. You can actually clearly make out the different planes between these two structures, that is the orbit and the temporal dura. And once you have done that, you can reach up to the medial part of the clinoid. So when you expose between the V1 and the fourth nerve, you would inevitably end up in the cavernous sinus. So the famous cavernous sinus bleed, liters of blood loss, nothing of that sort happens. You inject Tissile, tissue glue of any variety, you are into the cavernous sinus bleed stops, as you can see in the subsequent videos. So it's not a mythical story, it can actually be done. Clinoidectomy becomes very easy, as you can see, once you have done the exposure, because you have separated the temporal dura away from the bone, and you can ensure that you can actually pull it out at the end of the procedure. Next step, dural incision. Dural incision is parallel to the sylvian fissure. It's conceptually very difficult in the initial stages because you've always seen it being done different. The basic idea is to avoid the sphenoparietal sinus. So that's on the temporal side. You have to cut it medial towards the ICA origin and the third nerve. The key step here is that this cut goes up to the tentorium and disconnects the temporal lobe away from the tentorial margin. So that mobilization is from the third nerve and the fourth nerve exit. These are the two key points over there, and you mobilize the dura and the temporal lobe away from that. Now, after you finish all of this stuff, it's still not complete, because posteriorly you have to mobilize this dura over the Meckel's cave. Yesterday in the dissection I have demonstrated that, and once you do that, you have to actually incise the Meckel's cave. So that completes the full mobilization of the temporal dura. So stepwise, this is the sylvian fissure, frontal, temporal incision parallel to the sylvian fissure. So that's the incision parallel to the sylvian fissure. It goes all the way medial to the ICA origin, like this. So that deep structure is the ICA. That's somewhere near the external ring. You turn backwards, cut towards the exit of the third nerve. So this is at the Meckel's cave. Similar procedure at the Meckel's cave, that is cutting of the dura on top of the Meckel's cave. Yesterday I had shown the dura on top of the Meckel's cave. This is the cutting of the dura over the Meckel's cave. What is seen deep is the Gesserian ganglion. So this completes the dural exposure. Key corridors is, this is the Gesserian ganglion, the whole stuff is the nerve. You have to mobilize the dura from over the Meckel's cave. So lateral is petrous, medial is the tentorial axis, and at the center of the field is the fifth nerve. Fifth nerve is the Meckel's cave. Okay, single video. So extensive brainstem glioma, the one which I showed. Patient comes, rapidly deteriorates. This is the kind of lesion, accessible, has still got a boundary outside which indicates that some part of decompression can be done. And dead ventral. So orbitozygomatic over here, superior orbital fissure drilling. So you mobilize that simple piece of bone, you get the superior orbital fissure correctly, the plane between the orbit and the temporal dura. So the dura propria incision yesterday, which I have demonstrated. Cutting sharp dissection over V1, fourth nerve and third nerve. So those three nerves have to be dissected sharp. It's with a blade, it's with sharp dissection that you have to cut. The plane is obvious. It may not be very obvious on the video over here, but it is very obvious when you actually do that, during the surgery. So once that is complete, you can, yeah, so this is the mobilization of the clinoid. So the entire clinoid is within your direct vision. It is not hidden, it is not deep. You start drilling out the various roots of the clinoid, and at the end of the clinoid, incidentally, this clinoidectomy is performed by my resident. So, resident performed clinoidectomy, the entire clinoid is taken out, and that forms it unlocks that key corridor, the anterior key corridor which Dr. Jha spoke about yesterday. That's the tip of the clinoid process. So you can actually pass underneath the clinoid and then take out the bone. Okay, so the next step is you have to do the dural incision. This is completion. So this is the posterior part. That white structures which you see deep are the Gesserian ganglion. So it's a faster dissection. At the completion of your dissection, you would see all these branches. Any kind of further cavernous sinus bleeding can be easily handled with the tissue globe. So GSPN dissection, I have shown yesterday that you can do it at various stages. You can do it at a much later stage, because if you are not very confident that your stimulator is not working properly, this is a late stage GSPN exposure like I explained yesterday. So it is necessary to cut the GSPN towards the base and ensure that the dura is separated from that. So medially you can see the bone, that is the cavus quadrilateral which is getting exposed. So this is the GSPN, V3 posteriorly would be the Meckel's curve. Drilling, because remember that this is in a very awkward place, the tumor is at a very awkward place, so the petrosectomy was done. Dural opening. Dural opening again horizontal, going straight up to the carotid. You actually open up the cistern at this stage. So once you finish the exposure, you are seeing straight up to the third nerve. The third nerve forms the center of your operating field. It is not the carotid, it's not the optic nerve. So you already started seeing backwards. Completion of the tentorial cutting towards the fourth nerve. So first you see the third nerve exit, cut lateral to that. Fourth nerve exit, cut lateral to that. That completes the mobilization. More tissue glue, more bleeding, or rather it's more bleeding needing more tissue glue. Gesserian ganglion and Meckel's curve. That's something which I couldn't demonstrate yesterday. So at the end of the exposure, you would have all of these three things in your viewpoint. ICA bifurcation, posterior dissection, that's the third nerve. Midbrain, SCA, third nerve, basilar, PCOM, ICA. So you know you've got all your corridors. You can use any of these corridors based upon the anatomical challenges which are available. So this is cutting completion, tentorial incision over the Gesserian ganglion. You continue it medially until you connect with the tentorial edge posterior to the exit of the fourth nerve. So at the end of your dissection, you would see all this. You would see the third nerve, fourth nerve, the pons, the petrosal sinus which is excised, Superior petrosal sinus, yesterday I've shown a different video. There's a different video. Coagulation and cutting, completing the medial part of the true petrous apex. Further tent cutting, and then you have completed your exposure. It takes about 2 p.m. to 3 p.m. to finish all this stuff. Like Dr. Liu spoke, it takes initially a lot of time. So that's pons, this is ICA. So you got one microscopic field containing your ICA and pons. Incision on the midbrain, this is after stimulating to find out where the peduncle is. CUSA into the midbrain. First corridor. Can actually see it like a routine glioma. Pontine entry. This is below the trigeminal nerve, same exposure. All done under monitoring, no drop in signals. So to summarize, this single exposure gives you, it's like a bazooka, it's like a big tank. The exposure is a tank. You can do it safely. As you've seen, every single anatomical structure can be exposed, seen, dissected, preserved. So the morbidity, the cost of your exposure can tend to zero. There can still be some temporary problems. But what can be done is you can offer a decent chance of surgery to these patients with ventral brainstem lesions, intrinsic brainstem lesions of various kinds, and do a reasonable job. Of course, morbidity is high, mortality is something which can come, but you can offer surgical treatment to these patients. So deficits, yes, it can happen. But exposure related deficits as of now tend to almost zero. It happens, definitely it happens, but not regularly, not consistently, definitely not permanent. Thank you.
Is there any questions from the audience? Loud enough. If there are no questions, can I have Dr. Rajesh give Dr. Vikas a memento?
It's always a proud moment receiving a memento from a teacher after so many years.
That brings us to the end of the scientific session of the Interim Skull Base Conference 2024. Just before we close, I would like everybody to stand for the national anthem.
Wait.
I request Dr. KVR Shastri to give some remarks at the end before the closure of the event. Just to.
I thank you for the opportunity. I have been in the workshop yesterday morning session and the whole day today, and I found the lectures to be very lucid and educative. And all the speakers have done justice to the job they have been allotted. And I'm sure the same would have reflected in the dissection, the anatomy theater. I think such programs should be quite often done so that the hands-on experience of the dissection and the bone work is well learnt before we try to experiment on the patients. I think I should congratulate Narsingh Rao and his team and all the speakers who have come readily to take part and educate their vast experience to the younger generation. I think they all need a thumbs up.
Thank you, sir. Thank you, sir. We conclude the program and the national anthem to be played. Please stand up.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे